So I'll wait for your signal before we start.
Yes.
All good? Awesome. But thank you all for coming. It's my pleasure to welcome you all. When I entered the parking lot today, I was relieved to see a lot of people over here because until I saw all of you, I was convinced that this is my team pulling an April Fool's joke on me. So happy to see you all. And I want to also welcome the folks who are joining us online. We cannot see you, but we are excited that you're able to join us from your homes. And we have an exciting agenda today. The thing that I'm happiest about is that we are all here together in one room here and the virtual room as well. I remember a lunch that I had with Dr. Andrew Stacey and Dr. Ramesh Rangan, who leads our Proton Center plans for treating ocular melanoma a few years back. And we talked about how can we move things forward in this rare cancer. We were always proud of trying to provide the most outstanding care that we can, but how do we move the field forward? And we discussed a few things. The most important thing was to get people in the same room, talk to each other, because all sorts of creative ideas flow when we talk to each other and we are motivated to make a difference together. So the first step from that lunch was to actually host a physician retreat where all the folks who are treating ocular melanoma get together and we talk to each other. We learn from each other. I had no idea what is Dr. Stacey doing in his clinic. His clinic is at the University of Washington. We are here at Fred Hutch. I would see patients who have seen him in sequence, but I really had no idea. So it was great for me to learn what does Dr. Stacey do? And what does Dr. Rangan, what does Dr. Halasz do in the Proton Center? So it was great to get together. And then during that meeting, we also realized that we need to engage our patient community. Without our patient community's engagement, it will be hard to make definite progress. And fortunately, there are a lot of our patient advocates in this room who have been working tirelessly to do the same thing. Now, most of those efforts have not been in Seattle. So this is, again, a really landmark conference, so to speak. This is our very first ocular melanoma patient symposium. So I want to start by just acknowledging how important this is for our program and what a landmark it has been. And I just want to start by just a round of applause for all of the being here. Before we go any further, I want to acknowledge that this would not have happened if it were not for the tireless efforts of Ritu. She is not here. Is she here in the room? No, she's probably in the back room. But she has been working for many months trying to put this together. She has been reaching out to all the speakers, making sure that the patients hear about it. And the fact that we are here together is all thanks to her. So thank you, Ritu, if you can hear us. So this was, again, my partners in crime here are Dr. Andrew Stacey. Andrew, if you just want to stand up and just wave, please. And Dr. Evan Hall, who's sitting here on the other side. So we'll introduce them a little bit more as the day goes by. But this is our agenda for today. You can see we have a pretty full agenda. We have lots of exciting topics that we will try to cover. Since we don't have too much time for each topic, like each one of those topics we can talk about for the whole day. but we don't have that much time. So we will be focusing more on the highlights of each topic. But we hopefully will have some time for discussion after each talk. As the day goes by, I look forward to learning from all the speakers that we have. So we have our agenda divided into 3 sessions. In the first session, we will have a couple of talks by Dr. Stacey and Dr. Halasz, and then we'll have a break. And then in the second session, as you can see, we have some talks about treatment of metastatic disease from Dr. Hall, Dr. Monsky, and then Dr. Alison Scallett is come all the way from Portland to be with us on her family vacation time. So I especially thank you for that. And then the last, then we'll break for lunch, and the last session I think is the most exciting. We'll have a number of talks on practical stuff. It's not necessarily medical stuff that we do for treatment, but it's all those other practical things. How do we deal with anxiety? How do we deal with the loss of vision? And then most importantly, we'll have a couple of our patients have volunteered to share their stories, and their stories are very powerful. And I am looking forward to that. So with all that, I would go forward. Actually, a couple of housekeeping things. So the event is being recorded for the benefit of our patients who are not able to join us today. This will be available for their viewing later. For the virtual attendees, there is a chat function on the Zoom links. So you can actually type in your questions or comments in the chat. A couple of us will be trying to monitor that during the event, and we'll try to bring up your questions if the time allows. Also, if accidentally you leave the Zoom webinar, you can actually rejoin by just clicking the link that was sent to you in the email. So for the in-person attendees, I would encourage you, as the talks are going, you can, if you have a question, you can write your questions, and towards the end of the talk, we'll have some time for Q&A, and we can discuss your questions at that time. And importantly, we want to hear back from you. This is our first event, but we hope to have many more of those on a regular basis. So our intent will be to keep improving upon those based on your feedback. So without any further, well, we are not going to break right now. So can we have the next slides for? I know that was a lot. You probably do need a break after all that.
This is for.
Okay, perfect. Thank you.
Yeah.
Well, so when a patient gets diagnosed with ocular melanoma, the first person they see is an ophthalmologist. In this room, probably most of you have seen that ophthalmologist to be Dr. Andrew Stacey. So since the journey of ocular melanoma starts with seeing an ophthalmologist, our symposium has to start by a talk from Dr. Stacey. So Dr. Stacey has been here at the University of Washington for 7-8 years, something like that. And we are so blessed to have him. I think he has really led our program in a very vibrant direction. He not only provides outstanding care to our patients, but he's also an enthusiast when it comes to advancing care. He's very heavily involved in collaborating with ophthalmologists and other ocular melanoma providers throughout the country. And his efforts are instrumental to the direction that we want to take our program in. So Dr. Stacey, please, thank you very much.
Thank you. I'm not good at standing behind something, but I realize the microphone is here, so I might be moving back and forth. I'm really excited for today. Thank you, everybody, for coming. We've been kind of blown away with how much interest there's been in this meeting. We have quite a few people here, and we have twice as many logging in virtually. When I arrived here about 6 years ago, we were just in the process of building an eye cancer center. And to think that there's this much need and this much interest in the Pacific Northwest is something that means a lot to all of us. I'm also excited about the day. Each of you has a journey through ocular melanoma, and we're all at different parts of that journey. Along that journey, there are many different people that you may meet and many different things that you may encounter, and each of those things we're going to touch on a little bit today. I'm going to start with just basics of biology, epidemiology, which is population statistics of the disease, how we diagnose it, and some very basic things about treatment. I would encourage you, if you have questions, write them down. My talk is listed for about 45 minutes. I'm going to try very hard not to talk that long. I'll probably be closer to 20 or 30, and then I'd love to just have a Q&A session afterwards with any questions you have about the topics here. Other things that you may be thinking about, we'll probably have topics or discussions about those later. So anything that we talk about here, please write down your questions and I'd be happy to answer them. Okay. So the goals of my talk today are to understand the biology of cancer. What is cancer? To understand what uveal melanoma is and how it starts. To talk a little bit about the population statistics of uveal or ocular melanoma, how we diagnose it and how we treat it. So firstly, what is cancer? Where the heck does that name come from? Cancer is the study or a disease caused by uncontrolled division of cells. In olden times, when there was a tumor growing, a tumor oftentimes recruits its own blood supply, so it brings a lot of blood vessels to it. And so in olden times, when they saw a big mass with a bunch of blood vessels going to it, they thought that those blood vessels looked like crab legs. Cancer in Greek, if you think about our horoscope, right? People born in July are cancers. Cancer is a word for crab, and you can see there in the lower left-hand corner why they might have thought that cancer looked like crab, and it's stuck for thousands of years. So we still call it cancer, named after a crab. Some other words that you have heard or you may hear are words like oncology. Onc is a word also in Greek that refers to a mass. So oncology is the study of masses in the body. You may hear physicians use the word neoplastic or neoplasia, neo being new, plasia being growth. So all of these words refer back to the idea that there is some sort of new growth, an uncontrolled growth in the body. What is cancer? Cancer, I would say, is a disease of mutations. Mutations are when the DNA in our body is changed. The cells have a certain DNA that provides certain structure and regulation in the cells. When that DNA is altered, it can be altered in a way that allows the cell to grow and to grow unchecked. Cancer requires a number of different mutations for it to occur. If you have a cell that has one mutation, it may allow the cell to become abnormal, but stay in the same place. It just looks a little bit weird, but stays in the same place. In order to grow, it would require additional mutations. So there has to be a stepwise progression of mutations. This is important for ocular melanoma for reasons we'll discuss. Once you have additional mutations, you may develop uncontrolled or unregulated growth. Now, that doesn't necessarily mean that you have cancer. I have a mole here on my face that I show most of you, and it even shows through my mask. So you've seen me probably point to this in clinic. This is uncontrolled growth. Now, at some point it stopped and it didn't move any further. And that's because something in this mole allowed it to stop. What cancer is when that uncontrolled growth then invades into the body. It invades into deeper structures or it invades into blood vessels, and then it can become a problem. When it invades into blood vessels or into other vessels in the body, then it can spread. But that ability requires even additional mutations. So you can see a lot of things have to happen for a cell to become abnormal, to grow, to invade, and then to spread. Each of those requires some sort of change within the cell. When it spreads, then that's metastasis. Some of the mechanisms that a tumor uses to spread or to grow are these things. These are funny words. I'll explain some of them. We have genes in our cells that regulate the growth of cells. If you have a mutation that turns a gene on that shouldn't be on, it's called an oncogene. Remember, onc, growth, so a gene that causes growth. Our cells also have a lot of functionality to stop growth. So actually all day long, we're getting mutations in our cells. When we're out in the sun, we're getting mutations in our cells all day long. But our body has a mechanism to halt that, to fix the problem, and to stop the thing from growing. If your mutation, however, causes you to lose the ability of one of these attributes to halt growth, then you have a mutation in a tumor suppressor, and it no longer works, and your tumor can grow because your body can't suppress it anymore. Sometimes the body can repair DNA when it's damaged, but if there's a mutation in that mechanism, then the DNA can't be repaired. Your body should regulate how a cell grows and changes. So for example, if you scrape your skin, your body is going to heal that skin with new cells. And then as soon as the cells are flush and you have a healed wound, it doesn't grow anymore. Well, why do those cells stop growing when they're done growing? Because we have a regulatory cycle within our body that says, okay, you divided enough, you don't need to divide anymore. But if there's a mutation in that regulatory cycle that allows cells to just keep dividing, then we refer to that as cell cycle regulation. Cells can just keep dividing over and over again. One of the most important things in melanoma is that our body's immune system is constantly seeking out tumor cells. So we have certain cells in our body that are looking for tumor cells all day long. And when they see tumor cells, they attack them. This is happening all day, every day in each of our bodies. What a cancer can do is it can hide from those cells in ways that sometimes we know and sometimes we don't know. And that's called immune privilege. They can hide from our body's own immune system. Each of these things becomes important in uveal melanoma. So what is ocular melanoma? So words are important here, and we're going to use words, specific words, at least in this discussion. Online, and when you're talking to patient communities, you may refer to ocular melanoma. We don't use that terminology because it's not very specific. Ocular melanoma refers to melanoma anywhere in and around the eye. So there can be melanoma on the eyelids. There can be melanoma on the skin of the eye, which is the white of the eye. There can be melanoma in the eye socket. All of those could be considered ocular melanoma. But what we're going to talk about today is uveal melanoma, which is melanoma inside of the eye. The uvea, let's see if I have a laser here. Cool. The uvea doesn't show very well. Sorry. What's that show? All right. The uvea is a middle layer of the eye. So the eyeball is hollow, like a basketball. On the inside, there's just fluid. On the outside, there's a hard shell called the sclera. And the inner lining of the sclera is called the retina. The retina is the film of the camera. This is the thing that takes the picture. The middle layer between these tissues is called the uvea. There are three parts of the uvea that we'll talk about, but they are a middle layer all throughout the eye. The three parts of the uvea from front to back are the iris, the ciliary body, and the choroid. Each of these has a specific job, and I'll just mention them briefly. The iris's main job is to determine how much light enters the eye. That's your pupil. When you're out in the sun, your pupil gets small. When you're in the dark, your pupil gets large. It's the iris's job. The ciliary body is invisible. We can't see it unless there's a problem, but it has two very important jobs. The first is the ciliary body controls our ability to focus light in and out. Those of you who, when you've hit 40 and 50, need to get reading glasses, or you're holding things further and further away from you and you're getting upset and you're getting mad, that's your ciliary body saying, I've had enough. I'm not going to help you anymore. The other thing the ciliary body does is it produces the fluid that fills the eye. The choroid, which is the back of the eye, the back part of the middle of the eye, it provides blood supply to the retina, to the visual part of the eye. And it also has pigmentation. And the pigmentation has some important functions. The pigmentation is controlled by a cell called a melanocyte. We know a lot about melanocytes because they're in the skin. This is a picture of what melanocytes look like in the skin. Melanocytes provide pigmentation to various parts of the body to protect the body from ultraviolet radiation. That's its main goal, although it has some ability to do some immune functions in our body as well. The melanocytes are also present in the back of the eye, and they do the same thing. They produce pigmentation in the back of the eye. However, any cell in the body can undergo mutation, and any cell in the body that undergoes mutation can produce a tumor. And what we're talking about today is how these melanocytes inside of the eye produce cancer in the ways that we just talked about. In each of those three locations, we can develop a melanoma, or a growth, an abnormal growth of melanocytes, which is the cell. We can get them in the iris, we can get them in the ciliary body, we can get them in the choroid. Most patients who have uveal melanoma have choroidal melanoma. Remember, uvea is the whole middle area, and all three of these structures are considered uvea. Most patients with uveal melanoma have choroidal melanoma, although some have ciliary body and iris melanoma. How does this all happen inside of the eye? Well, this is where the world of uveal melanoma is changing, and it's very exciting because maybe 10, 15 years ago, we didn't actually know. And now we are actually learning what is happening inside of these cells to produce the cancer uveal melanoma. You see some letters here. These are some of the genes, the DNA that we know becomes mutated in the cells. We're still in the very early days. You can hear a little bit more about it today, but we're learning a lot about what causes the mutations, what the mutations are, and what's happening in the cells to produce the melanoma. Uveal melanoma is the second most common form of melanoma in the body, the first being the skin. Now, it only represents 5% of all melanomas. So for every uveal melanoma, there are 19 or 20 skin melanomas in the United States. The median age is 62, although you can see from this graph down here that it affects all ages, and we have even young children with melanoma in the eye. It is slightly more common in males, and for reasons related to pigmentation in the eye, it is almost exclusively, though not exclusively, in lighter-skinned individuals. The incidence is about 6 people per million per year, which ends up being about 50 people in the state of Washington every year, or about 150 in all of the Pacific Northwest each year. How do we make the diagnosis? So this is one of my favorite questions for our trainees, the residents and the fellows who come to clinic with me. We have one of them here. I'm so excited. One of the questions we ask when they come in is I say, what is the gold standard diagnosis for uveal melanoma? We use this word gold standard in medicine. This means the best possible test. If we're trying to determine what is actually a diagnosis, this is the test we use. And I ask them, what is the gold standard diagnosis? And inevitably, they all say biopsy, and they are all wrong. And that's why I love asking the question. That is, it's a trick question because almost every cancer in the body is diagnosed through a biopsy, but uveal melanoma is not diagnosed with a biopsy. And it's not because we don't want to, it's because it doesn't actually work very well. The reason for that is the eye is a ball. It's a basketball. If I go in and I cut a little piece out of a ball and I take it out, that ball is not going to hold its form. It's going to lose its integrity and it's going to flatten. So I can't cut out a little piece of an eye. There are ways to put a needle into a melanoma and pull out a few cells, which we will talk about, but for various reasons that I'm happy to talk about at some other time, it's not very useful in distinguishing what is a melanoma and what is not a melanoma inside of the eye. So we have to rely on our doctoring abilities. We have to look inside of the eye, and we have to figure out just by looking and doing some image testing whether something is a melanoma or not. This can become a little bit tricky, so I'm going to tell you how it works. Melanomas almost always inside of the eye start as moles. Now we use the word nevus, which is the same exact thing as mole. Here are some pictures of what moles look like in the eye. Moles are pretty common. About 10% of lighter skinned individuals have a mole inside of their eye. And just like moles on the skin, like on my face, for the most part, they never change. They just stay there and they don't cause you any problem. But as with every cell in the body, the melanocytes that make the mole can undergo mutation. And when they undergo enough mutations that allow them to grow, they can become the melanoma. Here are some examples of what a mole looks like when it turns into a melanoma. Here you can see on the left a mole that's a little bit pale. It's blonde. And it has two little buds growing after we were watching it for a little while. So this is melanoma growth inside of the old mole. Here's a mole that started to grow a little nub here. Here's a mole that grew in all directions and became quite a bit more massive. I guess I should explain the photos we're looking at here. I know that you have all looked at them with me in the clinic, but these are pictures of the retina of the back of the eye. This is the optic nerve of the eye. This is the center of the eye, and this is the side or peripheral retina. And this is the mole, which is about 3 times the size it was previously. Here is a mole that then grew what we call a mushroom or a collar stud on top of it. So each of these areas in the uvea has moles and can develop cancer. So let me give you just a little bit of information about each one, and then we'll go into how to diagnose them. Melanoma in the iris is the most rare. It's probably also one of the more easy to spot, because if you have a spot growing in your iris, you are probably going to notice it and you're going to go to the doctor. Melanoma in the iris is something that, though we don't see it very often, it's a fairly nice diagnosis to have. It's a little bit less dangerous in some ways than the other ones. But they can be pigmented, dark, or they can be blonde. This is one that's pigmented. Melanoma in the ciliary body is a little bit more challenging because as it's growing, nobody knows. You don't know, and even if an eye doctor was looking in your eye, they're not going to know because it's hiding behind your iris. You're not going to see it until one of two things happens. Either it grows forward in the eye and you get pigmentation in the front of the eye, which has happened here. You can see pigmentation grew through the wall of the eye and into the corner of the iris, and that's how we found this ciliary body melanoma. Or it grows large enough that it starts to affect your vision. But to grow large enough to affect your vision, you can imagine it's going to have to get towards the center of the eye, and it's going to become rather large before you can see it. Melanoma in the choroid is what we see most commonly. It can be both pigmented and blonde. I had a question earlier today about whether if something is pigmented or blonde in the back of the eye, if it carries any risk of spread. The answer to that is I do not think so. There are some things to do with how much pigmentation is in an eye in general that can help us determine some risk, but what the color of a melanoma in the eye, I don't think is something that is that useful in determining the risk of spread. Those are the type of questions, write those down. I'd be happy to answer those if you have those as we're talking. This diagnosis is the one that is challenging. Figuring out if something is just a mole or a melanoma in the choroid That is what Dr. Scallett and I do all day, every day. This is the bread and butter of being an ocular oncologist. And it's not a simple task because we can't rely on biopsy like almost every other cancer in the body. To my knowledge, eye cancers are the only cancers whose gold standard diagnosis is a doctor looking. And that's a tall order. The way that we do this is we use something called risk stratification. We look for risk factors inside of an eye to tell us whether or not something is a melanoma. Here are the risks that we look for. So we have this interesting spot in the eye. It's kind of broad. It's taking up a big part of the back of the eye. And I'll tell you that this part is a little bit thick. That's something you start to recognize as you look at a lot of these images. That thickness we can look at with an ultrasound. And this image is an ultrasound. The ultrasound gives us a couple of important bits of information. The first is the actual thickness of the lesion. That is a very important criteria. Lesions that are larger than 2 millimeters are very commonly melanomas, and those that are less than 2 millimeters are less commonly melanomas. We also get some information about the quality of the cells inside of that growth. And we get that information by seeing how bright that lesion is on the ultrasound. A very bright lesion is a little less concerning than a darker lesion on the ultrasound. When a melanoma is growing, it can develop a type of a scar tissue called lipofuscin, or for those who trained in the United Kingdom, I say lipofuscin, you say lipofuscin in the United States. Yeah. I have all these weird British sayings because I trained there. This is something that shows up as an interesting pigmentation when we look at the eye. It becomes what we call an orange pigmentation. So you can have a dark mole with little orange dots inside of it. That's a worrying sign that the lesion has become a melanoma. A mole can also become active and can release fluid underneath the retina. These are scans that many of you have seen in clinic called OCTs, or optical coherence tomography. Don't worry about that, OCT, we never say those words either. What this shows is fluid between where the lesion is and where the retina is. Here is the lesion, here is the retina, and here is dark fluid in between them. The fluid is a sign that something inside of that mole is active. When you have fluid in the eye, it normally produces symptoms, things like flashing lights, things like blurry vision. Each one of these characteristics is built into a model. And when we are seeing you or seeing a patient with a mole that is concerning, we look at these risk factors, and depending on which ones are present, that helps us know whether something is just a mole doing something angry, or if it's actually become a melanoma. It is not easy to make that distinction, I will tell you, and sometimes the best we can do is we say, I'm not sure, we just have to watch. And if the lesion grows, then we know, but sometimes we just have to watch because there is no other alternative. There are a number of things in the back of the eye that look like melanomas, but are not melanomas. We call these things masquerades. And this is also a big part of what I do, is things from around the area will look funny, and the doctors will send them to me saying, I'm worried this is a melanoma. In these photos, only one of them is actually a melanoma, and I won't quiz my resident, even though they are here. This is just a type of a mole that's not concerning almost at all. This is a form of inflammation inside of the eye. This is just a bleed underneath the retina. This is macular degeneration in one of its later stages, and this is a melanoma. So there are many things that look like melanoma, and it takes a lot of practice to figure out what is and what is not melanoma. Melanomas without treatment will grow. Oh, I'm doing good. We're going to have time for questions. Okay. Without treatment, melanomas will grow. And this is an example of a melanoma that was left without treatment of the patient's choice. And you can see the growth over time. Here, the melanoma is small, but over time, it grows. And you can see it's going to grow a little bit in its dimensions, but it's also growing in its thickness. And on this 2D image, you're going to have to imagine that the thickness is getting larger with each time. That is what's going to happen to a melanoma if it's not treated. So we have to treat these melanomas or they will destroy the eye. And as I've talked to many of you about, there are two risks of a melanoma in the eye. The first is that it will grow and destroy the vision. The second is that it can spread, and our treatments are aimed at doing our best to prevent both of those. There are a number of treatment options, and I'm going to mention them briefly, and then some of them we'll talk a little bit more about some of the other speakers. Active surveillance is just monitoring. We're just watching the melanoma, and there's reasons that that might be useful, and I'll talk about it. There are some laser treatments that we can use, which have some utility. Radiation is the mainstay of treatment. Most patients with uveal melanoma are treated with some form of radiation. And surgery is another option. It's uncommon to be able to resect or cut out a melanoma and keep the eye intact. The one caveat to that is in the iris. Sometimes you can cut out a melanoma and leave the eye intact. Eye removal surgery is the surgery most common that is performed. And oftentimes that is done at the time of diagnosis, and sometimes that is done later on after the eye has gone through a number of treatments. So briefly, let me mention each of these. Surveillance. Why would we just watch a melanoma? Well, what a doctor's job in this situation is to provide information. Every treatment has risks and benefits. When you perform a treatment, there is a risk of the treatment and there is a benefit of the treatment. When you don't perform a treatment, there are risks of not performing it, but also benefits of not performing it. So there is a risk-benefit ratio that is going on in my head all of the time. And I'm trying to determine if the risk of treatment outweighs the risk of not treatment. So what would the situation be where we would not do anything? Well, what if the melanoma is very, very small and right next to the visual part of the eye? A very, very small melanoma has a very small chance of spread. But if I treat it, I have an absolute chance of vision loss. So am I willing to destroy vision in an eye when I'm not really sure it's ever going to cause a problem in the rest of the body? That's a problem that I've discussed with many of you. It's not an easy solution. There are some factors that come into play here. If a patient is 90 years old, that patient and I may not feel as eager about destroying vision if the risk of spread is probably not something they're ever going to deal with during their lifetime if we do nothing. That would be an example why just watching a melanoma may be very useful. If a patient is 30, well, they have 70 years to live. Their risk of this thing growing and spreading is much higher. So that risk-benefit ratio is a little bit different. Laser treatment is a treatment that is possible in some smaller tumors. It's a treatment that is done by the ophthalmologist in clinic. There are a couple forms of laser. One of them is a cold laser called photodynamic therapy, or PDT. One of them is a hot laser, which uses a burning mechanism to destroy the melanoma. These treatments are useful because they are not nearly as toxic as radiation. We can treat some tumors and we can preserve vision. The problem is that their utility is not nearly as good as radiation either. So for a tumor that can be treated with a laser, usually only about half the time can we get the tumor to calm down and to stop growing with just the laser, which means that half the time the tumor continues to grow after the treatment. That's not a great ratio in cancer treatment. 50% is not something we're looking for. But In situations where the tumor is right next to the visual part of the eye, as some of you in the room probably have experienced, we will start with the laser and we'll see. Hopefully we get a response. And if we do, great, we don't have to do anything else. If we don't, then we have to move to radiation later. We don't usually think of laser as the only treatment. We think of it as the first treatment, and we may need to move to something else if we must. This is an example of a patient that was treated with PDT. You can see on the left is their very small melanoma right next to the nerve. And on the right is their melanoma, which shrunk down fantastically well from this laser. So far, so good, but this is something that we're going to have to watch very closely because it's a laser and it's not as successful in the long term as radiation. But at least for the moment, it's spared this structure here, which is the optic nerve, because if we need to radiate this melanoma, that optic nerve is not going to live. There's no way to radiate this melanoma and not destroy that nerve. Radiation, there's a few different forms of radiation. The two most common forms of radiation are brachytherapy, or what we refer to as plaque brachytherapy, and an external beam of radiation. A plaque is a device that is placed on the wall of the eye. So here is a kind of a picture of what a plaque looks like, and then how it's stitched using a surgery onto the outside wall of the eye, and the radiation is emitted into the eye for about a week. Here's a different kind of a plaque resting on the eye. In the Pacific Northwest, we have access to a proton beam. Now, many of you have heard about the proton beam, but you are unique in that respect because a proton beam is not widely available. To my knowledge, there are only 4 or 5 now proton beams that are treating ocular melanoma in the United States. So while it has been something that many of our patients have experienced, not many patients in the United States have that option. And so actually plaque is by far and away the most common form of radiation in the United States, though in the Pacific Northwest, both are available. These have very good rates of control. Above 90% of the time, the melanoma does not grow any further inside of the eye. And these numbers are referring only to the inside of the eye. In other words, 5 or 10% of the time after radiation, a melanoma may grow and may need some additional treatment. But as many of you know, the side effect rate is also very high. Radiation is destructive. That is its whole purpose. When radiation goes into the eye, it does not know the difference between melanoma and normal tissue, and it will destroy everything in its path. Here's an example of a plaque before and after. Big tumor that shrunk down after a plaque, but you can see if you looked at a lot of optic nerves, you would know that that is not a healthy optic nerve. This eye is not seeing very well. And surgery. We talked about how cutting out a portion of the melanoma is usually not possible. So when we do surgery, it usually refers to removing an eye. Usually that is reserved for very large melanomas. This is an example of a very large melanoma that needed to be removed with surgery. The one nice thing about surgery is that once the eye is out, the risk of the melanoma coming back in the eye socket is exceedingly low. It's not 0, but it's very, very low. I'm going to talk a little bit more about, oh, it's right here, about the surgery. Surgery is something that often is talked about at the time of diagnosis, but as many of you know, also it's something that we talk about later because the radiation treatments can lead to side effects that lead to pain and blindness. And when you have an eye that is not seeing and is only causing you pain, there's not much of a reason to leave it in. And so sometimes we'll move to surgery afterwards, not to control the melanoma, but to control pain. When you have surgery, you would be shocked at how normal your life is. We have 3 ocularists in the state of Washington, ocularist groups. They're all great. Northwest Eye Design, Erickson's Labs, and Custom Ocular Prosthetics. I just pulled up one of their websites. If you go to their websites, you will see a number of photos of people that look perfectly normal. You're going to fool everybody but close family and friends after an eye removal surgery. The way that it works is The contour of the eye remains the same. So if you were to look at my eyes, you see an iris on both sides. After surgery, there's not going to be a big hole in the eye like Hollywood wants you to think. You're not going to be able to pull out a big ball. It doesn't work like that. The contour is going to be exactly the same. It's just that the white of the eye is going to cover what's behind it. And what's behind it is going to be an implant. The eye is removed, an implant is placed, and then the white of the eye covers the implant. The prosthetic eye, it's just a painted contact lens. It's a contact lens that fits underneath the eyelid. And because of the way that we do the surgery, that contact lens moves a little bit. I'll move over this quickly. We stage melanoma based in two ways, one on the size and one on the DNA inside of the melanoma. Here are some pictures of 4 different stages of melanoma inside of the eye, from 1 to 4. They get larger as they go. 4 is a little bit confusing because it looks small, but it's actually here and all the way around here. That's all melanoma. We stage also with the DNA, and we talk about biopsies. Now, these are not biopsies to figure out what a melanoma is. These are biopsies to figure out how aggressive a melanoma is, looking at its DNA. There are 2 ways to obtain a biopsy. One is placing a needle through the sclera, or the wall of the eye, like this first image. We place a needle just inside the wall of the eye and we pull out a few cells. And that's what we do when the tumors are in the front of the eye. When the tumors are in the back of the eye, we can't do that because that's back in the eye socket. And what we have to do is place a needle into the eye, and then we watch it through a visualization system. We watch it go into the tumor. Now, there's been some requests to show a video of what this looks like. If you do not want to see this, the next slide is going to be a video, and I invite you to close your eyes. It's only going to be 2 minutes. I'm going to show you what it looks like to move the skin of the eye and then to place a needle inside of the eye. This is what it looks like in surgery. That is just the skin of the eye. The skin of the eye is white. We remove it in all of our surgeries, whether we were removing an eyeball or just doing plaque or getting you ready for a proton beam. I'm going to skip to this part. When we get into the eye, we place a needle into the melanoma carefully. Once the needle is in the melanoma, we pull on a suction tube and we pull out some of the cells of the melanoma. Now, this looks large, but this needle is tiny. This is almost float in the air if I threw it up. This is a very, very small needle. After we remove the needle from the melanoma, we wash it in some fluid, and then we send it for analysis. As I've spoken about with many of you, there are a few things that we learn from that biopsy. I'm not going to talk about them today because I think some others are going to talk about it. But what we learn is some very interesting things. And what I want you to remember about this is that the future is bright. These biopsies are new. They are within the past 15, 20 years that we've learned anything about what's going on inside of the melanomas. I don't want you to remember anything about this slide. The point of this slide is not to know what those things are. I don't even know what most of those things are. There's too many of them because you can't keep up. We are learning so much about the cells in these melanomas. Each time I read a new article or I see a new research or I see a new clinical trial, it's amazing what is changing in the world of uveal or ocular melanoma. It's a great time to be a doctor in the field. It's a great time to be a patient in the field. It's really exciting. And I'm really grateful to be part of it. So with that, thank you all for coming. I just want to say one thing. It's, I have a lot of hats that I wear in life, but the hat that I wear taking care of ocular melanoma is something, I don't know, I just wish that every doctor could experience it. the patients that I work with, you are inspirational to deal with something so challenging in your life, your family members, the caregivers that are here, to deal with something so challenging in your loved one's life, to see you go through it in a disease that you can't visualize. It is so scary because you don't know what's going on and you have to rely on us to tell you what's going on. I am inspired every day to see you guys deal with this, to deal with the vision, to deal with the surgery, to deal with the radiation, the scans, the anxiety. It is an inspiration to me to be part of it. And so thank you all very much for everything you do. I did talk longer than I wanted. Sorry, Shailender.
That was outstanding. Is this mic working? Well, any questions from the audience? And I'll bring the mic to you.
I was curious about with the biopsy, are there any risks with the biopsy and you've got a needle dragging itself from the tumor, the melanoma, through the eyeball? Are there risks associated with that?
Absolutely, yeah. So in general, we don't like to stick a needle in an active tumor. It's just not something we love to do. Anytime you place a needle into a melanoma, there is a risk that when you pull the needle out, you're going to pull with it some of those melanoma cells. Now, we take a lot of precautions to make sure that those cells don't go somewhere else in the eye. And I will tell you that we've done hundreds and hundreds of these, and we've never seen any of those cells migrate to another place in the eye. If they did, it would require a second radiation treatment. Now, it's exceptionally rare, but I will tell you that last night, Dr. Scallett, myself, and one other doctor who deal with this, it's on our minds enough that we were talking about it last night. Even though none of us have ever seen it, it's something that we think about. That's the main risk that we worry about. There can be some bleeding and some scarring at the biopsy site as well. Those are a little bit less risky, and usually they're things that go away on their own and don't cause much of a problem. You can,
well, I think it's actually great for the online attendees as well, so they can hear us.
I know you said that the gold standard for diagnosing ocular or uveal melanoma is just looking at it, but how often do you actually need to do a biopsy for diagnostic reasons, like percentage wise?
That's a trick question. I would say I have two answers. So when I'm deciding if something is a mole or a melanoma, the answer is never. And there's a reason for that. It's not because I don't want to. If such a biopsy existed, I would love it. And someday, with all of those funny numbers and digits that we saw inside of that cell, maybe someday we're going to be able to have a test where we pull out a cell and we'll be able to tell, based on some gene in the cell, is it a melanoma or is it a mole? But at the moment, that doesn't exist. So there is not a reliable way to do that. Now, you will hear different answers from different ocular oncologists across the country, but even in centers where they feel like a biopsy is useful, they are not biopsying very often when they're trying to decide between mole and melanoma. Where a biopsy is helpful is when you don't know what the thing is. Sometimes it can look like some of those other things, right? So if I biopsy something and I'm trying to decide if it's blood or a melanoma, and I see melanoma-like cells, then I know it's not blood. So if I'm determining between melanoma and something else, then a biopsy is useful.
Andrew, can you comment on the rate of risk of complications from the biopsy? And the risks, the complications, are they reversible, or is there a risk of permanent damage just from the biopsy procedure?
Yeah, so the biopsies are new enough that there's not great data on late-term complications, but I'll tell you what we see. Probably about 10 to 20% of patients have bleeding. after the biopsy. That's just something that can't be, some tumors are going to bleed. The blood will normally go away on its own after a few weeks or a few months. I have not needed to do anything additional to get rid of blood from a biopsy, though I can see that potentially being a problem, that the blood doesn't go away. The other potential risk is that the retina in the eye detaches after the biopsy. I have not seen that either, but I could guess that that's going to be something along the lines of a 1% or less risk of doing the biopsy. So the truth is, there aren't many risks from the biopsy. Now, the smaller the lesion, the higher the risk, and the location of the lesion can be a little bit concerning. If you have a melanoma that's just above the center of the eye and you biopsy it and it bleeds into the center of the eye, that might affect your vision. So some of those situations are the situations where I'll say, this is not a great spot for a biopsy. I think we'll go without a biopsy. And I do want to say, you guys are all living in a place where a lot of biopsies are being done, both in Portland and here. That's not true in other parts of the country too. It is not necessary to obtain a biopsy. It's something that doesn't affect our treatment. We're going to treat the patient either way. So some of you may not have obtained a biopsy, or I may have recommended in that situation to not get a biopsy, and that's fine. Sometimes we don't get them, and that's okay.
And what do you do with the information of the biopsy?
What do we do with the information of the biopsy was the question. In our center, so that's different based on the center you are being treated by. In our center, Dr. Hall, Dr. Bhatia, and myself use that information really for determining how frequently to scan the body in the future. So it doesn't actually affect me at all. I treat the eye the same way. I follow the eye the same way. It has no bearing on what you and I do. The only thing it really affects is what you and Dr. Hall or Dr. Bhatia are doing helps determine how risky the spread to the rest of the body is and how frequently the rest of the body needs to be scanned.
And how accurate is that result in terms of how accurate is the result of the biopsy in terms of how often you should scan?
Great question. And I might hold that one for Dr. Scallett because she has a lot of data. Just going to talk a little bit. Are you going to talk about that? Yeah. So it's pretty accurate. It's pretty accurate. And there is a new study coming out with thousands and thousands of patients helping to hone in our knowledge about what these biopsies are telling us. Though we're still admittedly in the early days of genetic testing of these tumors.
Thank you.
I'm assuming marker placement's only part of proton therapy. Is biopsy standard with your marker placement?
Again, I wouldn't use the word standard, but it's always an option. Sometimes the tumors are too small. Sometimes the location is not a good location for biopsy, but it is something that is always on the table.
Great. There's a question in the chat about metastasis. I actually saved that one for Dr. Scallett's presentation. I think it would be a good fit for that. So I think we'll move. Are there any other questions?
There was one more hand.
Oh, sorry. I didn't mean to interrupt anybody behind me.
The site's going to go away?
Yeah, great question. So what everybody wants is when they come back to me. So the question is, does the proton beam mean that the site is going to go away, that the melanoma is going to go away? Is that correct? Or the vision? Oh, no. Okay, so it doesn't mean that the melanoma is going to disappear, first of all. Everybody wants that, right? You come back after the radiation and you say, Doc, is it gone? I can't say that. I mean, there's always going to be a scar there that we're going to be watching. What happens to the vision after radiation of any form is a bit patient dependent. Not that you have anything to do with it, but it varies based on patients. So it's really hard to predict what the end vision is going to be. There's a lot of factors that play into that.
Great. Well, in the interest of time, we'll move to the next talk, but I'm sure Dr. Stacey will be available to answer any questions during the break times too. But let's just thank Dr. Stacey again for an outstanding talk. So after Dr. Stacey sees the patients in the clinic, he picks up the phone or fires up a Zoom meeting to discuss those patients with our radiation oncology team to discuss radiation therapy options. One of our fabulous radiation oncologists is here with us, Dr. Leah Halasz. She has been with our Proton Center since the very beginning days. She is also a director of our Brain Tumor Center, and she also is responsible for training the next generation of radiation oncologists, being the residency program director. So it's my pleasure to introduce Dr. Leah Halasz to talk about proton therapy for treatment of ocular melanoma.
Oh, okay. Thank you. Hello, good morning. And I want to thank the organizers for inviting me to speak today. It's always a really fun to talk a bit about radiation and protons and what we do. I have been involved with our Proton Center since we opened 10 years ago now. We just had our anniversary. And since we treated our first patients for ocular melanoma in 2015. So it's been a great team to be part of. Here are my disclosures. So today, three goals. I was going to talk a little bit about the history of radiation therapy to kind of explain how radiation therapy is used for different cancers and how radiation therapy has been used for ocular melanoma over the years. Talk a little bit about data on proton therapy and explain some of that. Some of you are very aware and have gone through that. Some have not, to talk about it. And then kind of touch on some of the innovations and the reasons we do that at Fred Hutch Cancer Center. So radiation causes DNA damage that cancer cells cannot repair. So Dr. Stacey gave us a very good and great kind of explanation at the beginning about how cancers are cancers and how they start to grow uncontrollably and invade into other tissues. So radiation overall are high energy particles, and there are different kinds, which we'll talk about. We give them to a certain dose, which we kind of give an amount of radiation called grays. And these particles actually cause DNA damage. So it's very much like chemotherapy, where the high energy particles goes against the DNA that is replicating over and over again. And there is some DNA repair and some non-repairable damage. And so that causes cell death of the cancer. So overall radiation, it's not heat, it's not a scalpel. It actually picks up dividing cells, and this is why it affects cancer cells much more than the normal tissues around there, although it will affect some of the normal tissues. So how does radiation therapy avoid damaging healthy tissue? So one, as I just talked about, it preferentially works on dividing cells, and since cancer cells are dividing, these are ones that are kind of open and ready to be affected. But there is also something called fractionation. And that's an idea that we give little doses of radiation over time. That allows, this is kind of a cell survival curve. So how many cells you have and how many times you push it with radiation. The healthy tissue, because it's not as dividing and doesn't get affected as much, when you hit it multiple times, does better than when you give it all in one large boost. On the other side, melanoma has always been a type of tumor that doesn't do as well with little tiny bits of radiation. So part of us giving radiation over 5 times or 1 time is trying to give a kind of a large dose, because melanoma cells don't do as well with in terms of getting treated with kind of smaller cells, smaller fractions. So the other part of this, and what I'll talk a lot more as a radiation oncologist, what we try to do is use our technology as well as the different types of particles to get at targeting more precisely. So you have this radiobiological effect that helps normal tissue, but you also can be much more precise. And so we use things like imaging. We use things like trying to stop the body from moving or tracking where the body is going so that we could be precise. We use a lot of complex delivery methods and programming on computers using algorithms to figure out the best way. And we use different sources of radiation. So to take a step back, what is radiation? What types of radiation do we use as radiation oncologists? Because we use radiation for the majority of cancers out there. So the most common is external beam. So that's the idea where we can give a beam of radiation from outside. And the most common is this diagram, which is called a linear accelerator, where you have a machine that creates X-rays that we can then point out in a beam. And we can manipulate that beam, we can shape it, we can make it different energies, we can move it around the body. We also have heavy particle cyclotrons, which give out protons, which is what I'll talk more about. Protons are a heavy particle compared to the X-rays, and so have different physical properties. There's also internal sources. So brachytherapy, which is used for most of the uveal melanomas. Brachy means short. And so the idea is that brachytherapy, you actually put a source of radiation right on the body part. And that radiation goes a very short distance. So you get to the tumor. And even though it keeps going, the dose is very, very low. So the most effect you're going to have is very, very close to your source. So that's what brachytherapy is. And we use brachytherapy in all different parts of the body. Here I'm showing how you use it in the eye. We also use it for cervical cancers. We use it for skin. We use it for prostate. Basically the idea of actually putting the radiation source right next to the tumor. And then finally, there is some radioactive drugs, and these are systemic radiation. So this is something that's ingested or injected. And these are used for different kinds of cancers, for instance, thyroid cancer, some of the blood cancers. So those are the three ways we sort of deliver radiation. So I wanted to step a little bit through the history just to kind of get at these three different ways and think about the history of our field. So we think about starting around 1895. Actually, that's when X-rays were discovered by Wilhelm Conrad Röntgen in Germany. And he first reported on this. And then very shortly after, actually, there was the first report of treating breast cancer with external beam radiation. So here is Dr. Röntgen discovering his X-rays and the kind of technology that was in 1895. Very soon after that, Marie Curie, who was a physicist, discovered radium. So she took uranium and made it radioactive, and radium was a radioactive source. And very soon after she made that discovery, which gave her the Nobel Prize, they used it for skin cancer with brachytherapy, so sticking radiation right on skin cancer. And this is Marie Curie. So protons came into medical use actually in 1946, so quite a while ago. So a physicist, Robert Wilson, first proposed the medical use of protons because protons had this unique property of going into the tissue, but being able to stop. So the idea was, can we, by stopping that beam from continuing to go, create less damage in the rest of the body? So here is the Harvard cyclotron from the 1950s. I just enjoyed kind of looking back at some of the technology that was there. This is completed in 1949, mostly a research facility, and actually many patients who have been treated around the United States and in Europe for ocular melanoma were kind of treated in research facilities. So it looks somewhat like this, and this was the computing power. This is the present day our cyclotron that's in the back of our proton center. So kind of looks pretty similar, still a cyclotron, which is where all of the protons are sort of created and then brought up to speed. And then a beamline, which bends it and brings it into our rooms. So that was 1946, first done. The first proton treatment for ocular melanoma was 1975 at the Mass Eye and Ear. Around the 1960s, don't want to forget about brachytherapy, the ophthalmologist Henry Stallard pioneered cobalt brachytherapy for ocular melanoma. This is Dr. Stallard, and of note, he did win a bronze in the 1924 Olympics in the 1500 meter race. Ophthalmologists have quite a lot of energy, you guys. Yeah, you must have tons of free time now. So I think, overall, this is kind of the historical look at when we started to use radiation. But really the last 20 to 30 years, what we've really capitalized on is one, new imaging. So being able to see the tumor. I talked about how in the very beginning, we used radiation very much for tumors we could see right on the skin, right on the breast. What imaging with CTs and MRIs has allowed us to do is really to see cancers in all parts of the body. And then computer power. So computer power has changed our field greatly. We use a lot of advanced and sophisticated computer algorithms to really make the radiation be much more precise and to be able to get the places we want. So overall now, proton therapy, it's really gained a lot of centers more recently. So now there are 41 centers in the US doing proton therapy. Not all places treat eyes, as Dr. Stacey was talking about. And this is a huge difference. When I first started using protons, which is now about 17 years ago, I did my training over at Mass General Hospital, and we were only one of 2 centers in the whole United States. So this is kind of a very fast change, and there are more and more centers. So what is proton therapy? So as I said, protons are charged particles, and they're really produced after stripping electrons for hydrogen gas. So you can have a canister of gas there for several years, and there's so much in there that just will sustain it. And the expensive part is having this cyclotron, and that's because for treatment, protons are accelerated to very high speeds. So the energy of the protons kind of dictates how far it can go into the body. So for instance, at our cyclotron, we go up to 230 mega electron volts. That goes to 32 centimeters in depth. So you can treat everywhere in the body. And that is 2/3 the speed of light. What happens when protons go into the body is that they're so heavy compared to what else is going on in the cell, is that they lose very little energy until they lose the energy of their mass. And that is called the Bragg peak. So the whole thing about protons is that they stop. And this is an example and a graph of the beam and kind of the dose and going into the body further and further based on what their energy is. And that's why that's helpful for eyes. This is a dose map when we look at radiation. A beam is coming from in front of the eye. This is kind of the bridge of the nose. This is the left eye. This is the right eye. So it's as if we're just looking at the top of the patient. And basically overall, the beam comes in, and I look at this on our computer. We have a tumor kind of mapped out right here. We have the dark blue, which is the very high dose of radiation. And then as these colors come down, it gets to be lower and lower dose, so that this light green is 1/10 of the radiation dose. So the idea with protons is you come in and then we can stop. And so that stops before getting to the brain, to other nerves, to the other eye, and you can stop it where you want. So long-term data on protons, and there are a lot of series. There has never been randomized trials really looking at protons versus brachytherapy. But I pulled up this recent publication, which is one of the larger ones from the Mass Eye and Ear Institute, because they started in 1975. Over 1,100 patients with uveal melanoma. These were smaller, medium-sized tumors. And overall, tumor control was excellent, 99% at 5 years, more than 95% at 10 years. But the long-term vision outcomes, which we were talking about, to me, left more to be desired. 20/200 vision was about 50/50 at 5 years, 10 years, just 29%, better vision at 20/40, just 9% at 10 years. So I think that's what we were just talking about, is that it's very good at controlling the tumor. Can we do better about sight? So one of the big reasons for the program being opened here is I always go back to our motto as the University of Washington, which is to improve the health of the public. And so really one of the big things is that we wanted to increase the availability of proton therapy, and we wanted to improve the side effect profile. And I mentioned that there are now 41 centers for proton therapy, but those 41 centers are mostly over here in the East Coast. As you can see, our proton center actually sits, Utah just opened, but we sit very much in a large area where we can serve a lot of our patients from the Pacific Northwest and beyond. And I always thought that this would be a really important place for a proton center. I'm originally from Seattle. I was very excited when I heard there were plans to build the center here, because it was on the East Coast and we were treating children with protons, which is kind of the main place we started, just to kind of limit a lot of the radiation effects for them. I remember I was taking care of 3 young children from the Pacific Northwest in Boston. And so I think what was really important is this idea to bring it here to the Pacific Northwest. So we partnered with 3 ophthalmologists who you're hearing from today, and we've treated our first patient in December 2015. We've treated more than 350 patients since. So where is the innovation? So part of this is that our center is not a research center, it's a clinical center. And so it's a very large 4-room center. This is a blueprint of the radiation center. Here's the cyclotron, which nobody ever sees because it's really locked up back there. But the protons are made here, and then it gets brought into each different room for treatment. So what a patient sees is actually these treatment rooms where it's an open room. They lay on a couch or bed where they sit up, and you have the proton beam that comes out of various nozzles. So previously, ocular programs have been with lower energy cyclotrons because that was able to treat eye tumors because they're pretty much on the surface. And it was all based on planning and modeling and drawings based on the ophthalmologist and where they placed clips. And then we'd put them into this eye model, and then we would deliver the treatment. The modern day and building our program in the last 10 years, we really had this higher energy facility, and we have CT simulation, which is what we do for the rest of the body, which is using our imaging, including a CT scan, which you see here at the top, and an MRI scan, which you see here at the bottom, that gives us a really good picture of the tumor. And so what we want to look at is actually creating a use for these multi-use proton facilities, which are being built all over the place for ocular melanoma. Now I realize this is a snapshot of the full patient's journey, and I look forward to the fact that we will hear about that later on this afternoon, the full journey. But this is the journey, which is quite a lot of steps for our patients in going through proton therapy during the time that they're really working with us and in the medical center. We work very closely with our ophthalmology team who meets the patients, does all this workup, everything. They go through ocular MRI and CT with our radiology group. They're evaluated by us in radiation oncology. They have the scleral clip placement by ophthalmology. They do CT simulation with us. They do the proton treatment in 5 fractions, and then there is follow-up by all of our groups. So I think it's a multiple step process that each of the patients go through. A bit about what it actually looks like when we treat patients. This is a patient who gave permission for me to take a picture. This is a mask that we use to keep people stable so that we're precise when we deliver. This is one of our physicists and the ocular snout that comes out. This is where the beam comes out of, and kind of our custom sort of cutouts to shape that beam. This is a little dot, which patients will look at, so we know exactly which way the patient is looking while treating. And this is the video camera as we follow and watch patients as they're being treated. So the first part of this was the thing about an eye tumor is that the eye moves. And so the tumor moves with the eye. So if I just start to treat somebody and their eye is moving all over the place, then I have to treat a much bigger area than if I knew where the eye was looking. So the first part of the treatment is really to have positioning with those clips. And so our ophthalmologist will place scleral clips on the outside of the eye. They're very tiny, it's just a tiny little finger. And they're put in 3 different positions. And the idea, and we kind of send in these diagrams so that they will put them there, is that when we treat, we can take an X-ray in the front and then in the side, and we can be right on for where the eye is. So first we get you kind of set up to the skull, but then we really hone in on that eye. And it's really amazing that when people look at that dot, you really can reproduce this so that we're only making little shifts of 1 millimeter, so we could be quite precise. We then have people get on their backs and we get a CT scan in that mask looking at that dot, so we know exactly what it looks like. And then we use our MRI scans that can show the tumor quite well and use that with our CT scans and make sure to fuse on the eye so we know exactly where the tumor is. So a lot of what we've been doing in our development and publishing recently has really been looking at creating a sharper beam. So as I was talking about, I think, what's important, this is that same picture, high dose to low dose. I want this spread from the very high dose to low dose to be as small as possible, because I want really, the eye doesn't give us very much room. There's not much to do there. So what we look at is a beam profile, and this is kind of looking at a beam coming in and out where you have high dose up here, and then it falls off to very low dose. So what we've been working on with our medical physics team is how to get this sharper and sharper. So much of that has to do with actually changing some of the range in the back, with creating these custom apertures where you can actually get a beam very close to a patient's eye, so you can actually get that fall off. And I think the most recent thing we've been working on quite a bit is that proton therapy used to be sort of a beam that you open and shape, and then you actually kind of give it different layers to go through so that you can sort of make it so that it really goes around the tumor, but not further. More recently, our proton places have gone to what we call pencil beam scanning. And the idea is, instead of having just one ray that comes out, is that you actually have little dots of radiation that you can change their energy. So it's very much, you can create a really specific shape. And one of my patients called it like a 3D printer. And I think that's a good way to think about it, is that you have a 3D printer and you can kind of put in dots. And so when you do a 3D printer, you can have very complicated shapes. So our most recent publication that we just did in March was to really figure out with these 3D printers how we can actually make as sharp a beam as possible. And so this is actually a very nice thing for me to look at, which is basically high dose going very much to low dose very quickly, so that we can be more precise with what we do. And in order to do that, we really had to develop overall a better way of delivering that beam. So I think the other future innovations that are important with being and having a modern program is that the modern program with having MRI and CTs allows us to really delineate where a lot of places are. This is what we work very closely with Dr. Stacey about, and to look at the radiation dose at each of these and what actually becomes the risk of side effects. And that way we can kind of be smarter in our design. So overall, our future innovations are really to improve precision and decrease the side effects by using models and imaging. We're also working on and with some new software that really brings in some of those fundoscopic photos that the ophthalmologists take and bring them in for planning. We've talked about also improving availability of clipless treatments with surface tracking. These are some of our future ideas. So I just want to thank a really large team. I think that this has been a team effort because we really bring different views from all sides and all different specialties. And most of all, our patients. I think it's so important to have feedback from our patients about going through the whole process, about what they've been through as we build these new programs. So thank you.
How does the body eliminate the radiation that remains in the area that is treated?
It's a really good question. So There is no radiation that stays in the body after the beam is turned on. So the only time that radiation is actually being emitted is when you're sitting there and they turn on the beam, and some people hear a little click, 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 click. So nothing stays, but what does stay, and why this is a bit confusing to people, is that the effects on the cells kind of happen over a long period of time. So you are fine to leave and be with others. You're not going to give radiation. Brachytherapy, the radiation is there when that plaque's in your eye. So then there are certain things where we're careful about having things too close and that sort of thing, because the radiation is really there. But once that plaque is taken out, then there's no radiation left.
Thanks, Dr. Halasz. You do great work. I was wondering if you get the data from the ophthalmologist after the treatment to see how the vision changes and if that is helpful for your team.
Very helpful and very important. So I think this is where working with Dr. Stacey and Dr. Scallett and knowing them well is important. We have overall, in terms of our follow-up, kept a very close group. So we look at a lot of the outcomes that happen. And I think that's important to kind of get the feedback, because we can do different things with technically. Sometimes we're very limited by what we have, but I think that multidisciplinary group and being close is really the key to try to improve our treatments overall.
Can I ask one question? Can you predict who is more likely to have symptoms or from toxicities and so on based on your treatment plans?
No, really good question. So you can predict based on where things are and how big they are. That's what we need to do, is to be able to look at the fine data. It's always a risk, and that's kind of how we look at other parts in the body too. It's, what is your risk at this dose and this amount that we're giving? But at the same time, I think that's where the new imaging can really be helpful.
Is there any kind of tumors that proton beam can't be used for?
Good question. So I think where the proton beam is important and helpful is when you are doing a local tumor, meaning a tumor that you can very much have a certain size in a certain place. I think once the cancers go into multiple parts of the body or in multiple areas, then yes, you can treat, but at the same time, you can't treat everything. So it's really for being very honed in on a certain place. It's a good question though. The thing about protons though too, is that you could treat a lot of things, but is it going to help you? So I kind of think about it, for instance, when I treat a lot of patients with brain tumors, ones that are on the side, protons really helps me because I can come in and stop. Ones that are right in the middle, sometimes it doesn't help me because basically I'm going to have to come from both sides anyways. So it's really the way that we can manipulate protons that kind of says when it's helpful.
We've got a couple questions from the online participants. It's been mentioned that protons for uveal melanoma is not as widespread as protons in general. One question was, what are the other centers that are helping drive this forward for ocular melanoma specifically? I know we've got some online participants from around the country, so that might be of interest. And then the second question is, on the vision chart, what does 2200 mean and what does 2040 mean? And I'm happy that I have other physicians who can explain that better than me.
Yeah, I think maybe the ophthalmologist would explain that. So I would say for the other proton centers, so I think the ones who started here in the United States, Mass General has a large program. There are other programs in California that have used some of their more legacy systems and are looking at using newer systems. I think Mayo is working on their system. Who am I forgetting is MD Anderson? Northwestern. Chicago actually is a group that we have worked with quite a bit, and they were the ones who kind of first pioneered this idea of using the CT scans, MRIs, and the new places. Yes. You want to answer about 2040 or 2020?
I won't go into how the chart works, but 2040 vision is functional. You can drive with 2040 vision. It's not great. 2200 vision is not good. So if you have less than 2040 vision, you are visually impaired. If you have less than 2200 vision in your better seeing eye, you are legally blind. So that's why you see those cutoffs.
Could you talk about a little bit about patient comfort during the treatment, in particular, the immobilizing mass and, patients experiencing claustrophobia when that happens?
No, that's a really good question. And part of my point of it's really important to have feedback. So the masks can be very constricting, and they're supposed to be, because we don't really want people moving. People generally do a little better because, the eyes are cut out. But we do practicing, and we kind of talk through. I've taken patients all the way from young age of 13 to age of 89 through treatment. And everybody, I think, gets worried a bit about being able to sort of concentrate on that dot. But to be honest, people do quite well once you sort of talk through it. But it is true that there are some people who have a lot of claustrophobia, and the eye of being strapped down in a room is really hard. So we try to talk about it before, we try to visualize, we try to kind of discuss that through. And usually people feel more comfortable after the first one.
So I saw where you stated that you had the eye vision tracked at 10 years. How long can one expect these vision changes?
That's a good question. I mean, all of the literature that I see, it continues, and that's what I think Andrew is nodding his head. What explains that for a while is that a lot of what happens from radiation damage, I think, sort of damages the blood supply to a lot of the parts. And so those kind of changes can occur many years down the road. Yes.
So the brachy radiation, seems like there's two surgeries involved in that, placing the plaque in the eye and then removing it. And then with the radiation, there's one. So is there a cost difference versus effectiveness difference?
Good question. I haven't seen any cost effectiveness outlook. I would say overall, probably brachytherapy is shorter number of visits, shorter number of people involved, but I haven't really seen that in the literature. That's my guess.
There's been one report, and they were pretty similar. Because the recurrence rate in brachytherapy.
Oh, interesting. Okay. Yeah, Dr. Stacey was just saying, because more of the tumors come back after brachytherapy, what this analysis found is they're about the same because you do the protons once, but those analyses are always a lot of sort of if when. So.
One related question online is, if the tumor changes later on, can you use protons again?
It's a good question. We have done that before, multiple decades after the first treatment. We don't like to do that. I think when you come back to treat the same tissue that's had radiation in the past, the risk and side effects are higher. But that being said, we sometimes do come back, but it's very rare.
All right, well, that concludes the morning session. We still have time for an 11-minute break. We're not too far behind. So thank you, Dr. Halasz, and we'll take a quick break.
Thank you for this.
Of course.
Okay. Welcome back, everybody. We're done with the most sciencey part of the talks. So you've gotten through the worst part. There's a little bit more of medicine here, and then it'll be less medicine in the afternoon. But I would like to introduce Dr. Evan Hall. Dr. Hall is one of our professors of oncology in the Department of Internal Medicine here at the University of Washington and at Fred Hutch. He did his undergrad in Pomona in California. He did all of his training in California, Pomona, and then he did his medical school at University of California in San Diego. He did not like the sun, so he moved a little bit more north to San Francisco, and that was still too much sun. So he did his residency and fellowship in San Francisco, and he was like, no, that's still too much sun. Let's come up higher. And so now he started his first job here quite a few years ago now at the Hutch. His focus is on melanoma, both in the skin and in the eyes, as well as other skin tumors. And I have heard that he plays basketball, but he has never invited me. And I'm looking forward to the day that I can play against him. So without further ado, Dr. Hall.
Well, that was a warm introduction. Thank you, Andrew. And it's great to be here. I just want to echo some of the sentiments that have been shared. This is really inspiring as someone who's involved in the care of patients with uveal melanoma to see the turnout in person on a Saturday as the weather's getting nicer, and to see the turnout online as well. So thank you all for spending a precious weekend day with us. So we're going to shift and talk about systemic therapy. So medical therapies for ocular melanoma. Yeah, I think as a kind of preliminary introduction, we can just talk about what types of systemic cancer therapy we use. These are names that get thrown around a lot, but sometimes we don't define them well, and it can be confusing. So our kind of original systemic cancer therapy, long-lasting, that we call chemotherapy. And these are basically carefully dosed poisons that are toxic to growing cells. And there's nothing really specific about them in terms of honing or targeting that toxin to cancer. They take advantage of the fact that when cells are growing and dividing, they're vulnerable to injury, and they injure rapidly growing cells, of which cancer is usually the most rapidly growing cell in the body, but other cells like hair and in the gut also are rapidly growing. And that's why we get some side effects like hair loss and nausea and things like that. So that's kind of traditional chemotherapy, which we will talk about some. Next, we have what we call targeted therapies. And these are often oral medicines, not always, but these are really targeting some specific pathway that cancer cells are using to grow. And these are pathways that our normal cells also use, but these are very specific targets that we think the cancer cells are preferentially using as part of their uncontrolled growth mechanism. We have immunotherapy, or what we'll often, for today, we'll talk about as immune checkpoint inhibitors. And these are intravenous medications that have a unique impact on our immune system and broadly stimulate the immune system, with the hopes that with a little extra nudge, the immune system can then engage the cancer and fight the cancer, just like your immune system would fight a virus or a bacteria. So totally different, and these are intravenous, and these are relatively recent developments in the last 10 years or so. And then lastly, as it pertains to our rare disease that we're discussing today, a new type of immunotherapy called an ImmTAC, of which tebentafusp is the FDA-approved drug, this is a new way of trying to engage the immune system and the uveal melanoma cell, and we'll talk about how that works. So these are all different types of systemic therapy that we might encounter treating metastatic uveal melanoma. So a common question that I get in clinic when we're meeting people, and I've appreciated the slides that kind of describe the many steps in a patient's journey and the many visits and different physicians that people meet, is I'll usually meet people after they have had protons or surgery or plaque therapy. And one common question is, what can I do now to reduce the risk of a future problem? And on cancer medicine, what we call that is adjuvant therapy. And we do this in a lot of cancers. We do it in breast cancer. Most commonly, patients with colon cancer or lung cancer might get
treatment after surgery to improve long-term cure rates and reduce the risk of recurrence. And so the question we often encounter in clinic is, what about for uveal melanoma? What can we do for that? And so this is describing a treatment point in the journey after surgery or radiation, where we would consider doing additional treatment to improve outcomes. This has been challenging in this disease. So there are a number of studies, which I unfortunately can summarize as saying nothing has been shown to be highly effective and beneficial for large groups of patients to reduce their risk of recurrence. And chemotherapy has been examined, targeted therapies have been examined, and immune stimulating therapies have been examined. And so far, none of these have shown conclusive benefit. And they all have a lot of potential for toxicity. And we give these drugs in other situations in our cancer center. And so in the absence of a clear benefit and with known side effects and toxicities, these are not standard. There are some ongoing studies that have been nationwide that we're waiting to hear back on. So this slide may get updated in the next year or two. That would be wonderful. But for right now, the standard is not to use adjuvant systemic therapy for this disease. So the other setting where we think about using medicine is at the time of metastasis. So on the timeline, some length of time after surgery or radiation, usually there can be a recurrence in another place of the body, and that's what we would call metastasis. And unfortunately, this is not an uncommon development for patients with ocular melanoma. So most estimates suggest somewhere between 40 and 50% of patients who have this diagnosis at some point in their life may be at risk of experiencing metastasis. And it's an unusual pattern, as I've discussed with many familiar faces in clinic. It tends to involve the liver in almost all cases, and then it often can involve other organs, but the majority of patients have liver metastases. It's usually after the treatment that people have received with their ophthalmologist and radiation team. So it's very uncommon. Maybe 1 out of 50 patients actually has evidence of spread at the time that the tumor is diagnosed in the eye, but this is usually a late event, often many years after treatment of the eye tumor. So just to tee up the following speaker, there are a couple different types of medical therapy that we would use. I'm going to be talking about systemic therapy, which are really full body treatments given either intravenously or by mouth that go throughout the body. And then there's also what's called liver-directed therapy, which we'll be hearing about more from Dr. Monsky, who's an expert in this treatment. But this is generally given into the blood supply that feeds the liver and has an effect specifically on liver metastases, which is a major problem for patients with metastatic uveal melanoma. So the past, we can, again, somewhat disappointingly summarize the past in a single slide, which is a lot of studies have been done using chemotherapy, which was kind of our original tool for medicine for cancer, and a number of different targeted therapies. And unfortunately, the results have been disappointing. In these large studies of dozens and hundreds of patients summed together, very rarely did the medicine seem to have a clear effect on shrinking the tumors. That's kind of our first sense of, is this treatment having an effect on the cancer? Do we see cancer shrinkage after these drugs are administered? Just kind of like we saw on the eye photos where we look at the tumors after they've had radiation and we can see them shrinking. We want to know, is the cancer shrinking? And unfortunately, cancer shrinkage with any of our prior therapies has been fairly rare occurrence. And even in patients where the medicine seemed to control or stabilize the cancer, that tended to be a very short-term effect, where long-term cancer control has been quite rare. So that brings us to the present. And really in the last year or so, we have this whole new part of the talk. So tebentafusp is the first FDA-approved treatment for metastatic uveal or ocular melanoma, and it was approved only a little over a year ago. And so this is a really interesting medicine. This is an entirely new class of medicine. And I think it's worth kind of trying to break down how this works. On the bottom of this schematic is your T cell. This is kind of one of the warriors of your immune system, searches out, destroys cells that are infected with viruses, bacteria, or other pathogens. And what we like to try to turn on against cancer. And on the top of this schematic is the melanoma cell. And it's been known for some time through the results of many of the basic scientific studies that Dr. Stacey alluded to, that the surface of melanoma cells have unique features. And there can be certain targets present for our immune system. And what makes this drug unique is that it's actually looking at a target, this blue dot, which is a protein called GP100. That's not incredibly relevant in terms of needing to remember that, but it's a target from the cancer cell that's presented in kind of a barcode of our immune system, which is called an HLA. And I'm going to show another slide on that in a second. This is the first medicine that has worked this way in solid cancers. And so it's really, the medicine is the orange here, and it brings together T cells on one end, it sticks to a T cell, and then sticks to a melanoma cell through this very sophisticated mechanism, and brings them together in a way that we hope will activate the T cell and get the T cell to attack the cancer cell. So this is really quite an exciting development for the field and a completely new form of immunotherapy that's different than some of the other forms that you might hear about for other types of cancer treatment. So a little bit about this HLA. These are inherited parts of our immune system, and it kind of relates to how we show and tell different targets to our immune system. And so these are things that you inherit from your parents. What types of these HLAs you have are inherited. And these are really crucial and foundational parts of our immune system. And there are many different types. So we all have different HLAs, and we all present targets to our immune systems differently. And just like a barcode or a QR code, their subtle differences can totally change everything. And so this is very important in immune function. And it's also kind of commonly referred to when people say, you know, I found a match for something like a bone marrow transplant. What they're talking about is that someone else has the same HLA as them. So this is like a very integral, fundamental part of our immune system, but it's kind of confusing. The challenge is that the way that tebentafusp works is this interaction with the blue dot, the target, embedded in an HLA complex. And so this is such a unique barcode that patients, in order to benefit from this medicine, have to have the correct HLA complex for this kind of barcode scanner interaction to function properly. And so the medicine is only believed to be effective for people that have what's called HLA-A2, which is not everybody, and it's something that's only determined genetically. There's nothing we can do about it. You either have it or you don't, which is, again, a completely new facet of this medicine that no other cancer treatment that we use for solid tumor oncology has. So this is really a paradigm shift. So just a bit about tebentafusp. This was an interesting study, a huge effort. So about 400 patients enrolled across 15 countries at 56 different cancer centers. So this is what it takes to bring a drug onto the market and to show if it's effective or not, a huge effort internationally. And patients were randomly assigned to have either tebentafusp or a number of other treatments, some of which were immunotherapies like pembrolizumab or ipilimumab, and some of which was chemotherapy like dacarbazine. And the physician who was treating those patients decided which treatment they thought was most appropriate, if that's the treatment patients were assigned. And then notably, because of how tebentafusp works, you had to have the right genetic barcode in terms of your HLA to participate. And this is one of the most common, but it only makes up about half of patients. So some patients who didn't have that inherited barcode, so to speak, were not eligible for this study. And it's about 50% of patients in European ancestry, but is somewhat less common in most other groups. So this applies to a significant but not universal set of patients. And what was seen and what was remarkable was that patients who received tebentafusp lived longer than those who received the other treatment. And this was a pretty striking difference. On average, 6 months longer. And I think what you can see is on the bottom of the graph is the amount of time since starting tebentafusp treatment. And on the top is the probability of being alive, starting at 100% and dropping. And what you can see is rates even out to 2 years of a significant proportion of people being alive from ocular melanoma, when we know that historically this has been a very serious disease once it recurs. So this is encouraging, and it's the first time ever that a treatment compared to another treatment has shown a significant benefit. And I think this is a tremendous breakthrough for the field. What's interesting about this drug is that some of the other things we usually go along with this, we didn't see. So I just talked about how our prior studies with chemotherapy, we didn't see tumors shrink very often. And actually, we didn't see tumors shrink all that often on the study of tebentafusp, which is surprising. Only 9% of patients had a significant tumor shrinkage, which we define somewhat arbitrarily as a 30% shrinkage of their tumors. But yet patients who received the drug lived longer, and that was clear. So this kind of somewhat disrupts the way oncologists think about things, which is that cancer treatments for metastatic disease shrink the tumors, delay the time until the cancer grows, and that results in prolonging of life. Well, in this case, life was prolonged, but the tumors didn't shrink, which is just kind of an interesting thing that we're still trying to understand. This treatment is not without its side effects. So patients can have fevers from the immune system being activated, sometimes associated with low blood pressure, and other side effects like rash and itching, and sometimes liver function test abnormalities. And it's given once a week. So it's a very intensive treatment. And the first 3 doses, because of the risk of fevers, are actually given in a hospital setting overnight. So it's a remarkable breakthrough, but it's also pretty rigorous treatment for people to go on, and is very involved and requires a lot of patient time and effort and medical resources. So about half of patients of European ancestry might be candidates for treatment with tebentafusp, but that means half won't. And we know that many patients who receive tebentafusp need to go on to need other treatments. So what is the current state of what we're doing for other patients? And we fall back on what are called immune checkpoint inhibitors. And this is a different type of immunotherapy that we mentioned at the beginning. And in this treatment, these are medicines that broadly activate the immune system. And so on the left, what you'll see is a schematic of a T cell, our immune warrior cell, fighting a tumor cell or encountering a tumor cell. And our immune cells are always circulating through our body, touching things and trying to determine if there's something in our body that doesn't belong and eradicating it. And so there's all these handshakes happening throughout the body. And in the schematic, this is depicted here. And so in this case, a cancer cell has kind of stuck onto or shaken hands with the tumor cell. But there are a variety of suppressive handshakes. Or I like to think about, is anyone Star Wars? Anybody? So kind of like the first original Star Wars, when Obi-Wan Kenobi is like, don't worry about it, there's nothing to see here, and then the stormtroopers wander off. It's basically, this interaction here is basically saying, don't worry about it, leave it alone. This is a suppressive interaction that happens naturally in our immune system. And there's good reasons for this. This is how we prevent things like our body's immune system irritating normal parts of our body and causing autoimmune diseases. But in the context of cancer, this is a T cell that might be ready to attack the cancer, but there's this suppressive interaction, the second handshake that's happening that's turning it off. And so a variety of immunotherapies have been developed to block this suppressive interaction and help give the immune cell a better chance of recognizing the cancer as abnormal and attacking it. And so these are drugs with names like pembrolizumab or Keytruda, nivolumab or Opdivo. There's things that are on TV all the time because this is not specific to melanoma, not specific to ocular melanoma. This is a universal cancer phenomenon where in some patients and some cancer types, the immune system can attack the cancer directly. And so that's how these drugs are working. They're working by blocking some of these suppressive impacts and helping give the immune system a better chance to recognize the cancer cell and to kill it. Another drug, here we go. Oh yeah. Another drug that works a little differently is a drug called ipilimumab, which actually works by our T cells have to get trained. The immune system is really fascinating. When I was in medical school, I don't know, I was at 15 years ago, we didn't even really understand it. Most of what I'm showing you today is stuff that's been learned in the last 10 to 15 years. But the T cells have to be trained on what to look out for and what to kind of be activated by. And so a drug called ipilimumab works at an earlier stage where cancer cells can either be stimulated and turn into active cancer cells, or they can be turned down. And this drug helps activate the immune cells and turn them into better cells that could hopefully fight cancer. So this is another medicine called ipilimumab that works this way. So for patients that don't have a treatment option like tebentafusp or who've tried it and perhaps have had their cancer grow despite treatment, many of them will be offered treatment with a combination of 2 of these immune stimulating treatments. And what we know about these treatments is that they are impactful for some patients, but it's not as many patients as we would hope. So there have been a couple large series of dozens of patients reported from MD Anderson in Spain. And what's noted is that there are patients who have significant tumor shrinkage. And most encouragingly, for those that get that, that can be a long-term phenomenon. So that's quite exciting. But this is a small number of patients. This is a 10, 15, 20%, not the 80 to 90% we would hope, or really 100% to have these great results. But these patients are out there. The challenge is these are pretty toxic medicines in some patients. And so going on them does expose patients to the risk of side effects, mainly from the body's own immune system, causing inflammation in normal tissues. And so there are patients that benefit, but there's a lot to do here about how do we find out who these patients are and give them this treatment, which can really help them, but avoid exposing people to serious side effects that aren't going to benefit from these treatments and find a better treatment for those patients. A word about the future and targeted therapy. So most melanomas have, most ocular melanomas have a mutation in a specific signaling pathway in the body. And this is in genes called GNAQ, GNA11, those are the most common, or these other genes nearby, cis-LTR2 and PLC beta. This is in almost every uveal melanoma, this is found. So it seems really important to how the cells become cancerous. It seems like it's really important to helping them grow. And so these mutations basically turn this cascade on. It's like a light switch that's flipped into the on position and doesn't turn off normally. And this triggers cells to proliferate, avoid dying, and go on and grow. So many of the pathways that Dr. Stacey talked about. And so now that we understand this, which has been a recent occurrence in the field, there have been attempts to use drugs that target various elements of this cascade. Maybe there's some way we can turn the light switch off by blocking a different part of this pathway. Initially, we tried blocking part of the pathway called MEK because we have approved drugs for other diseases that block that. And unfortunately, that was not as successful as we might have hoped. But currently, there's some pretty significant trials and pretty interesting results being seen for drugs that block these targets, PKC and FAK. And so this is where the field is moving. And the reason we're being able to identify this is because of an improved understanding of what's driving the cancer cells to grow and an improved scientific understanding, which is really exciting. So the present state of systemic therapy largely involves tebentafusp in combination immune checkpoint inhibitor therapy. But we know we need to do better than that. These drugs, we finally have drugs that seem to benefit some patients, but we need to find drugs that benefit more and that are less toxic. And I think that there is a lot of optimism in the field, and that's largely because we understand the biology better. So that's been a message that others have said, but we now have more rational and targeted therapies that are in development that might become our second and third FDA-approved drugs in the near future, hopefully, if they show good results. There's different types of immunotherapy that are being developed that we hope will work better for uveal melanoma. And there's also some growing work between synergizing the stuff I'm talking about and the stuff that you're about to hear next from Dr. Monsky, where we can use combinations of systemic treatment and liver treatment to hopefully get better results than either one on its own. So just in summary, there's no clear role for systemic therapy after treatment of the eye tumor right now. I hope that will change when we find something that is effective and safe. In the past, this tumor has proven to be stubborn. It's not been an easy cancer to find effective treatments for, but I think we're at the beginning of a new horizon. And tebentafusp is the first drug that proves that we can meaningfully change outcomes for people who have recurrence. And that's spurred a lot of interest. You know, I meet with a lot of companies that are developing drugs, and they're interested in this disease now because something has been shown to be helpful. It doesn't feel like an unconquerable problem anymore. And so I think it's a very exciting time. And I really think the key to this is understanding the biology better. The more we understand what's driving the cancer cells, what's making them resistant to our current treatments, the better we can design the next generation of treatments, test them, and see which ones are effective for patients. a brief add-on. So we're doing this research here at the Hutch. Within the last year, we've launched an effort to further our understanding of the biology of this disease. And so we have what we're calling our registry and tissue repository. And this is really an opportunity for patients, if they're interested, to get involved in research at our center. The goals are to aggregate data from patients we've seen and treated here to understand as much as we can about the disease, the epidemiology, and the trajectory and how patients respond to treatment. And then to collect biologic samples when available to help collaborate with our amazing immunologists here at Fred Hutch to understand more about the tumors and what drives them to grow and how to eventually develop better treatments. So this study is open to anyone who's been diagnosed and treated at our center. And this is, since we launched a little over a year ago, this is how we've explored, how it's taken off. So it started off back in the summer of 2021, and we've rapidly grown. We're over 30 patients. And if you're interested in this, reach out to me. Billy McCamey, who's our research coordinator, is actually here in attendance. Bill, you want to stand up and wave? And he has some information over lunch if people are interested in learning more. Totally optional, but I think it's a way to get involved. And you're going to hear about some other registries that are being done through some of the patient advocacy groups. And I would say, if you're interested, participate in all of them. It just helps drive the field forward. So with that, I'm going to finish, and I'm happy to take questions.
I'll start with one from the chat here, Dr. Hall. Is tebentafusp used for a recurrence of uveal melanoma or for metastatic cancers like liver cancer?
Yeah, so tebentafusp is approved for the treatment of uveal melanoma when it recurs in other places in the body. So its current use is for patients that have had growth of the uveal melanoma tumor cells in other places like the liver. That's a little different than liver cancer, which is a disease that starts in the liver. It wouldn't be used for that.
Ask another one from the chat. Do you share the blood data with OHSU? We'll make a plug that OHSU has their own biobank, though different, I think.
Yeah, our registry is set up to be collaborative. So one of the great parts about this event that's mentioned is it brings us together. And we are open to collaborating with any other institutions that are doing research or anything that we can do to help advance the field. So it's all done in a very strict way to protect patient privacy. That's object number one. But to the extent that we can share and collaborate, that's fundamental to how we're going to make a difference.
So I have a question for you with this whatever, how you pronounce it.
No, it's not an easy word to say.
So a patient of yours, and if they metastasize and they do have this correct gene mutation, would you automatically put them on this medicine?
It's a great question. So one thing is, the testing for that, which we've streamlined at our center, but a lot of people who are being followed around the country, this is not something most oncologists order routinely because of how unique it is to this medicine. It's honestly a test that mostly is ordered by bone marrow transplant doctors. But now we've all reminded ourselves about this part of the immune system and how to order the test to find out if our patients have the right type. So if anyone's having trouble with getting that test order, hears about it in a community, please let us know and we're happy to facilitate it because it is unusual. To answer your question, I think each patient scenario is different. And so if we discover a recurrence, we're going to evaluate all the options that are available to that patient. If tebentafusp is an option based upon their genetic composition, then that would certainly be one of the things we discuss, along with any other novel treatments, including liver-directed therapies, which you're going to hear about next. So it really is a case-by-case basis, but it's definitely in every conversation for people that have the right candidacy for it based upon their genetics.
So the clinical trial doctor that I did, he tested me for that. So he did it because he wanted to know. So, we already know. So that's why I was asking.
Yeah.
So
yeah. That is something that's happening more often. And, some people want to know if they're the right makeup for tebentafusp before they have a metastasis. That might, help them think about what would happen in the future. And we've been exploring that on a case-by-case basis. There's not currently a use for the drug until there's metastasis. So I think it's quite reasonable to wait to find out, but it's definitely something you should discuss with your oncologist. And it seems totally reasonable if you're a patient who's at high risk to find that information out in advance.
And so it's not a clinical trial. Since the FDA has approved it, you wouldn't have to be doing a trial.
That's right. You would not be a part of it. There might be a clinical trial where tebentafusp was combined with another medicine, but it can be given as a standard treatment. And since we activated tebentafusp, which was a few months after the approval, we've been treating about one patient every 1 to 2 months here, a new patient. So we've treated now 6 or 8 patients with standard tebentafusp at our center in the last 9 months.
The treatments you said for the tebentafusp was through, how, is it once a week? How many weeks are they on that for life?
That's a great question, one that we're still trying to determine. So usually in oncology, our practice is to continue a treatment for metastatic disease that's effective until it's either no longer showing signs of efficacy, meaning the cancer is clearly growing, or the patient's having significant side effects that we think makes it not appropriate to continue. So in the study of tebentafusp, some patients got it for a long time, for multiple years, if they were still continuing to benefit. So that's a great question. And I think that the verdict is still out on how much is the right amount. And it might be that it's a lot.
I have another question from the chat. A couple of questions here. A lot of interest in your talk, Dr. Hall. I'll try and combine them. How do you detect metastatic disease in the liver? Early disease is better, but I only get blood tests and MRI once a year. And other questions similar. What is the best way to detect metastasis? Yeah, that's a great question. So I think this may be something that will tie into Dr. Scallett's presentation, but usually metastasis is frequently detected by routine imaging that we do. And I think if you're followed for this disease, that's a discussion you have with your oncologist, and you come up with a schedule that balances lots of factors, one of which is your risk. Are you more or less likely to recur? If you're more likely based upon high risk features, we might do the scans more frequently. And then what type of scan? There's a lot of things that are considered reasonable. So MRI scans, CT scans are usually considered the preferred ways to detect cancer in the liver. But sometimes in certain patients, maybe ultrasound is a reasonable choice. There's a lot of variety there, but those are the types of imaging tests that we look at. It usually involves imaging. Blood work can be useful, but is usually going to show us something at a time that's more advanced than imaging.
Yes.
So if your scan shows metastasis, then is there a biopsy to confirm the type of cell?
Great question. So unlike Dr. Stacey, yes, the answer is in almost every case, we would like to understand that that is in fact what's happened. The reason is people can have masses for other reasons. It's always suspicious when someone who's had a history of ocular melanoma has a new liver mass, but there are rarely other things that can cause that. And we want to be sure of what it is before we start treatments that can have side effects. And it also has a real impact. I mean, obviously the onset of metastasis is a very serious event. I think balancing a lot of the hope for the future is that this is still a very serious life event if the cancer recurs. And so that's important to clarify as much as we can and to prove conclusively. So yes, for the vast majority of patients, if not all, we would attempt to do a biopsy if we were concerned about metastasis.
So Evan, first of all, I applaud you for putting in all the effort to get the biorepository going. I think it's a big step in the right direction because we want to be able to learn from each patient's unique story, unique specimens, and there's a lot of biology that needs to be learned. And there's a question in the chat related to that. If somebody is not a patient at Fred Hutch, can they still participate in your biorepository efforts and contribute to the science?
That's a great question. when we launched, so the short answer for that is we'd love to hear from you and get your contact information. The way it's currently set up is it's set up for patients from Fred Hutch and who have at least received care here or at UW at one point in time. But that's something we should definitely look to expand in the future.
We welcome any other questions because our next speaker is on a call about one of his patients outside right now.
Dr. Monsky is actually on call right now, and he's come while he's on call to give his talk. So
Can I ask you about tebentafusp?
Yeah.
So you said that many a times tumors are not shrinking, but so how do you determine for how long a patient is benefiting and to continue treatment for if you don't see tumor shrinkage or possible growth?
That's a great question. So I think if we've been following a patient and then we notice new findings, that suggests the cancer is growing because it means it wasn't there. We couldn't see it several months before. So I think if things have been growing and then they stabilize, that is a favorable impact that we think without the medicine, it would continue to grow. So I think stability is acceptable. We always get more excited when we can look and point to things and show patients things that are actually shrinking. But if things are stable, I think that suggests that tebentafusp is impacting the cancer. And so as long as things remain stable, I would consider that effective. And then there's lots of evolving science, including blood-based ways to check on cancer status that Dr. Scallett will kind of elaborate on, but ways we can try to detect cancer activity in the blood. And there may be another way for us to track that over time that's still kind of investigational, but there might be other ways in addition to our scans that help us identify who's benefiting from this treatment, who's not, because if you're not benefiting, we'd like to get you to try something else to see if it benefits you. And also it's a huge commitment. I think I don't want to downplay that every week coming in for an infusion for an indefinite length of time, that's really intense. There aren't a lot of cancer treatments we give that are that way. So we want to figure out who needs that and who's benefiting, and then figure out if it's not working for that patient, find something else.
Dr. Hall, I'd like to just make a comment. I'm on the registry. I was one of the early donors, so to speak. It was a blood test. It was very easy to do, but I want to tell about why I chose to do that, because I think for all of us, we have an obligation to the people that come after us and the people that'll be diagnosed in 3 years or 3 months or whenever. In 2007, I was diagnosed with colon cancer, normal, average colonoscopy, and it was a big tumor. I was treated with chemotherapy. I had the tumor removed by surgery. A year and a half later, it reoccurred in my liver. So first I was treated in Bellingham. Then I came to the University of Washington for my surgery, back to Bellingham for my treatment, my chemo. But what I know is that when I did the research about why the medicines I was given, why the surgeries, there were huge amounts of research that I, as a layperson, could get a hold of. I wanted to know, I wanted to understand. And I know that here I am many years later, like 15 and a half years later, because of the research that doctors were doing and patients were willing to participate in that process. So if you're willing to donate blood, if you're willing to be part of that for the future, I really urge you to participate. I have a granddaughter, an 8-year-old granddaughter with a freckle in her eye. I am terrified. And if I can do this for her, I will do it for your grandkids too.
I promise I didn't ask Mary to say that, but I'm really glad. I'm really glad you did. And I think, yeah, I think I couldn't have said it any differently. So.
Thank you, everybody. Thank you again, Dr. Hall. Here, I'll have you. If you ever get Dr. Hall and I mixed up for brothers, we are not offended. And it happens all the time. I'd like to introduce our next speaker, Dr. Wayne Monsky. Dr. Monsky is an interventional radiologist. So I know that the path of ocular uveal melanoma is a confusing one. Sometimes you meet a lot of doctors and a lot of things are going on. One of those groups of doctors are interventional radiologists. These are radiologists who have done extra training into doing interventions while using x-rays and other radiology techniques. Dr. Monsky did his undergraduate training at Syracuse, has an MD and a PhD from Georgetown, and then did his residency and fellowship at Harvard before moving out west. And as we mentioned before, he is on call right now. And so we really appreciate his ability to be here and talk to us about liver-directed therapies. Dr. Monsky.
First of all, thank you all for this fantastic program. And I really appreciate and feel for people that are going through what you all are going through. And this is a very tough path to take. And in general, about 30 years ago or more, it was clear to me, a lot of people don't know what interventional radiology is. And you were just told, so we do, it's called minimally invasive procedures. So it's kind of like surgery without surgery. And we get with our tools that we'll describe, catheters or needles into places without large surgeries. A majority of what I do is treatments for cancers that have spread to the liver. And we'll talk about how those treatments are done. And I treat the whole host of tumors, but metastatic ocular melanoma is a very, very difficult situation once it gets to the liver and elsewhere. And as we've heard, the therapies are certainly coming along, and there's fantastic things now and on the immediate horizon. And some of these things are toxic. And my passion for why we do this, and I'll describe what it is we do, is that when we give these agents through the veins, through the whole body, there's toxicities, and a small portion gets to the tumor. If we can get directly to the tumor by virtue of their blood supply, we can get larger doses into the tumor. It can penetrate better. My postdoctoral study has looked at kind of how drugs spread through the tumors, and we can get them to like move better through the tumor through tricks that we have that I'll describe, and we'll reduce the toxicities. I have no disclosures. So this is from a very, very important clinical trial that's initiated here with the thanks of Dr. Bhatia and others. And it's basically one of these agents that we're going to deliver intraarterially, and I'll talk about that and the other agents and how we approach this. But the thing that's really, it was mentioned and really important, is that 50% of people with ocular melanoma wind up having spread outside of the eye. So the tumor cells enter the bloodstream and travel to a place where they find hospitable, and particularly ocular melanoma, colon cancer, and some other cancers find the liver to be a really good site for seeding. So 90% of people that have metastatic ocular melanoma sometime wind up having liver tumors. It also can go, as we heard, to the skin, to the lungs, to the bones. And that's why it's a systemic or widespread. The cells are kind of everywhere and they can lodge in other places. So while I focus very, very much on treating things that are in the liver, it's important that systemic and other therapies are combined so that A, it's kind of synergistic or 1-2 punch, and B, it's taking care of tumors that are in other locations. So I don't know if you've probably seen scans but this is what we're dealing with. This is a CAT scan. MRI looks pretty much the same. I'm a radiologist, so I look at images and people say, what do my tumors look like? Well, when we look at it on a scan, we have the liver And these dark areas here are the tumors. These are metastatic melanoma tumors. They can be in the liver and they can be elsewhere, like the spleen here. And it's important to note that they're dark. So when we give contrast or a dye in your veins, things that have a lot of blood supply turn bright, and things that don't have a lot of blood supply, but some are darker. And if you'll note, and this is important when we talk about the clinical trial and how we deliver these tumors are kind of darker. So their blood supply in the liver isn't great. So whatever we give systemically in the veins, also it's kind of hard to get it into the tumor. We can kind of push it into the tumor right at the site. How do we do this? So we enter, so all these procedures, I'll show you a bit about that, are done under sedation, like if you had biopsies, or some people are familiar with cardiac catheterizations for heart disease. So go in, you'll be under sedation. We enter with a small needle in the groin, and that's it, instead of a surgery to remove things. And we have a spaghetti thin tube called the catheter. And that tube is fed up through the arteries up into the liver. And all you wind up is with a little incision about that big. We go up into the arteries, we use x-rays and dye, and we see what blood supply to the tumors is. And then with this spaghetti thin tube and our x-rays, we find out what arteries supply the tumor. And then we get as close to those arteries as we can, so we avoid getting these toxic agents to the rest of the liver. We want to get it really into the tumor at bigger doses, and try to avoid as much as we can injury to the rest of the liver, because these are still toxic agents. And then we inject those agents into the tumor, and then we follow it up with it's called an embolic. So it's a little bead or a little foam. And that does a couple of things. It starves the tumor, chokes off its nutrition and blood supply. It also traps the therapy in the tumor. And so it'll last in the tumor for, as opposed to when you get systemic therapy and you have to come every week or every couple of weeks for an infusion, we stuff the stuff into the tumor and it sits there for 7 to 21 days working. And then the tumor's breaking down, and this is important with these immune approaches. The tumor is breaking down because there's the blockage of the blood supply. And when the tumor breaks down, then it's noticed by the body as something foreign. I'll describe that in a minute. And so this is what the angio suite looks like if you haven't seen one. So the person is laying here. They're under some sedation here. This is a giant x-ray machine that kind of spins around you, and that's how we get these pictures of the tumor. And we see where our spaghetti thin catheter is going right up to the tumor. And your liver is divided into a right and left portion. There's an upper and lower portion to the right and left. These are the arteries to tumor, your liver rather, that we see with the angiography, the left side, the right side, and these branches. And these branches then supply the tumor. And so on a CAT scan, we have a tumor here, we have the catheter here, and a dye injected here, and tumor here. And we inject the agent as close as we can to the tumor. And the agent can be seen on X-ray or on CAT scan, and we see how it deposits in the tumor as a bright area. And then 6 weeks later, roughly, we get another scan. And while this was the tumor here, this is now a dead region in the liver. And so every 3 months, we'll get another scan and make sure. So we never take the tumor out. So we don't know if every single tumor cell is dead. So that's why it's important that every couple of months, usually 3, we're looking again to make sure nothing's coming back, that there's nothing new. If there is, then we, with some strategies, we could do these treatments again, and other strategies I'll describe in a second are kind of ongoing treatments. So I'm going to talk about what we call the current strategies. And there's basically 2 kind of divisions. There's the immunoembolizations, where we use the immunoagents, and I'll describe those, and you've heard a bit about them and how they work. And then there's chemoembolization. And in those, we use current chemotherapy, like was mentioned earlier, that are toxic. They're poisons, but they are effective against these tumors. And by getting it more in the tumor and less all over the body, there's much less toxicity than you may have heard or experienced with other chemotherapies. And again, we can inject that with this spaghetti thin catheter, and your blood flow actually kind of pushes it into the tumor in that current approach. All right. The clinical trial that we're going to talk about in a bit, and starting now, is called the Halasz trial. And it is with a new agent that I'll describe, and it's with a relatively new catheter injection strategy that about, I don't know, 15 years ago, I developed a similar catheter and brought it to market and had some very good effect. This is an iteration of that that's even better functioning. And what it does is it kind of opens up like a flange in the artery. And then with pressure, it drives the therapy into the tumor. So you get a much greater, so this is the agent distributed through the tumor, and you get much more of the tumor filled with the agent when we use this pressurized delivery system, as opposed to relying on your blood flow with each heartbeat to kind of push it into the tumor. So let's talk about the therapies a little bit.
Is that because the blood flow is blocked and you have control of the flow?
So very good question. So there's two aspects to that. So blood flow is about 20 millimeters mercury. Tumors have as a longer discussion, have low lymphatics, so they have high pressure, 40 millimeters mercury. It also like kind of pushes on those tiny little blood vessels that supply the tumor. When we open these flanges, we're injecting with kind of greater force than what your blood flow would be, 20 millimeters mercury. And so it kind of drives it in there, right, is one thing. And actually what happens is with you inject and these open up and drive it in, and then they collapse and the blood flow kind of pushes it. So it's a kind of a combined strategy. The other thing is when you have these pressure changes, so there's two blood supplies to the liver, the portal vein and the hepatic artery. And there's what it's called a sump. So it kind of the portal vein, when there's pressure in front of it, kind of draws the stuff into the tumor by this sumping phenomenon. And that's basically what the mechanisms are. So yeah, friends of mine tease me that we're the plumbers of the body. And I have a friend who's an electrophysiologist, and we say he's the electrician of the body. So it's all my orthopedics or carpentry. So it's all just the same stuff that we do. How does this all work? We've seen a good glimpse by Dr. Hall earlier and the earlier talks that I'm sorry I wasn't able to make. But so we're going to talk about first the immunoembolization, the current drug strategy that we're using. And these immunotherapies or immunoembolization approaches are all, like we heard, to gear up your own immune system. Like you know how to fight these tumors. You need a push, right? And it was, I don't know how many 50 or 40 years ago, I first read a book called The Transformed Cell. And it was really the beginning of IL-2 and T cell, all these immunotherapies. And I was blown away that we can, and it was just because they noticed that some people, like, their cancers just go away, and they said, why is that? And then they found it was like their immune system for some reason that was geared up. And so now we're here and we have fantastic agents that are gearing up our immune system, such as Sogramostim, which is what we use in current immunoembolization. And what that is a granulocyte macrophage colony stimulating factor. Don't make me say that 10 times fast. And what it does is it attracts. So there's a whole bunch of different immune cells that you have. Some of them are macrophages that eat foreign things in cancers, and some are granulocytes or dendritic cells that take the little pieces of the tumor and they present it to your T cells that we heard about. And then it activates those T cells. And then your T cells now know there's a foreign entity in your body, and they start attacking it. Now there's the handshake that we talked about, and there are mechanisms that cancers use or other cells use that stop that immune response. And that's why it's not uncommon that we'll use some of these other immunologics, such as ipilimumab or nivolumab, checkpoint inhibitors that also help in a different way. So it's all, like I said, like synergistic, it's working together. This does help to bring all those immune cells into the tumor. It does help them to attack the tumors. Now, the clinical trial, and this has been done since the current immunoembolization has been done since about 2009, described by Thomas Jefferson. We use their hospital, we use their protocol. There's very good literature we'll talk about in a little bit that suggests its efficacy. It's very well tolerated. The biggest issue is fatigue. About a third of the people feel kind of meh. A third of people feel like they have a bad flu. A third of people are pretty wiped out, even though we're directing it right into the tumor, because it kind of gears up your immune response. And in general, people who are wiped out to begin with are much more wiped out going into it. But if you're healthy, good performance status, we say, you're doing your regular stuff, most people tolerate this incredibly well. Usually there's an overnight admission to the hospital, but a lot of times once we do the first couple, people are like, I feel fine, I'm gonna go home. The clinical trial. So very, very important. Again, we need more of these agents. We need things that are going to be effective. And this clinical trial is, besides a quote unquote new infusion strategy, which I'm a great fan of, there is a new agent. And like we heard, more and more agents like tebentafusp, which I can't pronounce either. And one patient I was talking with said to me, I call it Tebi. I'm like, great, I like Tebi, I could say that. So anyway, so it's another agent that is right now called SD101. And it's another helper of the immune system. So it does two things. Again, there are cells that help the cancer to stop the immune response. And these particular ones are called myeloid-derived suppressor cells. And it kind of knocks them down. And then the other thing it does is it activates all the other immune cells, like your T cells, your natural killer cells, et cetera. And so it's kind of a multi faceted effort. So then there is so this is usually, these therapies are usually reserved with smaller disease burden. So if there's more, that is to say, like less tumors in the liver. If there's more than 50% of your liver has tumors, another strategy that's come out of Thomas Jefferson and more recently kind of investigated is the use of another chemotherapy that's used in a number of different cancers, like glioma, brain cancer, et cetera, called BCNU. And we do this in chemoembolization. So strategy is the same, except instead of an immunotherapy, we're injecting this chemotherapy. And they've shown, I'll show you the numbers, fair response with that. And that's the therapy they're describing. It works. It's called an alkylating agent. It's one of these poisons. It breaks down the DNA in the tumor cell, and then the cell dies. So one last that I'm not going to talk a little about, but it is in our armamentarium, and this is what I do. It's called radioembolization. It's what I do for almost every other tumor, and there's starting to be literature that it is important and useful, although right now it's kind of mixed, a mixed review for metastatic melanoma. And what it is, instead of chemotherapy or immunotherapy, it's radiation on tiny little beads that are the size of a grain of sand. And we'll inject like 1 to 3 million of these beads, and they emit radiation for about, I don't know, half a centimeter from where the bead is. And then that irradiates the tumor, much like you have the external beam radiation or proton therapy. So those are the different tools we have, and a little bit about how they work. So what does this involve to you? Like somebody asked, do you do this forever, every week, every day? I kind of want to, so that again, I'm going to talk about the clinical trial. I'm lost track of time. I'm going to talk about the clinical trial and then the immunotherapy. And when we do the clinical trial by Halasz, what it is one of these procedures that the first day of treatment, and then every week for 3 weeks. and then you get about a 6-week break, and then every week for 3 weeks. So it's a total treatment course of about 3 months, plus there'll be systemic therapy in your veins as well. And then in this approach, because we don't know a lot about this agent. That's why it's a clinical trial. There's initial studies that are showing it's effective. Right now, there's about 30 patients that have entered into this trial. There's not any much literature from that trial. And because we're trying to understand what happens, these biopsies and repositories that we mentioned are important. And so we get biopsies on the first day, the 57th day, and the 100th day to see where the agent is going and how the tumors are responding. So that's the clinical trial. What we do currently more of is the immunoembolization approach I described. And that's a longer set of procedures, but further spread apart. And so, like I said, there's a right and a left side of the liver. If we can't treat the whole liver at once with these therapies, so we would, if someone had tumors on the right and left side, we would treat the right side, and then one would come back 6 weeks later, and we treat the left side, right side, left side, right side, et cetera. And we do that every 4 to 6 weeks. So if it's both sides of the liver, it's 10 treatments every month or month and a half. So it's about 15 months of the immunoembolization every month, roughly. And then we switch by this protocol if there's still progression. So every 6 weeks to 3 months, depending, we get a scan and we see how the tumors are doing. And if they're growing after this point, we then switch to one chemotherapy, and then we switch to another chemotherapy. So how do these therapies do? So with the current chemoembolization, the literature from Thomas Jefferson and other places now, say that 32, so it's roughly a third, 32% of people have what we call a complete response, and that's based on the imaging. And tumors look like they're dead, or a partial response, and that's greater than 30% of the tumors are dead. In 30%, we have what's called stable disease, and that is to say, we can't tell if they're alive or dead, but they're not growing and they're not shrinking. And oftentimes, that's what's a little confusing about treating melanoma is, like we heard, these tumors don't like shrink away like other tumors. They kind of just stop, and so we keep an eye on them. And then the overall survival, if there's no response, is 14 months. But if we see that there is a response, this literature shows the overall survival to be at 34 months. And I never like these survival numbers because it's like all comers. So it could be someone with huge amounts of tumors, or it could be someone with a very small amount of tumors. And so it's hard to say what individual is on that spectrum, but this is what lots and lots of patients would suggest. At 1 year, 62% survival. At 3 years, 16% are survival. At 4 years, 11%, and at 6 years, 5% survival. And that's the current immunoembolization. Now, when there's greater than 50% of the liver involved, we use this chemotherapy called BCNU, and they're showing, so they're showing a median or average-ish of 7 months, a range of 1.2 months to 32 months. Again, we don't, every person is different, but that's the grouped data. And then 5 months to 1.2 to 32 months time until a tumor is progressive. And at 22% of these people with greater than 50% of their liver surviving past 12 months. So that's an overview of the different strategies that we use when the tumors enter the liver, and I'm open for questions.
Any questions for Dr. Monsky? One at the back.
I missed, what was the number of participants in this data? Do you have any information on that? Those last 3 slides?
Yeah, so there's a pooled or meta-analysis, which looked at several different studies. The first papers were about 35 patients. Now the latest studies are a pooled analysis at 754 patients.
And I have one. I'm looking at the pictures, the scary pictures of livers with lots of tumors in them. I'm about to start scanning and wondering, okay, if I'm going in every 4 to 6 months, do you see people with that many tumors when they're having regular scanning?
At times. So this is the issue with metastatic cancer in general is a lot of times it's silent. So there's no symptoms, there's no effects. And so people get, it's really, this is with other malignancies. If you're in a treatment course, you're getting regular scans, but it's not uncommon that someone will find out they fell, they got a CAT scan and they're like, there's something in your liver. And almost everybody I talk to, they don't, we always ask, do you have any pain? And no, like people don't even know, there. So it really depends when the diagnosis is. And I see people with one tumor, this big, and I'd say that's more the common situation is that there's a couple of 1, 2, 3 kind of tumors. It's very uncommon that there's widespread tumors. So, yeah.
And I can probably add to it, since we order most of the scans in our medical oncology clinics and we tend to see the results. This is a disease that likes to go to the liver and we focus on the liver for our imaging. I think the great thing about surveillance is that it does catch those tumors way before they would actually become obvious if we were to just rely on symptoms.
Right.
So we are catching tumors sometimes very small, like 4 or 5 millimeters. We can't even biopsy those. Dr. Hall talked about, like, we are never going to diagnose somebody that they have metastatic disease if we cannot do a biopsy confirmation. Many a times we catch those, they're too small to be even biopsied. And then, but at least we are aware that maybe there's a problem. We can give it more time. We can let them get a little bit bigger, then do a biopsy. But almost never we see a situation where, let's say we do a scan once a year and the tumors have just grown uncontrollably big. That would be a very uncommon situation. I would not rule that out, but the odds of that happening are very low. So we feel reassured that we are not going to lose control if we do regular surveillance, even if it is at once a year interval.
But yeah, it's very uncommon that there's widespread tumors like that. And really it's so important, surveillance. I mean, the key to all of this is catching stuff early. And then we have a much better, rate of taking care of things.
Yeah. And one other thing I want to say is knowing the limitations of our systemic therapies that we as medical oncologists use. Dr. Hall summarized those really well. Chemotherapies, immunotherapies, they can work, but the chances of success are so low. And I feel like the biggest difference that we make in improving the survival of our patients at this time, at least, is through what Dr. Monsky does for our patients. The procedures are very labor intensive. They're very complicated. He is not a plumber. If he's a plumber, he's a very skilled plumber. And I think those, and he showed how many times it takes to get control. You treat one lobe of the liver. Liver has many segments. You treat one side, you treat the other side, then go back and forth, assess the responses. Sometimes he uses immunotherapy. Sometimes he uses chemotherapy. So it's very complicated. But I feel like that is what makes the biggest difference. Now we need to take it to the next level. We need to combine it with our systemic therapies. And those are the efforts that we are engaged in right now.
Thank you.
Thank you, Dr. Monsky. We're going to have to move along, but we'll answer any other questions after the next session. It's my pleasure to introduce our special guest here, who's not a physician here at the University of Washington, but is a physician at OHSU in Portland. When we were planning this meeting, maybe we were thinking when it was 11 and everybody wanted to get to lunch, we should invite somebody really exciting to come and talk to us. But our guest is Dr. Allison Scallett. So Dr. Allison Scallett is an ophthalmologist. She does what I do, but down in Portland. She did her undergraduate training in Tulane, and then she did an MD and a PhD at Penn in Philadelphia. She went to her residency in ophthalmology at UCSF in San Francisco. And then she did a fellowship in eye cancer and pathology at Oregon Health Sciences University in Portland. She is a fantastic physician. She's a patient advocate. I know that because I share patients with her and they all love her. And she's also a friend. And when I came up here, she's a big reason why I've been able to have a successful program here. We are the only two programs like this in really north of San Francisco and west of Mayo Clinic. So there's just the two of us, and she's been a great asset to us. So everything that we have here, we owe some of that to Dr. Scallett. She was a big part of helping develop our Proton program as well, which happened before I got here. She is going to talk to us a little bit about detecting metastatic disease and some new insights into that role. So Dr. Scallett, welcome.
Hi, everyone. Thank you so much. It's really a pleasure to be here. So as Dr. Stacey said, I'm based in Portland. We also have a beautiful mountain that comes out every now and again when the weather permits. But I also share a joint appointment here at UW related to the Proton Center, and helping to develop that program in ocular melanoma treatment is one of the things I feel the best about, because this is back before Dr. Halasz was here, before Dr. Stacey was here. I'm like aging myself prematurely now, but when Dr. Rengen, who heads the radiation oncology group here, invited me up to start developing this program, I thought it was an amazing opportunity for patients in our region. And it's just fantastic to see where you guys have taken it. And I think there's going to be a lot of really important research coming out of the center here that's going to help patients around the country at these other Proton centers. I have a few disclosures. I'm a consultant for Castle Biosciences, and they're the company that does the gene expression profile testing, PRAME testing, mutational testing that I'll talk about today. They don't pay me nearly enough to tell you guys anything that's not true, but it's important to know that. I also consult for a group called Immunocore, which of course produces the tebentafusp. Although I won't talk much about that today. So it's truly a pleasure to be here at the Hutch. The Fred Hutchinson Cancer Center is a really important scientific center. As you guys saw, walk in, 3 Nobel laureates. And it's really been an important research center for cancer. And the first time I heard about the Fred Hutchinson Cancer Center was when I was an undergraduate student in New Orleans, and I was interested in medicine. I was interested in scientific research, and I was looking for internships. And I recall applying for an internship here at the Hutch. I did not receive it. And so I'm really delighted to be invited now, victory. But I had enough things go my way that I ended up here eventually. So I was really touched by some of the mission statement when I was looking up the Fred Hutchinson Cancer Center yesterday, and this concept that they were driven by the urgency of our patients, the hope of our community, and our passion for discovery to pursue scientific breakthroughs. And I think that that's something that all of the speakers have really touched on a bit, is that we are very much impacted by our relationship with our patients, by seeing patients every day who we feel that we're helping the best we can, but we'd love to do better. And I think the participation of the patients in our research and in inspiring us to do better is really moving the field forward. So you guys have seen this diagram a few times now, and not to beat a dead horse here, but uveal melanoma can affect multiple areas of the eye. This sort of inner lining of the eye, the peanut butter in the sandwich, we might call it. I'm going to focus on these posterior tumors, the ciliary body tumors and the choroidal tumors that are the aggressive high-risk uveal melanomas that are likely to spread. Let's see if I can get this to work. Dr. Stacey talked a lot about primary treatment of the uveal melanoma. That is, how do we treat the eye itself? And we can enucleate, surgically remove the eye. We can irradiate. We have both plaque therapy, which is an excellent therapy, and it's the most widely used therapy, as well as proton beam radiotherapy here available in the Pacific Northwest. And the way that Dr. Stacey and I decide which type of treatment to do for patients really comes down to the size and the location of the tumor, what patients prefer. And it's great. We're one of the only regions really where we have full availability of either type of treatment. They're both really effective. Dr. Stacey talked a bit about these trends in uveal melanoma, and there's large databases, national databases that we can look at, and groups like Arun Singh's have, who's based in Cleveland, have shown us that this incidence of uveal melanoma in the US has remained stable for decades. It's about 5.5, 6 people per million per year that develop uveal melanoma. We've seen that the trends in treatment have really changed over time. Initially, we were enucleating everybody. This is before my time even. But starting in the 1980s, we started treating with radiation treatment. And now that's the most common way that we treat melanomas in the eye. But unfortunately, survival has really not been impacted in many decades. And hopefully that's starting to change. But this, I think, is really, even though Dr. Stacey and I are ophthalmologists, we're focused on eyes, we're focused on vision, this is the most important problem, I think, for patients with uveal melanoma, and really has been the focus of my research. Why is this? It's because successful treatment of the tumor in the eye does not mean we have a patient that survives. And this is probably related to the microscopic spread of melanoma before we even meet our patients and diagnose the tumor. Uveal melanoma spreads through the bloodstream. We have cells that escape from the eye, they get into our blood vessels, they can transit around the body, and then they find places where they can successfully survive, usually remaining dormant for months, years, even decades. These micrometastases are so tiny that they are microscopic. We can't see them on any kind of current blood test. We can't see them on MRIs or ultrasounds or CT scans because they're too small. Tumors need to grow to at least a few millimeters in size to be detectable. And here we're seeing work by Hans Grosniklaus, who's out of Emory, looking at liver sections, pathologic sections, where we can see tiny little deposits of melanoma cells inside of the liver. And these are the problem. Oftentimes, they're just remaining very stable and dormant. When they're staining with a way that we can look for cell division, we don't see much happening there. But then something happens to trigger growth of these tiny little deposits of cells. And that's when we run into problems and we start to have tumors grow. Dr. Hall or Dr. Bhatia will notice them on the scans, and then we're really off to the races trying to find a good way to treat this metastatic disease. As this audience is very familiar with, after treatment of the eye, patients undergo surveillance imaging, and the frequency of that testing and what specific type of test is done is going to vary based upon your preference, your doctor's preference, how risky we think it is for you to develop metastatic disease. We focus on the liver because more than 90% of the time, that's the first place we see this develop. But often we're looking at the lungs as well. This means that patients, after successful treatment of their tumor, are going in and out of the scanner, usually multiple times a year for up to 10 years after treatment. And that comes at a considerable cost, both financially and emotionally. Everyone knows this situation where you get very anxious before you come in for your scans until you find out that things still look okay. Currently, it's nearly impossible for us to tell who's going to be a really happy patient with a durable cure after we treat the eye tumor versus someone who's going to develop liver metastatic disease. And this is where prognostic testing or predictive testing really comes in. There are two ways I'm going to talk about today where we can learn more about which patients we need to be really worried about, who should be wearing a t-shirt with a warning sign for us. Fine needle biopsies, and that's the thing that we've heard a lot about, these biopsy-based or tissue-based techniques, as well as non-invasive testing, something we call liquid biopsy that I'll talk about. These are ways that we are starting to be able to identify the patients that are at highest risk for disease spread. And it's really important that we identify these patients because we can then study this population to see if treatments like the adjuvant treatments Dr. Hall was talking about may help prevent disease, because the holy grail really is that we treat the eye and then, well, actually we can get even better than that. But one really, really important advance would be if we treat our eye using the usual techniques, radiation or enucleation, and we identify patients that are very likely to develop metastatic disease, and then we offer them a treatment that's going to prevent that from happening. There is also some hope, and there's going to be a clinical trial soon where we may be even able to take it a step further, where we actually can treat patients potentially with a medication to shrink the tumor in the eye. That's called neoadjuvant treatment before we actually do definitive treatment for the eye. And I guess that would maybe put Dr. Stacey and I sort of out of jobs, but we'd be really happy about it, because if we can diagnose you and say, this is a melanoma we need to treat, we send you to Dr. Bhatia and Dr. Hall, they give you some kind of magic treatment to shrink that tumor in the eye. Maybe we don't even need to treat it. Maybe we treat it with less radiation. And then we prevent the disease from spreading. I mean, that is a home run. That would be really great. That's true, we do. And that's a good eye joke. There's so many of these. We'll just give it a shot, you know? And it comes out and I'm just like, oh no, that's really bad. But my dad is proud. So there is a lot of really exciting stuff happening, but really for all of this, all of these advances, they really require us to be able to very specifically know which patients are at risk, because we don't want to treat everybody, because every treatment, as we've talked about, has risks. And we don't want to study everybody, because when we do so, we might be missing the patients in whom a particular treatment may actually be working, because it gets diluted out and we're not noticing an effect. So the research update I'm going to provide today, focusing on predicting the spread of uveal melanoma, is going to focus on two specific things. One is PRAME expression, and you guys may be already familiar with this because the Castle reports, when Dr. Stacey's doing biopsies for you, they come with that PRAME information, and they have for a couple of years. But we are learning a lot more about what that might mean. And those reports are probably going to be changing in the next year or so. And then I'll also be talking about a novel cell population called circulating hybrid cells, which is an area of research that we've been doing down in Portland at OHSU. So again, you all are familiar with this, but this is my schematic to just show sort of the timeline for what happens. So for a patient with uveal melanoma, you're diagnosed with a tumor in the eye. We do some type of surgery for you, whether that's putting on tantalum marker clips for proton therapy, putting in a plaque, removing your eye, and your eye tumor is treated. But then we send you over to the medical oncologist. You undergo a series of surveillance imaging testing. And then unfortunately, up to 50% of patients will develop liver metastatic disease. And then we try to provide some type of treatment. There are actually two sort of trajectories for patients with metastatic disease. Some patients have a pretty slow course and a fairly long survival with metastatic disease. Some patients have, unfortunately, a very, very aggressive, fast decline with metastatic disease. And until tebentafusp, but we haven't had a particular systemic treatment that's been very successful. Hopefully that's changing. Liver-directed therapy for my patients has actually been, in some cases, very, very impressive. We actually use more Y90 radioembolization down in Portland than the chemotherapy or immunotherapy techniques. But regardless, I think that we can all agree we need to improve those treatments. As we've already kind of talked about. For all patients with uveal melanoma, we can risk stratify just based on the size and the location of the tumor. This is something we call TNM staging or tumor node metastasis staging. We do it for all cancers. And the way that we do this for uveal melanoma, or the factors that matter, are the largest basal dimension of the tumor, kind of how wide is it, and how tall is it? What's the height of the tumor? And Dr. Stacey showed you some of this earlier today, but the smallest tumors are called T1 tumors. The largest tumors are T4 tumors. And then we take into account, does the ciliary body have any involvement? Is there extrascleral extension of the tumor? And then, of course, is there any obvious sign of metastatic disease at the time of diagnosis? And that's a very rare situation, as Dr. Hall talked about. But this essentially puts people in various categories, what we call stage 1 through 3 disease for most patients. And there have been several retrospective studies, meaning looking back in time to see how did patients do when they had a certain stage of their disease. And we do see that there's differentiation of risk for metastases based upon these stages. And this is data that came out in 2015 from a group that was an international group, this ophthalmic oncology task force, where we see that the patients who have stage 1 disease have a lower risk for developing metastases. These patients are falling off the curve as they develop metastases. So stage 1 disease as compared to the highest stage 3 disease patients, we see there's definitely a difference. So we can risk stratify everybody who comes to see us with this AJCC staging. And it's a good general way for us to tell what your risk is, but it's not as specific or as predictive as the molecular type testing that we can do based on biopsies. Tissue-based molecular testing can look at things like chromosomal status. It can look at the gene expression profile, PRAME, or preferential antigen and melanoma. And it can look at the mutations inside of the tumors. But all of these require either an enucleated eye that we can test or a needle biopsy. There's an important study that you guys, I think, would benefit from knowing about. It's called the TCGA, or the Cancer Genome Atlas study. And this is actually a very large study where they have specimens from all different kinds of cancers. Uveal melanoma is a really interesting one because it's the least immunologically infiltrated or involved cancer of all of the cancer types. And this is why the immunotherapy has been so difficult for uveal melanoma. We've learned a lot about uveal melanoma with this study. It involves 80 eyes that have been studied, and a group has published relatively recently looking at risk categorization based on what we call TCGA staging. And there's 4 different groups that patients fall into based on the chromosomal copy number, the most important one being chromosome 3, mutational status, and various things having to do with the DNA that are a little bit complicated for today's talk. The other thing, or main way that we are looking at this, and the most common way that we molecularly predict risk in the US, is using gene expression profile testing. So many of you are familiar with this. This is a way that we're looking at the RNA expression in the cells that are obtained through a biopsy, most typically, and there are 12 discriminant genes. We then get a report that tells us it's either a class 1 or a class 2 tumor, with class 1 tumors being low risk for spread, class 2 tumors being higher risk for spread. In prospective studies, this is the only one that's been sort of in a forward way prospectively validated as a predictive test. We see that it's highly predictive for who's going to develop metastases, although it's not definitive. And that's really important. So if you get a report and you see that you're a class 2 patient, that doesn't mean you're going to develop liver metastatic disease. And I have many patients who are class 2 patients who do well. And I also have patients that are class 1, class 1A, if we start really differentiating things, who then develop metastases. You know, we thought you were free and clear, but unfortunately, it's not a get out of jail ticket to have that result. But it is predictive, and it can help us, or specifically help the medical oncologist decide how to follow you. Gene expression profile has been shown to be more predictive than things like chromosomal testing. And thankfully, it's available to us in the US. It's not available outside of the US, and that's a really important thing to know about. So the first thing I'm going to talk about is work being done by the Collaborative Ocular Oncology Group. And this is a study called the COOG-2 study that we think is, we're likely to be submitting the first paper and much of this data in the next month or so. I'm among the leadership group for the COOG, which involves both ocular oncologists and medical oncologists interested in uveal melanoma. We have 25 centers that were involved in this collaborative study, which was funded by the NIH. And the goal for this was to optimize precision medicine for patients in uveal melanoma by prospectively validating an integrated prognostic test. This is the gene expression profile, PRAME. We're really focused on PRAME with this particular study, and then the targeted sequencing, which shows us mutations. So it's important to understand the molecular biology of uveal melanoma to understand this study. And we've had a really good overview, so thank you so much to everyone who came before me to explain this so nicely. We have these melanocytes, these pigmented cells in the uvea that undergo a primary driver mutation, we call it, and it's one of these 4 typically, GNAQ and GNA11 being the most common mutations. And what happens for the vast majority of these cells is that they grow into a benign choroidal nevus, or a mole in the eye. That primary driver mutation is necessary for developing a nevus. A very small percentage go on to develop additional secondary driver mutations. And this is all that's needed. Yes, we can have multiple additional mutations develop, but really for uveal melanoma, you need 2 mutations. You need your primary driver mutation, and then you need a secondary mutation to either develop into a low risk tumor, what we call class 1 uveal melanoma, and most are in that category, or a high risk class 2 tumor. And those tumors typically have what we call BAP1 mutations. What we're going to focus on today is PRAME, this preferentially expressed antigen in melanoma, and how that modifies your risk if you are a class 1 or a class 2 patient. Class 1 patients that are PRAME negative, we're finding have the lowest risk for spread, and class 2 patients who are PRAME positive have the highest risk for spread. So this work was initially developed by Bill Harbor's group. He's moved around a few times now. He's at UT Southwestern now. But this work was initially from, I think, his WashU days, where they found that melanomas, these uveal melanomas, clustered into 2 main groups based on what we call gene expression profile testing. And this is looking at the RNA expression from melanoma cells. And they found that the class 1 patients did not develop metastases nearly as often as the class 2 patients. And it was a very striking result. Long-term follow-up, however, revealed that there was a subgroup of these class 1 patients that did over time, and there was a longer period of time that they did well, but they did develop metastatic disease. And so this was very interesting. And what the group found is that they were different from the class 2 patients who developed metastases. They didn't tend to have the BAP1 mutations. They often were younger patients. They were less prone to having it develop first in the liver, and we would maybe more commonly see it in the lungs or in lymph nodes as an initial presentation. And they tended to live longer with metastases. So there's something different about these patients. And when they started to look again at what was the difference in the RNA being expressed by these class 1 patients that metastasized versus class 1 patients that did not, there was a gene called PRAME that became apparent as being really different between these 2 groups. PRAME is a nuclear receptor transcriptional regulator that's expressed in cancer cells, but it's not expressed in normal tissue except in the testes, where there's DNA recombination happening for reproductive reasons. PRAME is associated with poor outcome in many different cancer types, and it's actually a therapeutic target. Because of this, they're developing drugs against PRAME, which I think is hopefully going to be biologically relevant for patients with uveal melanoma. We see that both in uveal melanoma and in cutaneous melanoma, and this is again TCGA study data, PRAME appears to be important. And in early studies, small data sets, Dr. Harber's group showed that PRAME increased the risk of metastasis in both class 1 uveal melanomas as well as in class 2 uveal melanomas. So again, the COOP2 study is a large national study that's supported by the National Cancer Institute. Our 25 centers in 3 years recruited more than 1,700 patients. So it's a much, much larger study than most others in uveal melanoma. And what was done for all participants is that they either had their eye removed or they had a single needle biopsy, the way we would do in a standard way with Dr. Stacey or myself. And then it was sent for gene expression profile and PRAME testing, as well as the newer test based on that same needle biopsy specimen, looking for uveal melanoma associated mutations, those GNAQ, GNA11 mutations, BAP1, et cetera. Oh, yeah. Here's the list of all the mutations. So this is a custom panel that was designed to detect all the common mutations in uveal melanoma. Importantly, it covers the entire BAP1 gene. BAP1 mutations can be difficult to identify because they don't happen just in a single hotspot like all of the other mutations tend to, where there's like one little area that we need to look at specifically. They can involve large deletions or mutations all over the gene, and so difficult to find. So this is a test that has a very high ability to detect those important mutations. And what's also nice about this test is that it can detect the mutations from a very small amount of DNA. And that's why we can use that single biopsy, like, you know, the tiny little, as we almost call it a magical specimen. We can't see it with our eyes, but we kind of know and we feel that it's there once we've done that biopsy. Keep our fingers crossed. And I would say the biggest risk really with the biopsy is Dr. Stacey was talking about this earlier, but I think that the biggest risk or complication is that we sometimes don't get a result because the tumors are so small. Most of the time we can get one. And here are the data from the COOG2. We enrolled 1,763 patients. We had successful biopsy results from 1,689 patients, and then successful mutational analysis for 1,454 patients. We think that the study is important because it really represents real world practice. So these patients have a more typical age distribution than other studies, including the first COOG study, the TCGA, and most other published data sets. The tumors were also smaller, more like what we're seeing in real life. Not everybody has a large tumor that requires enucleation, thankfully. And they less frequently involved the ciliary body than prior studies. Fewer of the patients were enucleated, although we did include enucleated patients as well. 32% of the patients had class 2 tumors, 70% were PRAME negative, and 30% were PRAME positive. And this is really the important data slide here, where we're looking at, it's actually kind of flipped from all of those Kaplan-Meier plots that we've been showing you before. And the risk for metastasis we're seeing as being highest in this group here, the class 2 PRAME positive patients. Class 2 PRAME negative patients have a lower risk for metastasis, but higher than any of the class 1 patients. And then our lowest risk is in this class 1 PRAME negative group. We also found that we could detect mutations in 72% of the tumors that we tested. So we didn't find mutations in every single melanoma. Most tumors had one of these two, the GNA-Q or GNA11 mutation, which we expected. That's that first primary driver mutation. And then we saw that there were fewer BAP1 mutations among our group of patients, probably because there were smaller tumors, we think, and fewer of these SF3B1 mutations. That's the intermediate risk mutation, but more of the EIF1AX, the low risk mutation in this patient group. So the conclusions from this study is that, we have a large multi-center study that validates PRAME as a significant risk modifier to gene expression profile and predicting risk in uveal melanoma. We think that there's this 4-group classification, or we show that it provides highly accurate prognostication, and it's probably going to replace this 1A, 1B that we've used in the past. We can also accurately and reliably detect these mutations from the single fine needle biopsy specimen, but the mutations don't really give us as much information. It's not as useful in terms of predicting risk as the PRAME and the gene expression profile. And then, we're really excited about how quickly we were able to recruit with this study. I'm hoping to get Dr. Stacey and the group here at UW involved as we plan our next study. And I think it's a way for us in the Pacific Northwest to really help move things forward on a national level, because we are really well set up for additional translational studies as well as clinical trials, particularly in this adjuvant setting. So stay tuned. I think that there's a lot of important work that's going to be done with this group. So we're talking about molecular prognostic testing and telling you it's really, really predictive, but what are the issues with it? I think the primary issue is that it requires tumor tissue, and some tumors aren't very accessible. Some patients don't want to take on any additional risk by having a biopsy, and that's a real challenge. In addition, it can't be repeated. These tests need to be done before we treat the primary tumor, because otherwise the gene expression may change, and certainly we're hoping that the tumor is going to shrink and we're not going to have active tumor cells to be testing in the future. In addition, because tumors can be heterogeneous, they can have different areas that may have different biology. They may provide an incomplete picture if we're just biopsying 1 or 2 areas. So this is why I've been very interested, as well as others, in a concept called liquid biopsy. This is where we take fluids from the body, most commonly the blood, but in the eye we have other fluids we can look at, like the aqueous fluid or the vitreous fluid, and we look for what we call biomarkers. Are there molecules or cells that we can look at that can help us to know more about what's going on? Liquid biopsies are being explored for things like screening for cancers, for making initial diagnosis, and I think there's some potential role there for uveal melanoma patients in staging or predicting risk, what we call prognosis. I took this from the internet. I see therapy could be spelled better, but selecting therapies. And then for ongoing monitoring, like how are we doing with treatment and how effective is the treatment? As Dr. Hall was talking about, that's something that would be really helpful to know, particularly if we're not seeing shrinkage of tumors with some of these newer therapies. Today, I'm going to be focusing really on these circulating tumor cells, or what we call CTCs. They're particularly interesting because they contain tumor DNA, so we can look for things like mutations, for example, in these cells, and they have cellular features. They have some of these proteins on the surface, as Dr. Hall was talking about, that can tell us more about how we might target these cells for therapy, can tell us more about the biology. There's really a clinical need for a liquid biopsy in uveal melanoma that would let us risk stratify all patients using molecular techniques. So, I mean, that would be really, really helpful. We'd have really good information for everybody without needing to do a biopsy. They could help us monitor for disease progression without doing imaging, or in addition to imaging, and then also assess our treatment responses. There's been a lot of interest in this and many groups looking at it and looking at taking samples at the time of treatment from the aqueous, the front part of the eye in front of the iris, taking samples from the vitreous jelly, taking blood samples, and we can look at things like cell-free nucleotides, RNA and DNA. We can look at proteins. Oh, and I forgot, we can even look at the tears in the case of the eye, which is really exciting. And there have been groups looking at proteins that are in tears to see if they can give us clues. And then of course, tumor cells, as we talked about. I think a blood-based test would be particularly exciting because this would be a way where, for example, if you have one of these tumors that's a little bit funky and it's hard for us to tell, is this a melanoma or is it not a melanoma? Is it a melanoma with high risk for spread? Maybe we could do a blood test to help us earlier identify those patients who really would benefit from treatment, because then it makes it a very easy decision. You know, if we can know that you're high risk for disease to spread, even though you have a small tumor, because that can happen, then we're all okay, I think, taking the risk on the vision. It's much harder when we really don't know, and we know that we're going to harm your vision if we do treatment. In addition, hopefully better monitoring and surveillance, because we could draw your blood every 6 months, every 3 months, you know, and potentially identify tumors even earlier than we could detect them on the ultrasound or MRI. And then potentially more effective or even personalized treatments based on what's going on in the blood. Circulating tumor cells are a general concept, a general phenomenon that happen in all different kinds of cancers, in which the primary tumor, wherever it starts out, in this case in the eye, is the site where the cancer starts, but then the cells start moving into the bloodstream, traveling around the body, and then eventually exiting the bloodstream, going to different organs, and finding a place that they like to set up shop. Maybe just hang out for a while, maybe start growing into new tumors. And with a peripheral blood draw, just like you would get for any blood test, we can detect these CTCs in blood samples. And there have been many groups that have looked at CTCs, traditional CTCs in uveal melanoma, hoping that we could find something useful. But the results have been disappointing. And this is in part because they're very rare and often not reliably detected, even in patients where we know they have metastatic disease. They may not have traditional CTCs that we can find. And some groups have found that they may predict risk for spread, and some groups have found that they didn't predict risk for spread. So it's been really unreliable. But the work I'm going to talk about that we're doing at OHSU suggests that we may have been missing the population of real interest. And I'm going to tell you about this novel cell population that was discovered in my research partner, Dr. Missy Wong's lab, by initially a graduate student named Charlie Gast. And this was published in 2018. And I actually met Missy at a meeting that was much like this one, where she was presenting her research. I gave essentially Dr. Stacey's talk that day. And it was for a combination of patients and caregivers, and for primary care physicians and dermatologists, et cetera. And it was really a very serendipitous encounter, because I was very captured by her research, and then later sought her out to ask about potentially looking at these unique circulating hybrid cells in uveal melanoma. And it's been a really interesting ride since then. So what Charlie found is that looking at cell lines, that is immortalized cells in a tissue culture dish, he saw that cancer cells and immune cells could fuse spontaneously and become sort of a combination cell, this fusion hybrid. And these hybrids shared genetic and behavioral identity of both cells. They kind of acted like both parents. They looked like both parents. And this resulted in cells with enhanced migratory function. They were able to move around the tissue culture dish, or we think around the body, more like an immune cell can. They're normally patrolling all around. And they were also cancer cells that had what we call enhanced tumorigenicity. They were better at making tumors. And so it's sort of a supercharged cancer cell. And I have a video from the lab where I'm going to show you this here, where there's a cancer cell that's labeled in red and a macrophage type of immune cell labeled in green. They kind of get together and have this fusion event. So you've got a cell that's now both red and green. And it can migrate then. You'll see it dances around actually pretty vigorously in the tissue culture plate. until it undergoes mitosis or cell division. And it divides into two identical red and green progeny cells. This is a colon cancer model. When I wanted to just go over very briefly, what am I talking about with DNA and RNA and protein, et cetera. So DNA is, of course, it's sort of the building blocks of a cell. And these cells share DNA from both parent cells. And I'll show you that, show you actually the RNA in a moment. DNA is transcribed into RNA, which is sort of the message that the cell makes. And then that's translated into proteins, which are what makes things actually happen in the cell. And that's what directs what we call phenotype, or the behavior of the cell. This is, again, colon adenocarcinoma cell lines, where this MC38. And what we're looking at here is that there's like a fingerprint, an RNA fingerprint here for a macrophage, which is on the bottom. That's the immune cell that looks like this. And this is sort of what how you would recognize a macrophage. And then there's a RNA fingerprint for the colon cancer cell that looks different. And then there's a few different hybrid cells, which all show that they all look a little bit more like one another, although there's differences between all of them, but they look like a combination of the two parent cells. And that was really interesting to see. In addition, they share functional or behavioral characteristics of both cells. So one of the things that the lab looked at is whether, because these were macrophages that were one of the parent cells, did these cells still retain the ability to respond to macrophage stimuli? So it's essentially like putting out breadcrumbs for a macrophage, and are you gonna come over and eat your treat? And they found that yes, indeed they did. So the unfused cells are in black here, and they didn't really move or do much. But the fused hybrid cells, once we put the stimulus in the tissue culture plate, we're seen to then move around quite vigorously. In addition, these cells were highly tumorigenic. So they took, in this case, is like a breast cancer model. These cells were put into a mouse where tumors developed, and then the cells were sorted by fluorescence into these hybrid cells that express both a green protein and a red protein, or the unfused tumor cells, which were red only. And then they were injected into a wild type or a normal mouse. And what the lab showed is that you needed 100 times more of the unfused cells to develop a tumor that could be appreciated as compared to the fused cells. So they were better at creating tumors than the unfused cells. They were also shown to have metastatic potential. So when these in this case melanoma, cutaneous melanoma fusion hybrids were injected into a mouse, that mouse was tracked over time and eventually sacrificed to look at the lungs. The unfused cancer cells were shown to develop lung metastases, but much lower volume of tumor than there was for the hybrid cells. And so this was all the pre-human work that was very, very interesting. Where I became involved was at this point, where we were starting to look at human cancers and human cancer patients. About 1.5 years ago, we published this paper, which showed that hybrids are present in both the primary tumors and the metastatic tumors in a wide variety of cancer types. They're also present in circulation, where we call them circulating hybrid cells. And they outnumber the traditional CTCs in more than 14 cancer types, including uveal melanoma, which I'll show you in a moment. So we think these cells are really interesting because they may be actually driving the metastatic process. These may be the cells that are escaping and causing the problem. But how do we identify them? It really is like a Where's Waldo kind of situation, because there's a lot of cells in circulation, and how do we know which ones are the ones of interest? This was actually a really challenging problem for uveal melanoma and different from all these other cancer types that we were looking at, where essentially you could use the same marker, the same protein on the surface to identify any of these carcinomas, whether it was lung cancer, breast cancer, esophageal cancer, et cetera. For uveal melanoma, it's a very different cancer. We needed to find something different. So the universal immune cell marker that we use is CD45. And then you'll be familiar from Dr. Hall's talk with GP100. That's the target for tebentafusp. It's a uveal melanoma marker that's been used to look for circulating tumor cells in previous work. So we started by looking at GP100 and CD45, and we found that these cells were readily detectable in uveal melanoma patients. Here we're looking at a slide where we've separated out the peripheral blood mononuclear cells, which includes various immune cells. And then we are staining with fluorescent antibodies to look at cells that express GP100, which is green in this case, and CD45, which is red. And our circulating hybrid cells, or CHCs, express both of those markers. So you can see they're both, the same cell is both red and green. And the circulating tumor cells don't have the CD45, but do have the GP100. And that's essentially how they've always been defined. And the cells that express CD45, which is an immune cell marker, have always been discarded and not really looked at. So once we knew we could find these in uveal melanoma patients, we became really interested in whether they could tell us something. We knew in some other cancers like pancreatic cancer, they could be predictive for how patients did clinically and whether they developed progression of their disease, whether they survived. So I recruited patients from my practice, and I will say ocular melanoma patients are among the best patients. I think we had one patient out of hundreds that didn't want to participate, which shocked my collaborators. And I don't think it's my sweet talking. It's just really that I think we all share this this concern that we need to do better. And sure, yeah, go ahead and you can draw my blood, because we all want to be part of the solution. And I know that's why you guys are here today too. So I really do encourage you to participate in Dr. Hall's study and any others that you can participate in. We really can't do it without you. So patients underwent their normal treatment. They showed up for their surgery. They had their IV placed, and we drew some blood for the study. And then they were treated as they normally would be, and we monitored for metastasis as well as measured the CHC levels, excuse me. And what we found was that the CHCs, which are shown in red here, significantly outnumbered traditional CTCs, which we looked for as well. But what we were really confused about initially is that there was no correlation between the stage of disease and how many CHCs we were seeing. And that was really different than what we had seen in all the other cancer types we looked at, where stage 3 patients would have many more of these cells than stage 1 patients. And furthermore, when we looked at outcomes, we saw, gosh, there's not really any difference between patients that have high levels of CHCs and low levels of CHCs, or CTCs for that matter. And this was 63 patients we had looked at, and I remember the day that, we really decided that it wasn't panning out the way we thought it would. And it was very confusing and a little frustrating. And this is how science works though. And then we thought, well, there's something interesting going on here, because we had never seen a cancer where these cells did not predict in some way or correlate with outcome. So we went back and we looked to make sure our patient population was behaving the way we would expect. Are all of our other things tracking, or are my patients just all surviving? What's happening? And we saw that in terms of the AJCC stage, we saw the distribution that we might expect, where stage 3 patients were progressing to metastasis more frequently than patients with stage 1 or stage 2 disease, and that they were also unfortunately dying from their melanoma more frequently. We also looked at gene expression profile and PRAME testing, and we saw that the distribution and the correlation there to survival outcomes was what we might expect. So the patients weren't the problem. There was something about the test or the experiment that we were doing that wasn't making sense. And so what we started to think about is whether GP100 was sufficient to identify all of these cells. because uveal melanoma is really interesting in its biology. There's so many interesting things about this cancer that make it a challenge, but also really fascinating to study. We know from some other work done by other groups that the more aggressive cells in uveal melanoma tend to become less like melanocytes. They sort of lose that differentiation. They go back to a more stem cell or undifferentiated state. And because of that, they may downregulate markers like GP100. And so we looked at some other data sets, and this is a little bit complicated, but essentially here, this is single cell RNA sequencing data that had been published by Bill Harbor's lab. And we looked and we saw when we compared class 1 versus class 2 tumors that the GP100 was less well expressed in the higher risk class 2 patients or tumors. And then a serotonin receptor called HTR2B was more highly expressed. And so we became interested in HTR2B as a potential marker. We looked at the TCGA data set and saw that HTR2B looked interesting in terms of correlation with progression-free survival, or that is survival without development of metastases. And then after a lot of work, that was kind of boring and tedious, we found out that we could do develop a multi-protein antibody cocktail to essentially look for cells that express GP100 or that expressed HTR2B. We had to eliminate other kinds of cells that might express those markers. And we could then cast a wider net to look for these circulating hybrid cells. And when we did that, we saw that there was a correlation between CHC levels that we were measuring and the stage of disease, although it wasn't statistically significant in this relatively small group of patients, 38 patients in this cohort here. But we also saw that especially in some stage 2 patients and in stage 3 patients, when we added the HTR2B, we were finding more CHCs. So these red bars were significantly higher in some of these sort of later stage patients. And then when we looked to see how did the patients do, we found that patients with higher levels of CHCs unfortunately did more poorly with regards to both progression-free survival, survival without metastases, as well as overall survival. And this was not something we saw that traditional CTCs could predict whether, and in this case, it's just whether they have one CTC or more. So it was very exciting. And this is work that's ongoing. But one of the other things that was very interesting to us is this variable expression of these uveal melanoma markers in these patients. And this experiment is actually looking at 7 different CHCs that were taken from a single patient, a single blood draw. And we can see that we've got both GP100 and HTR2B, those 2 protein markers that we had talked about before, and then also tyrosinase here. There's many markers we can look at that can all identify a uveal melanoma circulating tumor cell or circulating hybrid cell. And they all express CD45, that immune cell marker. But some of them express all of these melanocytic markers. Some express just one or 2 of them. But it's a very heterogeneous population. These are all in circulation at the same time in the same patient. And that was very interesting to us. We went back and we looked at enucleated eyes, the primary tumors, at these same markers, and found that the expression of HTR2B was higher in the class 2 patients. So the higher risk tumors, we saw more HTR2B, which kind of made sense with what we saw in the circulation as compared to the traditional melanocyte markers, GP100 and tyrosinase. Essentially what we found is that we needed to look not just for like Waldo, and I learned more about Where's Waldo in this talk than I had before. There's also apparently Wilma. I don't know if you guys are as familiar. You have to look for Wilma too. She's wearing a skirt, but she's still a circulating hybrid cell in this case. And then there's Waldo's nemesis, which I didn't know was a thing, but his name is Odell. He's not wearing the red and white stripes, but he still is a player, and in fact is potentially higher risk. So I think of these now as GP100, tyrosinase, and this is HTR2B, who we have to be really careful about. So to summarize this part of the talk, these circulating hybrid cells are a novel cell population that hasn't really been studied before, but they're really exciting because they can predict clinical outcomes in cancer patients, including uveal melanoma patients. They're very heterogeneous, and they are a novel and promising biomarker in uveal melanoma that we think may provide insight into the way metastasis happens and disease biology. And we have a lot of work ongoing looking at various ways we can learn about uveal melanoma based upon these cells. So this work is really based upon a large research team. I particularly want to thank Ms. Wong, my research partner at our Knight Cancer Institute. We have many mentees and staff members who participated. Michael Parapilli and Yuki Chin did the bulk of the work that you saw today. Ashley Anderson and Riley Whalen were also very involved. And then my fantastic study coordinator, Ann Lundquist, without whom none of this would be possible. And of course, to my patients who participate with a lot of interest and inspire me every day. And then particular to this audience, the MRF and the Ocular Melanoma Foundation have provided support for much of this work. Thank you. I'd be really happy to take any questions you may have.
Hi, Dr. Scallett. Thank you for coming up to Seattle today. We're really excited you made the trip. PRAME testing was a few years after my diagnosis. Is it possible for me and others to get a PRAME finding through a blood test or another test?
That's a very good question. Unfortunately, all of the work that's being done is based upon PRAME testing prior to treatment of the tumor. So we don't have a good way to get that information now for patients that have already had their testing done, unless they happen to have a specimen still banked at Castle. Sometimes that's possible that they'll have some leftovers and that they could do the testing on that sample.
Thank you, doctor. I was wondering if we know enough about melanoma to answer why it has such a long lifespan, as you mentioned, can stay dormant for decades even before becoming active and live that long compared to like a normal non-cancerous cell.
Yeah, I think that the long dormancy between metastasis developing or recurrence developing outside of the eye is an open question. We don't really know. There's a lot of interesting things about the immunology of the eye, though, that may factor in. So the eye is what we call an immunologically privileged site, which may help the cells kind of escape from the immune system. The liver is also kind of relatively immune privileged, and there's probably something that changes about the immune system when these cancer cells suddenly start to develop and grow. I don't know if Dr. Hall or Dr. Bhatia, you guys have any better explanation other than it's sort of a mystery.
Well, explanations, I'm not sure, but we have our theories. So my take is, and I learned this, I never realized it in medical school, but eye is an immune privileged site. We do not want scarring in our eye. So there's less possibility of inflammation in the eye. So if a tumor cell is developing in the eye, it does not face some of the challenges that tumor cells in other parts of the body have to. So there's not as much immune surveillance going on in the eye. So I like to think of these cancer cells as somewhat immunologically stupid, actually. They're not as smart as some of the other areas. So when they spread, they probably are not able to survive in other parts of the body where immune system is more robust. But the liver is another environment where the immune system is suppressed.
So my theory is that these cells actually go and they are able to live in the liver. They're not able to survive elsewhere. And they stay dormant because they don't know how to grow. But over time, sometimes decades, my record is 35 years. We were talking about it yesterday. A patient who had a primary tumor developed metastases 35 years later. And during that time, there are a couple of things that could have happened. These cells may have gotten smarter over time, or the person's immune system was not as robust. And that is why I think that long dormancy is possible. The cancer cells were there, that's why they showed up, but they were not able to manifest themselves clinically for 35 years. Is that a
Yeah, that's my theory.
believable theory, I guess? Great question. That this is something fascinating about the biology of this disease. And I think it tells us about that immune system can work against this cancer. We just need to know how to stimulate it, how to bring it back in the game when the tumors are.
Right, and that's sort of where the MTAC molecule and the tebentafusp come in too, because one of the challenges with immunotherapy for this cancer is that the T cells don't seem to recognize the cancer cells without some additional help. Sort of that bridge of that MTAC molecule that brings the T cell to the melanoma cell. But there's a lot of very interesting and challenging aspects having to do with the immune system and how it works and with regards to this particular cancer. And there's a lot of work being done in the tumor immune microenvironment is what they call it. So when you have a tumor is not just made of cancer cells. There's also supportive cells, stroma there's a whole set of immune cells there in the tumor of varying degrees. And so as we're studying more cancers and uveal melanoma as well, in order to learn about the biology of the disease, we need to know not just about the cancer cells, but also about all the other cells that are in the neighborhood and how they interact. I think that's really important.
Any other questions? What's that?
Can you get any, if you develop a different tumor someplace else that's not like say a melanoma, a skin melanoma, can you pull information out of that that is relevant or informative to ocular or to your research?
Well, so it makes me think of a slightly different question that I think is relevant. The question is, if you have another type of cancer, say a skin melanoma, can you pull out information that's helpful in terms of the ocular melanoma? The way that I, as I am constantly thinking in clinic, how could I do better for my patients? One of the things that comes up that Dr. Stacey touched on is one of the few reasons we do diagnostic biopsies is when we're not sure what something is. And one of the things that comes to mind is sometimes a solitary metastasis like a lung cancer can show up in the eye, and it can look a lot like a melanoma and be a little confusing. And sometimes we'll actually see metastatic disease from a different type of cancer, and we can't really detect a primary cancer someplace else. It's a unusual situation. But in cases like that, I feel like because we can detect these circulating hybrid cells based on their unique marker, what t-shirt they're wearing, we could call it. I think that there is potential for helping us to make a diagnosis to say this is melanoma for sure, as opposed to this is a breast cancer or this is a lung cancer when we are looking at this CHC and identifying the types that we see. So sometimes patients can have multiple cancers present at the same time, and that's a confusing situation.
I think we're going to have to cut off questions. Thank you so much, Dr. Scala. Fantastic job. We are going to take a break now for lunch. Lunch will be served right behind us, I believe, right, Ritu? We have only 30 minutes.
Right, I like that. Okay, great. Yeah. Right, give it another little while. Good. Wow, that's quite a basket there. All right. As people filter back in, we're going to keep going. We're close to on schedule. We want to make sure we get everyone outside to enjoy a little bit of the spring day after the program. So I think one thing that has always struck me since I began to get involved in ocular melanoma care has been the incredible community that exists among patients that are going through this rare disease, very organized and very strong advocates. And so we're lucky today to have two patient advocacy organizations on site to share some information about what they're doing to help advance care for ocular melanoma. So to start, I'm going to introduce Melody Burchett, the president of Recurrence Insight, and Hannah Hulick, who's the director of communications and community engagement for Recurrence Insight, to tell us a little bit about their organization. And they also have a raffle, and we're going to be circulating a basket with numbers. So if you take a number from the basket, at the end of their presentation, we'll draw one and someone will win this very lovely gift basket. So thank you. Oh, there's actually the mic here too.
Who's in charge of the clicker? Thanks. Thank you so much. We are so excited to be here. We flew in from Raleigh, North Carolina to be with you all today. Recurrence Insight is a patient advocacy organization. We are for patients by patients. Every member of our board, a board of directors, are patients. So we understand what patients go through and we implement programs that you tell us we need. So we were founded in 2013. So this is our 10th anniversary. And we're excited with the future that we have. We want to make sure that we connect new patients with the community as quick as possible. And by doing that, we offer a new patient packet with that we send out to new patients just to kind of make them feel more engaged with the community, give them some information and some kind of fun stuff to make them feel good. We also have our buddy program that will hook up a new patient with a veteran patient to just kind of help them through the first process. And this is something that helps patients feel more connected and to feel like they can talk to somebody about their true feelings about their diagnosis. We also offer medical aid. With this also comes financial aid to a qualifying person when they fill out an application, that we give them money for a medical bill, insurance premium, travel expenses, living expenses, because this is a diagnosis that hits you out of the blue and not everybody is financially ready for it. So with that, we want to make sure that we're helping people get to travel. We have helped quite a few patients that have had to travel to Seattle for care from the outlying states that did not have the doctors to treat them. So we were happy to be able to do that. One of the things that we want to make sure is that everybody is supported and taken care of and seeing the best doctor possible. And we do not want financial circumstances to be in the way of that.
Another thing that we have is a podcast. We have a patient, Danae as our host, and she does a fantastic job. We rotate between having physicians and providers and pharmaceutical companies come to present the projects they're working on, the research, as well as patient stories. And we have, I think we're up to about 80 episodes as of this year, and we're over 5,000 downloads. So we're quickly growing and very excited about it. Danae also does our social media also to try to help get some of that research and the projects that we're working on, that other researchers and physicians are working on, out so that patients can see updates daily. So we're on Facebook and Instagram, Twitter, LinkedIn, and even TikTok. She's amazing at all of that. And this may or may not be relevant, but just our cumulative reach is about 4,000 patients, just meaning the individuals that see it across all of our channels.
We have Eye Patch Day. This was started in the UK quite a few years ago, and it's something that we do to kind of raise awareness. It's the third Friday of May, and it is a way to bring ocular melanoma awareness in the month of May, which is Melanoma Awareness Month. And we ask everybody to decorate an eye patch, wear an eye patch, encourage your friends and family, your coworkers to get involved as well. And we always have a eye patch decorating contest as well, where we give away a gift card for the best Eye Patch Day submission. So it's just kind of a fun way to raise awareness. And we're getting a lot of the pharmaceutical companies are getting involved in it as well. So it's kind of a fun thing. So on the third Friday of May, bring out your eye patch. We have free eye patches. You're welcome to take as many as you'd like.
We also have a series of webinars that we do across the year. There's about 4 quarterly webinars. And we rotate between various topics. Recently, we had a rare disease day special talking about how rare ocular melanoma is and then the rarities within the rare disease. And so those are interesting webinars to tune into.
We also fund research. We're not a huge research funder, but we do fund what we feel is quality research. We recently funded some research with Thomas Jefferson University, and we made our final report should have been in 2022, but because of COVID and supply chain, it kind of went a little long. So we made our final payment to them, and we're waiting for the final report to be coming out this year. So we do fund that. We also fund research that has been stalled, needs a little bit of extra boost. Our normal awards are between 50 and 100,000.
We also had the opportunity this was our second year earlier in January, where we team up with Melanoma Research Alliance and did a Steps for Sight campaign where we encouraged participants to get 7,000 steps a day to represent the 7,000 patients. And then they were able to double our impact and put in or match the donations that we received.
Thank you. I don't know, it just all of a sudden just. I apologize.
I think though next we were maybe going to be talking about our registry that was briefly mentioned earlier. We have a global patient outcome registry that is open to any patient to, we have several surveys that deal with natural history and demographics. We're working on adding some surveys about COVID and metastatic disease. And we are very excited about that. We have about 733 enrolled patients that have been through all the consent process. And then we have about 514 participants that are actively completing surveys and updating them yearly. So
our registry was the brainchild of a doctor in the UK. And so he had done the first registry there. So we were able to model this for him. And he unfortunately had to leave the United States and go back to England. So we took over and kept the registry going here. So we were the very first registry to be developed, the very first natural history registry in the United States for ocular melanoma.
and I guess this is what we're going to be talking about before, but we have a series of 14 5K run walks to raise awareness and money for research. And we'll be going across the United States. So here in Seattle is the one for this area of the Pacific Northwest on July 8th. And you're welcome to come if you like to run. Please run. If you like to just hang out with us, you don't have to run. So love to see you there. This we've mentioned.
We have a golf tournament in Napa that we do every year. It's our 10th anniversary this year. And we bring people from the community. We don't get a lot of ocular melanoma patients that come, but we do have a handful. But it's mostly we're bringing contractors we're bringing people from outside the Bay Area into Napa, and we're educating them about workplace safety and why they need to be taking care of their eyes, as well as to understand the importance of eye exams. And so this is our first fundraiser that we did, and it's our kind of our flagship event. We also have a store, if you guys did not know. You can buy awareness merchandise on our website. And we also take submissions for designs. If you are an artistic type person and you have an idea for something, we accept all applications, and we'll see if we can turn it into an awareness product.
We also have a newsletter for those we want to post updates for those that may not be on social media. So if you want, you can add your email to our list, and every month on the last Friday of the month, we post updates on research and events that we're working on, and different pharmaceutical updates. So it's a great place to hear about what's going on in the community. We also, this year, we had our patient event was in Nashville last year, and this year it is in Seattle. There we go. And so join us if you'd like. September 8th and 9th, we'll have kind of a similar type seminar, a retreat where patients can come and learn more about research, and also just connect with each other and spend some time with people who really understand what's going on in your life.
We have wonderful partnerships. We work with a lot of pharmaceutical companies as well as physicians, and we believe in this connection. We want to be the bridge from the pharmaceutical companies to the patients. So we work a lot with pharmaceutical companies to give them information that you guys are asking for, but also we do some really nice patient advisory boards for them where they can get information directly from patients, so that they know how to work on their clinical trials and their product development.
Here's the registry, more about that we spoke earlier. I apologize. This is a good thing to mention too, though. We're working on this project with Dr. Afshar out of UCSF. And as we know, the majority of this disease affects Western European in descent. And unfortunately, oftentimes that can lead to misdiagnosis in people that aren't part of that racial group. And so Dr. Afshar is working on collecting some photos and some data of individuals that don't fall within that majority, so that we can help educate physicians to be on the lookout for ocular melanoma even earlier in people who they may not expect to see it.
But we also want your photos as well, because he's also going to use the photos to come as a composite, that they might be able to train artificial intelligence to help diagnose earlier.
And this is another project we're working on with Dr. Moser out of Phoenix. And he's working on collecting images from the initial scans to look at using AI to improve diagnostics.
So this is our 10th anniversary. Now I'm gonna cry. I'm so sorry. You go.
I've only been working at ACIS for about 6 months, but I'm hugely impressed with all the work that they've done over the past 10 years, and the way that it's bringing support to patients and helping them have a place to find out more about information that they need to know, and also find friends. So looking towards the future, we have something I get to work on and I'm really excited about. We're working on linking a biorepository, a biobank, to our patient registry, and this will be held at Honor Health with Dr. Moser. We'll be collecting biopsy tissue cells from the initial tumor and from metastatic tumor in livers. And then this data, in connection with our patient registry, will be available for researchers to be able to study the cells and then study the patient history that is connected to those cells. And we also like to say, don't play favorites with, we know there are multiple registries like the wonderful one they have here at Fred Hutch. And you should participate in any you can. They're great opportunities to participate in research.
Collaboration. We believe in collaboration, and we want to collaborate with anybody that'll collaborate with us. We think that the more minds that we can put together, the better off we're all going to be. And nobody is an island. So that's the same with organizations and researchers and physicians. We all need to work together and put our heads together. So we're hoping to continue collaborating with pharmaceutical companies and centers such as Fred Hutch so that we can get to the patients the information that they need so that we can advance research so that hopefully one day that we can find treatments that work and ultimately a cure.
That's a little more on that on collaborating. And we just would like to say that we know that this diagnosis is a very difficult thing to go through. And so we work so hard to provide you with all the information that you need to feel connected and also to have a place where you can find people who really understand what you're going through so that you don't have to feel alone and that you can feel that there's hope here for you. So thank you.
Thank you. So do we have the pool of numbers? All right, do we draw one? How does, oh, you have a number. Go.
27.
Does that mean?
Yeah.
27. All right, in the back. And so I would encourage you to stop by the booth outside if you have any questions or want to learn more about the organization. Thank you so much for coming.
Thank you so much. We appreciate being here.
So next, from representing Cure OM, another patient advocacy organization, we have James Merrick, who is the Chief of Communications and Marketing for the Melanoma Research Foundation. Thanks, James.
Awesome. Well, good afternoon to each of you. I'm really excited to be here and to partner with Fred Hutch to speak with you all a little bit today about the Cure OM or Cure Ocular Melanoma program. So wanted to talk a little bit about the mission and vision of the Melanoma Research Foundation. We were established in 1996 by a patient by the name of Diana Ashby, who was concerned at that time with the lack of melanoma treatment opportunities, with the lack of community that she found at that time did not exist. And so she created the Melanoma Research Foundation as a patient advocacy group that's really focused in three different areas. The first, as our name would imply, is research. We have to date funded over $23.1 million in research funding to advance melanoma treatments, not only in the cutaneous space, but also in ocular melanoma as well as the other rare subtypes also. The second pillar of our mission is really all about education. That's why we are here today, to really talk with you all, the patients in this community, to help provide the resources that can help you navigate your journey, resources that can help connect you to available clinical trials and treatments as well, and provide an opportunity for you all to come together and really engage and network with one another. The last pillar of our mission is advocacy. We are headquartered in Washington, D.C., and so our proximity to our federal legislatures allows us to advocate on the issues that are most important to you all. In 2011, seeing the specific need for the ocular melanoma community, we developed the Cure OM program with Dr. Sarah Seelig and her late husband, Dr. Greg Strax. The mission statement for the Cure OM initiative is really similar to that of the entire MRF organization, of course, with a specific focus on ocular melanoma patients. We've expanded over the last several years to really have a focus not only nationally, but globally as well. We work with several other research foundations across the globe, including in Canada and Australia, to really make sure that we are supporting this community and collaborating from a global footprint. So I'm just going to touch a little bit on our three sort of mission areas and then have a brief video to share with you all as well. In terms of education, we hold an annual Eyes on a Cure Symposium, which is much like the symposium that you are sitting at today. In fact, We are actually across the country currently this weekend with our friends over at the Moffitt Cancer Center in Tampa, conducting our annual Eyes on a Cure Symposium there. We hold several webinars throughout the year as well that focus on several different topics related to care, psychosocial topics as well. Navigating that patient journey are all sort of the topics that are discussed at those webinars. We also provide print materials through our Education Institute, which can be found at curom.org. And those resources are made available to our patient and caregiver community as well as clinicians. Like our friends over at ACIS, we also provide a lot of awareness campaigns. We understand that ocular melanoma cannot be prevented. However, through early detection, outcomes are definitely improved. And so we feel it's important not only to advance awareness around ocular melanoma to current patients, but also to the general public at large. Again, given our proximity to Capitol Hill in Washington, D.C., we do quite a bit of advocacy at the federal level and also at the state level too. We are currently working with the Department of Defense to increase melanoma funding, particularly with the rare melanoma subtypes, as well as provide awareness around access to available clinical trials and treatments, and increasing the utilization of telehealth. Through COVID, we understood that there's a really significant need to increase the availability of telehealth for those patients who are living in more rural or isolated populations. And so we are actively working with the federal government to increase access to telehealth. And then lastly, just want to focus on research. In the OM space, we have currently to date funded over $2 million in research grant opportunities to research foundation organizations like the Fred Hutch Cancer Center, and have supported several scientific initiatives through our scientific meetings. And I'll speak a little bit more in detail about our registry and just a plug for that. You know, really, again, it's been echoed a few times already today, but really encourage you all to take part in all of the available registries, including ours, which is the Vision Registry. The Vision Registry really has three main aims. One is to record global cases. And so, as I mentioned, we've partnered with other research foundations globally to really ensure that we are capturing data globally. We are helping to advance the understanding around ocular melanoma and treatments. The Vision Registry is a natural history study, and again, is really ensuring that we're better enabling patient-centered recommendations. And then lastly, as has been discussed, we're here to ensure that we increase collaborations between those within the OM community, but also with our clinicians and researchers as well. In 2022, we released our first ever Vision Registry data report, which really captures the data from the first year of the Vision Registry, and that is available at melanoma.org/vision platform. And I'm just going to share a brief video. It's about 5 minutes or so in length. That really speaks to the CureOM program in more detail, and really, again, puts the patient and clinicians at the forefront of what we do.
When Greg was diagnosed with metastatic disease and we were told he had 6 months to live, we were faced with the hardest time in our lives. And we knew we wanted to do everything we could to save his life. I knew I wanted to do everything I could that was in my power to save the love of my life. And when it became clear that we weren't going to be able to save his life, but we could perhaps extend his life and might have the opportunity to save the lives of other people, that became a real driving force for us. So with a rare disease like uveal melanoma, it can be hard for patients to find each other, and it can be hard for researchers and clinicians to really get a full grasp of what's happening in this disease and really understand the patient experience and patient preferences.
The local support groups are breast cancer support groups or lung cancer support groups, and nobody with the same kind of cancer. And it's not the same. It's not the same because I didn't have treatment options. I didn't have a group of other people to say, well, this is what it's like to navigate life with one eye. I felt very alone. I felt very, that there wasn't anyone around for me to really bounce ideas or what the next step should be, or if I make a misstep, what does that look like? The big moments for me are meeting the other patients and caregivers. Those are huge moments because you walk into the room and you don't have to explain yourself. I don't have to tell them what my journey looks like. I don't have to tell them what it felt like. They just understand.
One of the greatest things about CureOM is the ability as a researcher and clinician to have, direct networking and communication with patients.
They give important grounding for researchers, give researchers an opportunity to speak directly to patients and caregivers and hear directly back. And that's an important conversation to have, so that there's a bidirectional flow of information from the community to the bench and back again.
One of my most favorite things is, presenting new data at these patient meetings. It's one thing to present data to your peers, but when you get to present some positive results of a clinical trial or some new and interesting ways that we could treat the cancer to patients, it is really, really powerful.
Once we started noticing that there were a lot of patients diagnosed in a certain geographic area at the Atlanta conference, Dr. Olaf actually said, we really need a registry.
It was clear to us when we were trying to do some epidemiology work that we were kind of missing important parts of understanding the disease. Where were they living? What were their lifestyles? We are all very excited that we've recently launched the Vision Registry, which is really a tool to help kind of gather a lot of this information so that we can look and hopefully better be able to help patients navigate through this, the treatment journey. Not only will the Vision Registry help researchers, we're also hoping that the Vision Registry acts as a tool to even bring patients together.
The Vision Registry is critically important because it gives an opportunity for patients to be involved in the field. From a researcher's perspective, it's very important because it will provide critical information about groups and cohorts of patients and might lead to insight in terms of what are the initiating factors, especially environmental factors.
So when I first started treating patients with uveal melanoma, there weren't many specific clinical trials for patients with uveal melanoma. Now, when I have conversations with patients who are newly diagnosed, certainly newly diagnosed with advanced disease, the conversation is really complex. There are at any given time 4, 5, 6, 7 potential treatment options. Again, the conversation is getting more complex, but it just goes to show how much more we know about uveal melanoma now and the different treatments that we're trying to explore. Now more than ever, the clinician, so the oncologist who's seeing patients in the clinic, the researcher who's in the lab, and the patients are working together really hand in hand to push this forward. And I think that's going to continue. And I think we're going to see really amazing things over the next 10 years.
Sarah and Greg brought together the researchers and the clinicians for the very first time. And that is big because, they're everywhere. They're scattered all over the country and not one person is going to cure this disease. And I feel like we have gained so much momentum to the point where we're going to find an adjuvant therapy. No longer are patients going to be diagnosed and not have that therapy that stops OM from progressing. We're going to get there.
So being at CureOM patient meetings today is always a little bittersweet for me because Greg's not there. It's also amazing to be able to hug people who have been here since the beginning and are doing wonderfully and their health is good. And I know they'll be here for years to come. And my hope is that there are more patients like them at every meeting and that patients are living longer and longer so that there aren't empty chairs at Thanksgiving dinners. And that's why we do this.
When you first get diagnosed, it just feels overwhelming. It's this big mountain in front of you and you don't know how to get to the other side. But then when you look and you see somebody who is on the other side, somebody who made it through year 1, made it through year 2, year 3, year 4. Oh gosh, now we've got somebody who made it through year 10. That is hope. And that's what we need. We need to spread hope. We need for people to understand that you can live, you can thrive, you can live alongside OM.
Thank you, everyone.
Thank you.
Just going to take a minute to introduce our next speaker. Flannery Moran has a unique perspective, and she's going to talk to us. Flannery is a nurse. For many years, she's been a nurse. You may have met her or spoken to her on the phone. She's also been the nurse here in the melanoma group at the Hutch. What you may not have known is that she has her own eye cancer diagnosis, though slightly different than yours. Her cancer started when she was a child, and she's been dealing with vision issues for a long time. So we thought that she had an interesting perspective, both working in the melanoma field with you and her own eye cancer journey. So with that, I'll introduce Flannery Moran, who, by the way, is now Dr. Moran. She recently finished her doctorate as a nurse practitioner.
I am so grateful that you were all able to make it for my dramatic reading of my new children's book, Miss Flannery and Her Misbehaving Eye. I'm just kidding. Happy April Fools. Brevity may be the soul of wit, but is not the soul of Flannery, so I will try very hard to keep this succinct. But I'll be honest with you, almost everything I prepared to speak with you about today were the practical aspects of vision loss and my journey with retinoblastoma as an infant, and then 30 plus years of perfect crystal clear 2015 vision that I felt extremely fortunate to experience. And then all of the curveballs that have come since. All of that kind of went out the window yesterday when I sat in Dr. Stacey's office and received another curveball. And so what I really decided I would rather speak with you about today is something that I wish I'd had a chance to speak with somebody about years ago. And I too have experienced not really having anyone to talk to about the cancer that I experienced as a child, nor my subsequent parotid tumor that I experienced about 6 years ago. They're rare cancers. It's very rare to meet another childhood cancer survivor, but especially a bilateral retinoblastoma survivor. And you would never know by looking at me, you know, walking around, speaking to me. You might notice my asymmetry, which is a consequence of external beam radiation treatment as an infant, or, you know, sometimes a little bit of a scattered thought process. But for the most part, you would never know that I went through that. And I think that's the same for a lot of ocular melanoma patients. And it can feel very isolating. I think in some ways, COVID was an extremely frustrating, grief-filled process for all of us. But I think for some of us, we were already kind of acquainted with that unique isolation that comes along with a unique diagnosis and treatment. So in any case, I'm a bit of a nerd, a book nerd, and I wanted to share with you two writers that have really helped me and you know, and my father is watching, so I had to throw in a dad joke with an eye toward resiliency. I'm not sure how many of you are familiar with Václav Havel, who was a Czechoslovakian playwright, dissident, statesman. He became the president, and then he was very well known as a poet. And he gave this multi-day interview regarding resiliency of the spirit. And the very boiled down quote that I cling to is that hope is not prognostication, it's an orientation of the spirit. And that is something that I've shared with a few of my patients at times when things get really tough. Another writer that I love is actually my namesake, Flannery O'Connor. I'm not sure how many of you became acquainted with her short stories in high school or college. Many of you were probably shocked and appalled when you got to the end of the stories and there didn't seem to be any redemption or resolution to the story. And you're like, what is going on here? Why does anybody read this? Fortunately, I went to school in the Deep South before nursing school, and I had a professor who explained to me that Flannery O'Connor actually lived with significant both physical and mental illness. She also wrote from a place of deep faith and trust in a larger story. And so her writing is very unique in terms of, to boil it down, you don't always find the redemption or the beauty in the story or the wisdom that she's trying to share at the end. It doesn't always look like it's wrapped up with a nice bow. Sometimes you have to look for the redemption and the beauty in the midst of the hard stuff, in the midst of the struggle that's occurring. And a lot of that is interpersonal communication or, greed, etc. in those stories. But what I take from both of those writers and what has really helped me with my very difficult treatment paths, I've been having eye injections and steroid implants now for about 4 years, 4.5 years. And the curveball that happened yesterday is that they don't seem to be working quite as well. So we're kind of back to square one. And there don't seem to be any new ideas. So it's kind of a little bit scary and quite disruptive to my equilibrium. But what I keep reminding myself is that I'm going to look at every day as its own trajectory. I do believe in a big picture. I see the beauty in a large story, but sometimes when you're going through isolating and scary circumstances, it really helps to remember that hope is not something that you derive from joy. Hope is something that you choose when things are dark. And it's not a way to predict the future or your outcomes, but it is a way to orient your spirit to find the beauty in every day. And that has been something that has really helped me through some very hard times, as well as a really strong support system. I know that everyone here probably has experienced the strange phenomenon of not knowing who they can talk to about what. But I treasure the fact that I have friends who've never been through anything like what I've gone through. But I'm 3,300 miles away from my family in Southwest Florida. And there was a time when I thought I was going to have to quit grad school, move back to Florida, never knew if I was going to be able to live on my own again. And I had friends that came alongside me and encouraged me to seek wonderful therapy, that, when they invite me to go and do things at night and they know I can't drive at night, they just automatically say, okay, I'm going to come pick you up. Or we're walking in the dark and they always offer me an arm so that I don't stumble. And that's very, symbolic to me, because I think that the community that has come up in the OM sphere, we all need that arm that's offered to us, even when we don't know what to say to one another. It's really powerful to walk together. And that's why it's kind of an unbelievable thing to be able to stand here and say that I did finally complete my doctorate. And I'm really looking forward to working with oncology patients in the future, because I think this is an incredible community. And even though it's a very difficult thing to go to, we're lucky to have one another. So thank you. It's lovely to speak with you.
Does anybody have a question for Flannery?
I think you'll notice that perhaps starting with that, the rest of the program is a bit of a shift into kind of the pragmatic. How do you kind of go through your day, and what's it like to kind of have had this diagnosis? And that was really powerful. Thank you, Flannery, for sharing that. So it's an honor to introduce our next speaker, Dr. Julia Brechbiel, who is a clinical psychologist at University of Washington in the Fred Hutch Cancer Center and an acting assistant professor of the Department of Psychiatry and Behavioral Science. She has a particular interest and passion in mental health issues among patients with serious medical conditions, such as cancer, and has worked closely with a number of our patients with brain tumors and head and neck tumors at the Cancer Center as they navigate mental health issues. So she did her undergraduate work at the College of William and Mary and PhD studies at Virginia Commonwealth University in counseling psychology, and also completed a postdoc program at Harborview in the Department of Rehabilitation. So my pleasure to introduce Dr. Brechbiel.
Right, that was a very warm welcome. Thank you. And thank you, Flannery, for sharing that. You really set me up, teed me up well for what I want to talk with you all about. So like Dr. Hall mentioned, is that I'm really passionate about patients' quality of life when they're going through something really difficult. And so fear of recurrence is something I see a lot with my patients. And so I think a lot of you probably know what fear of recurrence already is. But I think what's also startling is that a majority of cancer patients do experience this, and their loved ones experience it as well. So research kind of has this broad range thinking of like 22 to 99% of patients experience this. And those percentages are higher for folks who have more rare or unknown cancer types like ocular melanoma. I often hear people say it's like when they have like a twinge or a headache, or they have a memory of treatment, or they're driving by the clinic on their way through the city, it'll kind of rush back to them of that salience, or they'll see an old picture of themselves when they were going through treatment, and all of a sudden that feeling, that fear, that anxiety will kind of come back to them and think, oh, what if it comes back? So part of what I work on with patients is kind of some education that this fear is just an emotion, just like any other emotions that we have, and that fear of recurrence is completely normal and real, and that our brain kind of does this autopilot mode to keep ourselves safe. And so the way I often try to calm people down about their fear of recurrence is kind of teaching them about what their body and their brain is doing, that it is all those senses, those memories, the physical sensations going through their brain through the amygdala. So I often think of the amygdala, and we're not going to get super scientific about it, is a smoke detector. It's just kind of monitoring, seeing if the smoke is rising, and if they're worried, if your brain is worried about you, it's going to go off. For my patients with cancer, their smoke detector is probably a little overly sensitive because you've been through a lot and you don't want to miss a recurrence. And so I often work with patients to help them retrain the smoke detector and think about like when it does go off, that your body is going to go into fight or flight. Some of you may be familiar with this term, fight or flight, but it's just kind of the automated way your body prepares for danger. So I often think of it as our reptilian brain of back when we were hunters gatherers, that we had to get ready to cut and run if we saw a tiger or a lion. But nowadays it's like a presentation. Like right now, I can feel my autonomic nervous system going, wanting to do a good job in front of you all. But I don't have to like fight or run from you all. You all seem really nice. And so I try to remind my fight or flight system, like, no, my heart might be racing, but I'm excited to be here. I can calm down. And so I teach my patients how to override that system and turn on our rest or relaxation through like breathing, relaxation, or challenging our thoughts. And so kind of spoke a little bit about fight or flight, but sometimes people are freeze in that response and they're just overwhelmed by what to do. And they're not like, I don't know what to do with this symptom. I don't know what to do with these thoughts. I'm just kind of paralyzed. I know I don't want to ignore my cancer or these symptoms, but I also don't want to approach and go to the doctor and talk to them. And so they're just stuck sitting with these thoughts that freeze. And so I often teach them this fourth response, like how do we face this fear? How do we approach it and manage it? And so there's a lot of psychological research about interventions. I'm not going to bore you with statistics or things like that. But the two main ones that I kind of want to teach you about are cognitive behavioral therapy and acceptance commitment therapy. Both really focus on managing the emotions, managing the thoughts, and then how can we reintegrate ourselves inside ourselves and with the world around us so that we're not perceiving everything as a fear response or a danger. So first, cognitive behavioral therapy, you all might have heard of this before. One of the reasons I also want to teach this to you is that one day maybe I can put myself out of a job that I like to demystify mental health so my patients can do it themselves. And so when you're looking for a provider in the community, you can kind of ask these questions about what kind of counseling do they offer. So cognitive behavioral therapy is focused on a triangle, and each node represents the relationship between thoughts, feelings, and emotions. And so someone who practices cognitive behavioral therapy is going to help you think about what thoughts go through your mind when you have that emotion, that fear response. What is your brain telling you? And then what behaviors do you engage in? Do you work on calming yourself down? Do you provide yourself reassurance? Do you go to your doctors with these worries and concerns? Something I recommend my patients do a lot is to write down a list of questions and give it to their doctor and then say, okay, I don't need to worry about this in my brain anymore because my doctor knows. And I can place that responsibility back on them instead of me thinking about it every day. The other one I really like, I'm like a little biased. I practice more acceptance commitment therapy than cognitive behavioral therapy because I think it takes it to another level where we're not just focusing on thoughts and feelings. What do we do instead when we're not anxious, when we're not worrying about fear of recurrence? Being here in the present moment, enjoying these talks, enjoying the time with friends and family, rather than part of your brain being elsewhere, being like, when is this going to be the last time? Or is this going to be the last good holiday? I want my patients to be focused and enjoy those moments. And then also finding like, what are their values? What keeps them going? Why did you go through all this treatment? What are you hoping for in a quality of life? And then finding ways we could fulfill those values and taking commitment to act on those. What's important to you? And let's make a plan. Let's write down, what do you want to be doing in this next year, this next 5 years, this next 10 years? I think another helpful thing, part of ACT is that we're going to diffuse, meaning my body is going to have these reactions. Emotions are a part of the human condition, but I'm not going to play tug of war with them. They're not going to influence me. They're just going to sit over there, have their space. I'm not going to feed them with attention. I'm going to instead go and think about what is important to me and spend my energy elsewhere. And then I think another helpful piece is self as context, that I as a person am more than the experiences that happen to me, more than the thoughts I have, more than the emotions that come through me. I am my own person and I have agency. Okay, so I actually wanted to keep my slides really brief because I want to answer your questions, hear your concerns. I'm happy to, my contact information's on the screen. You're welcome to reach out to me if you want more information on this. There are some really wonderful, like self-guided workbooks on both of these approaches and resources in the community that I could help providers with. But I would love to hear like your experiences or what you have found helpful or questions you have for me. I'm gonna grab my water.
Any questions?
Can you hear me?
Yeah.
Can you talk a little bit more about what ACT looks like? Because I've actually never heard of it before. Mostly I hear about CBT, and to hear that that's your favorite,
Oh,
I'd like to know more.
Yeah. So it really depends on the provider you work with. So for me, I have a very collaborative style, very non-structured. Some people really like structure. So sometimes I practice like talk therapy, psychotherapy, like a 55-minute session is typical. And so I'd be sitting with patients, and sometimes we will do exercises in the room to kind of teach like how to relax, how to diffuse. Sometimes it's like fun, silly activities like your anxious thoughts will give them a name like Barb and give them a funny voice. And that kind of separates it of like, that's not me, that's Barb. So that would be like an example of like a diffusion activity. And so for each of those nodes for ACT, there are different activities, different metaphors, that help bring out and work on those domains. So like a values card sort is a really common one, something very easy you can Google and just do yourself if you want that language of what are my values. A great question.
I don't know that you can really answer this
I'll do my best.
question without years of therapy. We're talking about like the fear of reoccurrence, which is not like an unfounded fear, right? It's like
No,
practical to
very.
be aware of it and plan for it. So I guess I'm just wondering about if you have any tricks besides years of therapy for kind of walking the line between being afraid of stuff all the time versus being like aware and prepared for that possibility.
Yeah. I think like a really like quick, easy answer that I tell people or teach people when I work with them is called worry time. Again, another thing you can Google. And there's like a handout, and the whole principle is I'm going to plan my worry knowing that I'm going to do it anyway. I rather worry for an efficient 30 minutes or 15 minutes each morning with my coffee and plan my day and my worry than spend all day being consumed by these thoughts and feelings. And so like my worry time is typically on my commute to work. And I will think, okay, what am I worried about in my work and my personal life? And then I remind myself, what am I doing to manage those worries? What's the plan? What's the solution? Like with like recurrence, there isn't a specific solution, but reminding yourself, am I doing everything I can to give myself the best chance? Like what is within my control, and am I doing that? Am I going to my checkups? Have I talked with my doctor about these fears? Do my friends and family, do I have community I can talk with this about? Yeah, you probably do a lot of these things. And so then you can reassure yourself during that worry time, I have a plan. I am monitoring this. I'm not going to miss it. And then, but the hardest part about worry time is ending it, setting that time limit. And so I often recommend people, like, that's why I do it during like a set time during my commute, because there's an end to it. I arrive somewhere or having an activity afterwards. So you get up and take the dog out, or you go hang out with your family and you do something else that you rather spend your time on than worrying. Go ahead.
Just a question for me as a doctor and for everybody else. As patients, when is a good time for a patient with a diagnosis like this to get involved with a therapist or a psychologist? What should be the impetus for that?
I think, well, what I like about, well, I'm biased. I think everyone should be in therapy. So the answer is whenever, when you're ready. And so sometimes I see people here at the Hutch, we do a screening. And so we monitor it here of like, how anxious are people getting? And we reach out, we're proactive about it. Our social work team typically is like boots on the ground. They're really awesome. And then a lot of times patients bring it up or their doctors notice it and they have a conversation about it. I don't think there's too early. I think it can be hard during treatment because you have so much going on. And so it really comes down to like personal preference. I often will meet people 1 or 2 times during treatment, and then we'll do more counseling when they're on like the less strenuous side of treatment, when they have fewer appointments, because it can be hard to have a whole day of an appointment and then try and talk about your feelings in the middle of that. So I try to like meet patients where they are. So it's really asking yourself of like, do I need this space and this accountability to care for my mental health during treatment? Or do I want to wait until the end of my treatment and say, I want to process everything I had just gone through and what I'm worried about for the future? So it's kind of comes down to personal preference, and then doctors checking in and saying, we have these great services. Do you want a list now so you can act on it now or later? So what I probably would recommend. Thanks. I don't know how much time I have, but yeah.
Well, this is super helpful just for us to be reminding ourselves that these emotions are normal. We all have stressors. In your experience, obviously nobody here wants to be stressed about anything, but
Mhm.
things happen and we do get stressed.
Yes.
How do you think we should remind ourselves? What motivations work best for people to be reminding themselves of the need to do this proactively?
Mhm.
Yeah, and while you answer that, I guess I want to add a motivation from my side of things, how I see things. Immune system is the key in fighting cancer, and we know that stress is not good for the immune system. So that would be one motivation I would have for my patients, that, think about your immune system. And so it's important to manage stress, but easier said than done. But what
Exactly.
other motivations can people
Mhm.
remind themselves of?
I think it comes down to personal preference of what actually motivates you. And goes back to values. Like, why did you go through that treatment? That was really difficult. Why are you coming to talks like this and spending your Saturday with us? Like, something's really important to you. And so finding that motivation is going to be very personal. For me, it's quality of life. Like, I value my patients. This job is stressful, but I love seeing my patients like blossom and grow after their treatment and often find a better version of themselves. I think it makes sense. Like, some doctors like that stress immune system approach. Sometimes that can make people feel more anxious, no offense, that they feel responsible for every cell in their body, which is not the case. You don't have that much control, in my opinion. So reminding yourself, like, okay, this is normal. What do I else want? And so that kind of more of a pivot away. You don't always want to think about cancer all the time. I hope that answered your question.
Yeah.
Okay. Yeah, there's a couple.
Okay, I guess I'll go first. I got my
Yeah.
microphone first.
You got
It's a race between me and her on the other side of the room. I have a therapist. I absolutely love my therapist. But I hear a lot in the cancer community, people are having a hard time getting in to see a therapist. Like, there's a real shortage happening right now. Are there things that you would recommend for those that are waiting or trying to get in, places that they could go to maybe?
Yeah. It is rough. It is like a 3-month wait, and often finding, like, trust me, it's stressful, for me and my patients. And so talking with your medical clinics, sometimes they have like a referral list, where, like, I know who has availability right now in the Seattle area, like, because I'm connected to that community because I work here at Fred Hutch. And then I often will, like, see my patients once a month if they want to find someone in the community instead of me, because I know it's really hard. And we'll keep trying and finding other clinics they can find. What I do like is that we have what is called Psych Pack. It is a conglomerate of states where we have cross agreements now with telehealth, where you can be working with someone who is not in your physical state. And so Washington State is now one of those. And it's like 20 states, 15 states now that are part of this group. And so if a mental health provider is licensed through that organization, it kind of frees up access. So there are a lot of, like, search websites for these now, like Psychology Today, Good Help, Zendash. I think those are the ones I think of off the top of my head. Yeah.
And I would also say, I think just talking to the physicians who are involved in your care, they may have some other resources. I know psychologists and psychiatrists are super busy, but we have medical social workers who are very driven to help patients in tough situations. And they may not have a degree in psychology, but they know a few things, and they can point out other resources to help patients. It may be literature, it may be online help. So I think there is help around. It's just that we are at an interesting point where access to care is compromised.
And I recently had a colleague say primary care is the new mental health. And so many primary care doctors are prescribing medication for, like, depression, anxiety, and have I know like I have a colleague here in primary care who has like a better referral list than me, which is a little embarrassing, but he's like, I get asked all the time. And so primary care doctors are really attuned to this, and can probably tell you like in your community who or where to start looking. Yeah, Flannery.
I was just wondering if you could enlighten us for a couple of minutes, if you don't mind. I know that we talk a lot about the stress and the grief that goes along with the diagnosis and with treatment. But I've spoken with a lot of patients who are post-treatment and in remission that experience a different type of grief. And just kind of, there have been some treatment modalities that have come to my attention in terms of complex grief, you know, and being post-treatment.
Yes, I see this quite a bit, where there's like that grief, or like a really mix of emotions of like, yes, I finished my treatment, but then you don't see your oncologist for 3 months. You don't go to the clinic and see your nurses that you've built relationships with for months. And then you just kind of feel alone that you're supposed to be like yourself again and normal. And then you're not, you know, there's changes in your energy and your functioning. There's emotional changes. You view yourself different. You may look different. Others are going to treat you different. And so there's like that grief around identity that is a huge piece to try to process. And often it can kind of, it takes on a different kind of like sadness or stress of like, when am I going to feel like myself again? And so sometimes it's talking with loved ones of how you can increase that sense of normalcy, resuming roles and responsibilities, having people not treat you as like fragile or sick or ill, or finding ways you do want to spend your time. Maybe you didn't like your job before your treatment, and now you have this opportunity to explore how do you want to spend your time. And so it is a lot of like complex grief. That's a really good way to put it. And I see patients years out from their diagnosis and they still feel like this. There's two versions of themselves they haven't been able to consolidate. And so that's a lot of what I work on with patients. Is that like waxing poetically enough? Thank you. I feel like we probably have others. So thank you, everyone. Great questions.
All right. Really enjoying the afternoon. I don't know about all of you, but I think I'm learning a lot. Next up, I'm really excited to introduce Lauren Facchini, one of our genetic counselors at Fred Hutch. So often when I'm seeing patients for their first visit, there's a concern about why did this happen to me, which we've talked about is largely unknown for most patients with this. And then what does this mean for my family? And so I think having Lauren speak to us today about the genetics and the role of genetic testing is really an exciting opportunity. So thank you, Lauren.
All righty. Let me orient myself here. Yep. Okay. That will work. All right. Well, it's so good to be here today. Again, my name's Lauren and I'm a genetic counselor here at Fred Hutch. I've been at Fred Hutch for going on 5 years, which is crazy. And I've done a couple of these talks and I always find them rewarding. The community is always fantastic. And that's really just very true and evident today, as many people have already said. Today, we're going to talk a little bit about cancer genetics and genetic testing. We've already talked a lot about that already. Some of it will be a bit of a review. We'll also talk about hereditary ocular melanoma, which is something we really haven't talked about yet today, as well as the one gene we think about quite a bit, which is BAP1 tumor predisposition syndrome. I'm going to just say BAP1, just so you guys know. We're not going to say the whole name. And then we'll talk about an example case, which is a patient I recently saw with a family history of that. So genetic mutations, we've already talked a lot about genetic mutations, but these are changes within your DNA. So kind of modeled here, we can see that sometimes these are letter changes where we would expect to see a T in the DNA, we might see it replaced with a C. And usually these are fine. We all have genetic changes. That's what makes me, me. That's what makes you guys, you. But when these genetic changes are in a gene that's related to cancer, so let's say it's related with cell growth, or it's an oncogene. That's where these things can really become issues because they change the way the gene functions, and that of course can lead to cancer. One of my favorite sayings is all cancer is genetic, but not all cancer is inherited. So I think these are two things we need to separate, and this confuses a lot of our patients coming in. They're saying, wait a second, my oncologist already did genetic testing. Why do I need to talk to you? What type of genetic testing are you talking about now? Did this already get done? And then I have to take a step back and say, well, actually, we're talking about two different things. So there are what we call somatic mutations or tumor mutations. These are things that are acquired. So due to the environment, due to age, due to all sorts of other things that are happening within your cells. You can see here, these are changes that are just isolated to one cell group, right? They're in one part of the body. These are not inherited. They can't be passed down. And then the other type of thing we're talking about when we say not all cancer is inherited is we're talking about germline mutations. So these are genetic mutations that happen in the egg or the sperm. They can be passed down from parent to child. And this is what I'm really interested as a genetic counselor, right? I'm interested in these genetic mutations that you're typically born with and that are present all over your body. So they are essentially related to a hereditary type of cancer risk. It's essentially putting you one step closer to cancer than the average person, okay? And so that's really what we're gonna focus on, and that's what I really focus on as a genetic counselor. Okay. And just like there's two different types of genetic mutations, there's two different types of genetic testing. Both help us identify these types of mutations. But tumor or somatic testing helps us determine the nature of the cancer. It can help guide treatment. This is where a lot of those treatments we talked about previously are focused. It's saying, let's take a look at the DNA within the tumor and let that guide us and let us help essentially create precision medicine, right? That's the goal. And then there's also germline genetic testing, and that's trying to say, okay, was the person born with any genetic mutations that put them at a really high risk for cancer? And again, that's what we're talking about here today. When we think about hereditary ocular melanoma, you know, we know this is a really, really small group within an already really small group. So it is very rare within the rare cancer. It's maybe 1 to 4% of all ocular melanoma cases that have an underlying genetic cancer syndrome. And really, we know that there's really only one gene we think about, BAP1, as I mentioned earlier, that we found in those families where we're seeing that underlying genetic predisposition. However, there's definitely more, right? There are other types of genetic predispositions we probably don't know about, we haven't yet discovered. And certainly there's a couple what we call like preliminary evidence genes we're thinking of that the research is saying, maybe we should start looking at these genes over here because those also could be contributing. So certainly it's 1 to 4% based on what we know now. That could go higher, you know, as we learn more, as we do more genetic testing, as we look more at these tumors in these families, absolutely. So, you know, as a genetic counselor, I'm really interested in that small group, that 1 to 4%. You know, my job is really to look at someone's own history and their family history and say, what's the chance that that's happening here? What's the chance that you and your family are going to fall into that 1 to 4%? And so there's certain things I look for that essentially make me really concerned about that or less concerned about that. But these are some of the things I look for. And this is not just ocular melanoma, but really all different types of hereditary cancer families. So the first thing we look at is age of diagnosis. I am much more concerned when I see someone diagnosed at a young age with a cancer. So for ocular melanoma, that can be like under the age of 30, but really under the age of 50 is a little bit young. And certainly for more common cancers like breast cancer or colon cancer, anything under the age of 50 is certainly young. I also look to see if the person has had a history of other types of cancers. So getting cancer at some point in your life is unfortunately quite common. A lot of people develop some sort of cancer. But sometimes my patients walk in and they said, you know, before this I had colon cancer and then I had breast cancer and then I had basal cell carcinoma and now I have melanoma. What's going on? And I'm telling them, yeah, that's unusual. You're in the right place. And so, you know, we certainly look for people who have had this atypical history of multiple types of primary cancers, not where one is spread to the other, but when they're separate diagnoses. And then we also look at families, right? So a big part of my job is taking a large family history. We're going to go 3 generations back. I'm going to be asking you about your cousins, about your aunts, about your uncles, about your great aunt and uncles. And people start to raise their eyebrows and go, I don't know. And I'm like, that's okay. You know, I'm going to ask about all these things in case you do know. But certainly when we meet with families, we build out a big tree. And what we're doing when we do that is we're looking for families that have a lot of the same type of cancer. So, you know, that could look like a lot of melanoma in one family or possibly a lot of breast cancer, but also related cancers. So things like breast, prostate, ovarian cancer can run together. When I think of ocular melanoma, I also think of like renal cell carcinoma and a couple other ones we're going to get to. I'm going to save that for later. But essentially, we're looking for these trends. Is there a lot of one type, or is there these, again, these patterns we look for? And then also cancers that have a high rich chance to be genetic. So there are things like ovarian cancer, 20 to 25% of that is genetic. They have a germline mutation. So certainly when I see a cancer like that, it's a red flag. And then other clinical features suggestive of a particular condition. So again, sometimes there's some of these kidney cancer genes can have skin manifestations. So other things that we're looking for at the same time. And then ancestry can kind of play a role. We know that certain ancestries can sometimes have what we call founder mutations. So, and some of those founder mutations can be cancer-related genes. So we're looking at that ancestry and saying, okay, is there anything we need to be thinking about with their cancer diagnosis that makes us more suspicious? Okay. So I want to talk about BAP1 tumor predisposition syndrome because this is the big one we think about. I'm going to hold that back. With uveal or ocular melanoma. So this is when someone has a germline or an inherited BAP1 mutation. So again, something they were born with, they have a BAP1 mutation in every single cell of their body. We know they're at an increased risk for these BAP1 inactivated melanocytic tumors. We used to call them Spitz tumors, but essentially they look like moles almost. They're raised, they have a kind of a pink or a flesh colored appearance to them, but when they take them out and look at them with pathology, they actually can see that there's BAP1 mutations in them and they're BAP1 inactivated. So that's one of the big things we see in that group. But the other big cancers we can see is this increased risk for melanoma, both of the eye and of the skin. Mesothelioma, which is a cancer that people don't think about as being inherited. They say, oh, that's just with asbestos. You've heard all those commercials on TV if you've had asbestos exposure. No, but we also think of mesothelioma, kidney cancer, renal cell carcinoma, also basal cell carcinoma, which is a pretty common type of skin cancer. And then also more rarely some liver cancers, bile duct cancers, and meningiomas, which are like a brain tumor. And so if we just look at families that have essentially familial uveal melanoma, so like 2 or more cases of uveal melanoma in one family, which is very unusual, 19 to 23% of those families actually had an underlying BAP1 germline mutation, which is pretty interesting and quite high if you're just looking at that category. And so what I usually tell patients is, look, we should probably consider doing BAP1 germline genetic testing. That's just on your blood or your saliva. When there's 2 or more BAP1 types of tumors, so these ones I've listed out here, in the patient themselves, or maybe close together in the family. So like maybe you've had uveal melanoma and then your parent had kidney cancer, then maybe we should start thinking about that. Or again, if we're seeing things really, really young, NCCN says if you're under 30, you should probably think about that testing as well, or at least meet with someone like me to talk about that. Okay, I want to talk about my example case and then we'll take questions. So this is a pedigree or a family tree that I take in sessions. This is a real family, although I've edited it slightly just for privacy concerns. So my patient was a 35-year-old female who came in because she had this mole on her arm that was a little atypical. Her dermatologist removed it. They sent it off for pathology, and turns out it was this BAP1 inactivated tumor. When I took the family tree, you can see that it was really notable for these BAP1 tumors. So her mom had a meningioma at 18, later was diagnosed with melanoma at 29, again, very young, passed away from it at 40. And then her mom's brothers, these 2 squares over here, let's see if this mouse is going to work. Here we go. So we're seeing melanoma and a basal cell carcinoma as well as mesothelioma. It was in the lung over here in this uncle, and then this uncle also had mesothelioma. But the family had really just kind of assumed, oh, we're around asbestos, we're a farming family, we worked out in the sun, this is all normal, right? These are just environmental. And then we went further back, and the grandmother over here on mom's side also died of kidney cancer, again, relatively young. And then there is also lots of cancers over here in grandmother's siblings, but they couldn't really tell me more about it. They just knew that there was asbestos and lung cancer and who knows what. But we did genetic testing, and turns out the patient did have BAP1 mutation that was germline that she was born with. And then her uncle went and got testing, this uncle who's living over here with melanoma and basal cell carcinoma and mesothelioma, and he had the exact same mutation. So we can assume that this is also what mom had. This is likely what grandmother had. This is likely what her other uncle had. And that kind of answered that question of what's causing all these cancers here in this family at, relatively young age for some of the diagnoses. And so the next steps for my patient was, I told her we're going to keep monitoring with dermatology. We want to make sure we're evaluating for skin melanoma risks and basal cell carcinoma. We sent her to ophthalmology so that she could get eye checks regularly. And then we also referred her to medical genetics. So that's someone like me, but who has a medical degree. And she's going to be monitoring the kidneys as well as the lungs for mesothelioma risks. And then we're also recommended testing for her brother here who hasn't been testing. And then her daughter, who's only 3, she's going to start testing at 11. And that's because at 11, if you have a BAP1 germline mutation that you're born with, we do say that you can actually start doing those eye exams at that young. So when she hits 10 or 11, we'll send them over to Children's, and they'll talk about the pros and cons of testing at that time. And if they want to know, and if she has it, we'll get them set up. Okay, so final takeaways. Hereditary cancer syndromes are very rare, but knowledge of one can be helpful for you and your family, really for, again, providing a diagnosis, a reason as to why, as well as so that we can keep an eye out for these other types of cancers, not just in the individual, but also their family. And if you're concerned, please talk to your doctor or ask for a referral to genetics. We're always here. And this is a QR code directly to our prevention site if you guys are interested, but happy to take a few questions. We have a couple minutes. Oh, so if you have a germline mutation in BAP1, so essentially you most likely inherit it from one of your parents. And then there's a 50% risk that it could be passed to children. And a 50% risk it could be passed to full siblings. So essentially it's kind of a 50-50 chance each generation. It's quite high. So we're waiting until her daughter, who's 3, we're waiting until about 10 or 11 because screening doesn't start till then. So we're not going to, even if we do the testing now at 3, nothing's going to change for her. And so we usually say to start testing at the age which screening starts. And for BAP1, that's typically 11 for the eye exams. But a lot of hereditary cancer syndromes do happen later than that. A lot of times they're fully adult onset, in which case we tell them to wait till 18, just so that they can have a little bit more say in that discussion and in that decision. Yes.
I was wondering, is this all done, or does insurance cover this at all for certain situations, or is it all out of pocket?
It is not all out of pocket. Yes, insurance does cover genetic testing. They have actually gotten really good about covering genetic testing. It used to be pretty much a self-pay only, especially for rare conditions like this, but that's less and less the case. And there are self-pay options available that are, relatively affordable, probably about $250 that I always talk about with my patients if it is a concern or if insurance denies it. But typically for families that clearly meet like that criteria I mentioned previously, it is covered, which is good. Yeah, we're thrilled.
Can you please talk about downside of genetic testing?
Yeah.
Other than the financial parts?
Yeah, financial concern is always one of the big ones. I think the downside is, some people really just don't want to know. They say, if I have an underlying cancer predisposition and you tell me that I have a high risk to get something else in the future, that's just going to put me over the edge right now. I absolutely don't need to know that. Which I think is very fair. Like, as much as you have a right to know, you also have a right not to know. And so certainly I think that's another big reason why people end up declining, is because they really don't want to know. There can also be some concerns with insurance privacy. So I will say health insurance, employment, those are actually protected by law. So your health insurance cannot call this a pre-existing condition. If you have a genetic mutation, they can't raise your rates. They can't deny you insurance coverage, which is great. But there's some loopholes for things like life insurance, disability insurance, and long-term care insurance. Those are the folks that can say, sure, we'll give you $1 million life insurance plan, but we want to see your health record, which can include a genetic test result. So that's where it can get a little hazy about insurance. But I would say those are kind of the big downsides. Another big downside every now and then is we get uncertain information, right? We get a mutation in a gene that we don't know if it's actually causing a cancer risk, or in a gene that's only been newly identified, so the cancer risks aren't fully understood. So there's certainly a level of uncertainty that can also come with it, and that can be a downside as well. Yes.
I just wanted to make a comment on the flip side of that. As someone who was born with a hereditary form of eye cancer, I experienced a secondary and unrelated tumor later on in life. And I came to you guys basically just for some peace of mind. I met with the survivorship clinic, at Fred Hutch, which I absolutely completely admire them and recommend everybody check out. But it was really helpful to me, especially given my family a history of lots and lots of seemingly unrelated cancers, to have that peace of mind and to be able to say that moving forward, I am aware of my risks, and, looking forward to having a family at some point and knowing my risk of passing that on is unbelievably precious to me. So thank you.
Yeah, absolutely. And thank you for sharing that. I feel like a lot of our patients, even though it can be initially stressful in the beginning, most of them are actually very happy and grateful that they ultimately did this testing. Most of them don't regret doing that. And we've actually done long-term studies on that, looking 6 months out post-diagnosis. Most people are actually quite happy they got that information. And they don't feel like their stress level, changed dramatically after that amount of time, which is good. Any other questions? Okay,
Great. Thank you so much. All right. We're going to conclude with what in past symposiums for other diseases that I've attended, has been some of the really most powerful stuff, and that's hearing stories from patients. So that's everyone, I think, has said that's why we're all here, is for our patients. And a few patients have volunteered to share their stories with the group, which is wonderful. So I'd like to welcome first Nikki Doyle. You can use this mic.
I'm going to hold on to both of them because I am a quiet speaker, and if this one doesn't work, is this loud enough for everybody? Okay, all right, great. Then I'll give this one back. If that changes, just let me know. I also realized when I got here that I wrote everything on my note cards in really fine print. Thankfully, my wife brought my readers. So not quite sure where to start. I was a little nervous when Dr. Bhatia called me up and he was like, will you share your story with everybody? And I was like, good Lord, how in the hell am I going to explain 4.5 years of a cancer journey in, 10, 15, 20 minutes? How do I pack that all in? And I can feel my anxiety raising. I'm not sure. Yes, there you are. Yep. Yeah. It's all right there for me, right? Like all of that anxiousness and excitement. So I just kind of want to do this a little differently than how you've been doing it today. I'm happy to share with you all of my medical stuff. And I also want to kind of share with you some of the internal work that I've done as well. But I want to kind of do it in a popcorn excuse me, and a popcorn effect. If I say something and you're confused or you're questioning, what the hell is she talking about? Just ask, just raise your hand. I'm happy to have one of our doctors run the microphone up to you here. First thing I want to do though, is I really just want to thank all of you for being here. I want to thank all of those who are online and who are here with us, all of our caretakers who stand by us and walk with us on these super scary journeys. I just want to thank all of them for being in the muck with us, for continuing to show up, send us funny messages and videos, and do research for us when we can't bear to read another report or another study that may or may not have a difference in our outcomes. In 2018, I went to the eye doctor because I was having flashes in my left eye. They would all start and they would rotate around my eye on the outside. I called them my private laser light shows. And I thought they were really cool at the time until I realized on a job site that I kept running into people on my left side. And my boss at the time, who I'd known since we were 14, he said to me, "What the hell is up? Why do you keep bumping into me?" He's like, "The joke is over, knock it off." And I'm like, "What do you mean?" And so we did this old trick where, you put your arms out and you use your peripheral view. There's my anxiety popping up. I'll just breathe through that. And he was like, "Just have your arms come out. And when you can see your hands, stop your hands." Well, what I didn't realize is I can see my hand here, but I couldn't see my arm until I got to about here. And that was when I was like, well, I guess the glasses that I just spent all this money on aren't quite cutting it. And I should probably go back and get looked at again. My doctor was like, "I kind of see something." It was in a very odd position. And I think he was kind of chicken to kind of give me the diagnosis there in the office. But he said, "I kind of see something and it doesn't look quite right. So I'm going to send you to a specialist." And I think that they just changed. I think it's somebody new. But when they call, take whatever appointment you can get. This is not something to mess around with. This is something to get looked at and get looked at right away. So I kind of left the appointment going, cool, I got to go see somebody new. He's a specialist. I wonder what kind of things they're going to do to check me out. Not even thinking of the reality of what this could be. So my wife so lovingly forced herself to join me on that appointment when I got that call to go and see Dr. Stacey. And we were supposed to go and pick up my mother at the airport. And we had to call my niece right in the middle, right after Dr. Stacey said to me, "I believe what you have is a malignant melanoma tumor." And I was like, "Are you telling me I have cancer?" And he said, "Yes, that's exactly what I'm telling you." And the next thing he said to me was, "I want you to understand, there's absolutely nothing that you did, and there's absolutely nothing that you didn't do in order to get this. It's just a rare disease. We have no idea what it's from, what causes it, what doesn't cause it. It's just kind of the luck of the draw. And you kind of got the short stick." And that always brought me a sense of peace, because the first place I always like to go is, well, shit, what the hell did I do wrong? Did I not wear my sunglasses? Did I not wear enough sunscreen? Because when you go to the dermatologist and they tell you you got a bad mole, they usually tell you to start wearing more sunscreen and cover yourself up in the sunshine. Well, it really gave me a sense of peace to know that I just didn't do anything wrong. And I didn't necessarily do anything right either, but it was all out in the wash. I like knowing that I didn't do anything wrong. So my tumor was located in both the ciliary and the choroidal bodies of my eye. I think I said that right, choroidal bodies of the eye, yeah. And it's in a strange position in that I have to really look to the side for them to even see it. They really, really dilate my eye to the point where it's really hard to see any color. It's just pretty much all black, which looks kind of funny. And I was going through trying to find slides to submit, and I was like, all these are pictures of my black eyes I'm looking at. And they're usually very hazel, so I opted not to bring those. Between the time of diagnosis and getting to meet with all of the doctors, the radiologist who was going to do the plaque treatment for me. And getting into surgery, the tumor had grown from a large medium to a large tumor. And in the operating room, they had to change from a smaller plaque size to a larger plaque size. It was a very strange experience rolling into that room and seeing not just a few doctors, but seeing like a dozen doctors in the room. And it's a very strange 4 days of having something sewn to your eye. And it was a very strange experience being rolled out from recovery in a wheelchair. And I had the sensation of feeling like I was rolling backwards. I couldn't open both of my eyes. I felt too sick and nauseous to do that. So I had to ask my friends, are you pushing me backwards or forwards? And they're like, we're pushing you forwards. And I'm like, well, it feels like I'm going backwards. Hopefully this will kind of calm down. And over the course of 4 days of just kind of laying with my eyes closed, I just got really present to the fact that I didn't have enough life skills. I didn't have enough tools in the tool belt to deal with this. All of the things that I had grown up with, all of those survival skills to get to the point to where I was, were not going to cut it. I knew in that moment that I had to start shifting and looking and searching and finding for other things that could help me in the midst of this journey, being at the very beginning of it. Well, for 20 years, my regular physician had been telling me, you should really try some things that will reduce your stress. And I was like, okay, what the hell does that mean? Have an extra beer at night? Or, you know, does that mean take up a extracurricular sport activity? And I had started meditating when I was in college, when I was 19. And it started really slow. And I had kind of given up because meditation, I don't know if you've felt this way before, but sitting down and trying to meditate, it's like my thoughts are not quiet. My thoughts are loud and they are annoying and they are scary and they are confronting and they never seem to shut up. And I would get tired of the routine. You know, I was having a hard time just sitting and being with myself, let alone what do I do with all of these things? But I kept at it. I kept trying other things. I've tried yoga. I've tried Qigong and Tai Chi, and I've tried journaling and art journaling, and I've tried even laughter yoga to try and generate some happiness in life when it seems really dark. I have a big family. I haven't even told you. I totally skipped that whole part. I love it how stress happens. I was born and raised in the state of Washington. I'm from a blended family. I'm the last of 9 children. I grew up in the late 70s and 80s. So a lot of my family was into Star Wars and Star Trek. And with some of my siblings, we actually joke about I'm 9 of 9. All you Trekkies out there will get that. Other people will be like, what? But so I had the plaque treatment. And about a month after that, I was able to go back to work. At that time, I was doing construction. It was my job to do all of the fine details. So I did a lot of painting. I did a lot of caulking around the seams and the seals and the treating of the lumber that was going to go in and all of the stain work. And I don't know if you've ever tried to paint white walls with white trim. It's very difficult to do with both good set of eyes, but having one that had a little bit of depth perception problems, it became a real challenge. And it also became kind of fun in learning what my body had remembered, that muscle memory, building that new muscle memory of how do I find the lines? How do I pour water into a cup? I put my hands more towards the top and aim for the middle, as opposed to just willy-nilly pour it like I used to. So I was able to go back to work for a few months after, it was about a month and a half after surgery, and life was going pretty good. And I kind of fell away from some of my stress reducing activities and kind of just got busy with life and kind of got caught up in the hurry and make as much money as I can before this could go south. Well, in 2022, in January of 2020, my scans, Dr. Bhatia and I had a really heart-to-heart conversation in that they found tumors in my liver in January of 2020. And for those of you online who are not here in Seattle, you'll know that that was when the pandemic was really starting to hit here in Seattle. So as I'm going to all of these appointments to get prepared for, what's the next treatment we're going to do, I could see that the hospitals were starting to scale back. They were starting to rotate shifts so that they would have a backup of staff if staff got sick. So the hospitals all of a sudden went from being very, very busy to clamping down and even having security at the door. You had to have an appointment in order to even get in the doors. It was very disturbing to see. It was a very confronting moment in time. But we opted to go with immunoembolization was the first round of treatment that I went with. And I had a very poor reaction to anesthesia. I had a very poor reaction to the CT contrast, which I developed an allergy to the CT contrast through that appointment, which was, let me tell you, not my best day. Laying flat for 6 hours. We're also trying to throw up in a bedpan with my head tilted to the side. It was pretty rough. And I went in that day and my wife was going to be able to stay with me overnight, and came out of surgery and the policy for the hospital changed, and that was no longer the case. She had to go home. So I really was confronted with myself laying there. And I remember a moment where I had this washcloth. This was before we were even wearing masks, before we had even realized that it was spread through the respiratory system. And I had a washcloth on my face, and the nurse had just handed it to me. And I was like, okay, God, like if this is the time that I'm meant to go out, this is the time, but I'm really putting my faith and my trust in you to just kind of get me through this, to just protect me and get me back home safely so that I don't have two things to deal with now. And everything went well. I sure did enjoy rolling out of that hospital. We have lots of photos of me in the wheelchair going, get me the hell out of here. And I was not eager to sign up for another one of those. So Dr. Bhatia and I had some good conversation about switching to systemic treatment as opposed to liver directed. So he told me all of the odds of doing IPI and NIVO, which is not necessarily a very popular words to use in this community, but it was the shot that I was willing to give. And I was just determined that I was going to be in that small percentage of people that had a good reaction to that treatment. I stopped working. That was hard to do, especially after coming off of a high of trying to work as hard as I can as an independent contractor in the construction field, to all of a sudden stop and pass off my jobs and close down my jobs and hand those back off to my friend. I made it through 2 rounds of the combination, and things were going really, really good. And that second infusion just kind of stopped me in my tracks. I ended up with my thyroid going hyper and then going hypo within a week's time, which if you've ever had thyroid issues, it's kind of brutal. You get really lethargic. All you want to do is drink cold water. You are nauseous and you throw up, and it's pretty brutal. But what's really great about it is that you just take one little pill and everything balances right back out again, which I'm so grateful for, that little pill that I wake up at 5 a.m. every day to take. I also had a hepatitis that was caused by the immunotherapy, and we took what I lovingly refer to as the summer of steroids. And I got really busy in the yard, and I cleaned and prepped and repaired and then painted the back of the house that we were renting because it desperately needed it. I didn't want it to have another winter in the state that it was in. I do a lot of dancing. I listen to a lot of music. I really got interested in cooking and nutrition. I take a lot of nutrition classes. I just started really searching for the things that were going to help support me, adding more tools for my tool belt of life. I I had done some breathing techniques, but I realized when I was getting my liver biopsy, those techniques were not vast enough. So I started learning others to help, not necessarily the big, deep breathe in and hold and then let out for longer. I needed to develop some other ones that could help me for moments like that. An interesting thing happened while I was also going through treatment for Mets, and that my original tumor in my eye started to regrow again. And so Dr. Stacey and I were like, I was like, well, what the hell can we do for that? And he was like, well, we could do the laser treatment. We would do the hot laser treatment, I believe it was, in the office. And he said, we can also remove your eye. And he said, the third option is that we could just wait. He said, you're already doing treatment that treats the entire body. We could just wait and see. He said, and even if you want to remove your eye, since you already have Mets, there's not that big of a rush. We know that that ship has already sailed. So we can wait until the eye becomes uncomfortable or painful, and then look at having it removed at that time. And I don't know if it was my freeze or my fear, but I opted to wait. And in 6 months, when I went back in, not only was the tumor dead in my eye, but it was surrounded by a dead tissue. It looked like a golden halo of light that was shining around my tumor. And I was just like, well, this has got to be a good sign that things are starting to work, because all of my other scans of my liver, they just showed those tumors were still there. They hadn't grown, but they hadn't shrunk, but there was nothing else that was showing up. And it was all of a sudden, in October of 2021, that the scans came back. Dr. Bhatia was busy with another patient. He had one of his fellows in giving me the news. And the fellow said, well, you're Ned. And I was like, okay, hold on, back up. You're using words and terminology that I never expected to hear. So I need you to really kind of reread this and look at the images and look at the results. And there was absolutely no mention of the original tumors that we were treating through the liver directed and with the systemic treatment. They were just gone. I couldn't believe it. I actually made him go back and review everything, get back with the radiologist to review everything. And I was finally comforted, I think, after the next round of scans, when it was true, they really were gone. They were just not there anymore. So I still kind of am in a little bit of disbelief about that. Every time I go for scans, I'm like, they're really not there. There's still no mention of them. There's a few things that we're watching, some things that were there when we had the original scans, but nothing is growing, nothing is active at the moment. And I think a lot of that has to do with my tenacity to just look at all of the bad habits that I had, the things that weren't serving the health of my body. I was so addicted to being busy, and I was so addicted to that stress response. I actually loved that feeling, and I would channel that feeling of that anxiousness into effort and productivity. So I had to unpack all of that and figure out how to slow my life down, how to slow myself down, how to take really good care of myself, how to listen to the signals that my body was sending my brain, because I had learned really well how to shut those off. So I would push myself way too hard. It caused a lot of ruckus in my life because people had to start to learn how to see me and hear me from the new place that I was, this new being that I was, because I'm not the same. If you ask my family, they will tell you, you're so different. Why are you so different? Well, I have on my card here all the different things that I did. I've done gardening and hiking. I did nature bathing during the pandemic when I couldn't get out safely to walk. I've taken nutrition and cooking classes, doing lots of art. I tried doing watercolor painting. I've taken lots of watercolor painting classes. I'm not quite sure that I have the patience for that yet, but I keep trying. I like acrylics where they dry quick and you can push the paint around a little easier. I listen to a lot of music. One of the things that I did to stopped my mind from that repetitive pattern of worry and concern was I took up ukulele and taught myself how to play the ukulele, because there is no way my brain can concentrate on anything else other than what this hand is doing and what this hand needs to do. And how to do this without my peripheral, a lot of guitarists can use their peripheral vision to know where their fingers are on the fretboard. I didn't have that option. So it was great for getting me out of my head. It was a lot of fun. I told you about laughter yoga, which I wasn't quite sure about, and I feel really, really silly when I do it. The only thing that really gets me through that is the fact that everyone else is being just as silly as I am. I find that my nieces and nephews that are younger don't have a problem with that class. They actually really like it. I found support in other groups. Online, Recurrence site has some really great groups that they meet once a week. I found another group that meets once a week on Zoom so that I can meet with other people who are dealing with this and battling this. I also found a local group that has a women's support group. They also have a men's support group too. And they all have different types of cancer, but we all deal with the same fears. We all deal with the same struggles of how do you adapt to life through cancer? How do you get back to your normal life when you're at a place where you're not in treatments? How do you adapt to those sorts of things? And I find so much support and love in those groups. And it took the pressure off of my expectations for my family and friends to show up for me in ways that they didn't know how. They didn't have the skills. They haven't walked it themselves. I have no fault for them. I love them. I want them to be happy and I want our interactions to be good. So I sought other support groups. In the beginning, when I couldn't get into a therapist, SCCA, Fred Hutch, they also have chaplains. And so I met with a chaplain to just kind of be able to talk about my fears and my concerns with, and how do I handle and manage that? They were fantastic getting me through that interim period. Does anyone have any questions?
Before you close, I know that you wanted to mention palliative care and the huge impact that that's had on you as well.
Yeah, I've told Dr. Stacey and Dr. Bhatia, I think that that should be one of their first things that they do with their patients is get them in with palliative care. Palliative care is not hospice care. Palliative care is a team of people that are designed to help you in the midst of your cancer journeys, help you deal with, side effects and treatments, and to help you deal with your mental. Oftentimes, Kathy, my palliative care nurse, will ask for my wife and ask how she's doing and want to see her face and her voice, hear her voice as well to check in. So it's a very holistic type of care. I encourage anyone and everyone, if they have an opportunity to find a palliative team, do it. Don't wait. He's creeping closer to me, so I think I must be I must be running out of time. I hope that all of you out of this have a sense of hope that even in the darkest times, we can still find joy and we can still find light. We can still find those little sparkling miracles that happen in the daily, day-to-day stuff. They showed up for me in every stage. I just sometimes had to look a little harder to find who was being nice, who was going out of their way to make my level of care good, and just showing gratitude and love for these people who put themselves out there to walk with us through this terrible time, to try and help us find answers and to try and get us through it. I wish you all the best, and find me online. I'm around.
Thank you so much. I'd like to introduce our second patient speaker, Jack Odell.
Hi, my name's Jack Odell, and I was thrilled to get asked to speak today because, as you heard, it's one of the favorite parts of the conferences. Oh, I hope I can get through this. Not because I'm scared, not because my story's terrible, because I feel blessed. And that's just hard sometimes. Can I ask how many newly diagnosed people are here? Is that allowed? Within the first year? Thank you. Welcome to the tribe. If you see these people, ask them questions because I know they'll help you. We have to all learn to reach out and ask for help. And us old timers need to say yes. That's a lesson I've learned. How many of you were scared when you were first diagnosed? I certainly was, and I'm not the scary type. And when I get scared, I get quiet. And that bothers everybody. Like Nikki, I'm in construction. I was a licensed architect in Hawaii and Washington, and I had a staff of 11. And the last part of my career, I designed very nice houses. And I loved it. And I've been retired since '09. And Nikki, I'm still looking for projects every day. I need your help. I had an eye appointment in May 2013. I was 61 years old. I came in and registered, signed in, and I was told, oh, your doctor's retired. Well, I just made the appointment 2 weeks before. No one told me. So I have this brand new guy, and he turned out to be really nice. He was very forthright in telling me what he was doing and what that my eye was looking good. And we got done, and he said, it looks good. I think I'll see you in a year. And he left the room, and he said, please stay here. My nurse will come in with the final paperwork. And he left the room, and his hand stayed on the door jamb. And it didn't move. And I was in the chair. And all I could think was, this is really Hitchcockian. The guy is standing there holding onto the door jamb. Is he filing papers or calling the nurses? I had no idea. And then his head turned in, and he walked in slowly, and his shoulders were down, and he said, Jack, everything's not all right. I'm sorry. There's a shadow in your eye. And I don't know what it is. Do I have your permission to overdilate your eye? And I said, sure, please. So next time he looked in my eye, he said, you have a tumor in your eye. That's what the shadow is from. It's in the ciliary body, and it's right up front, so I couldn't see it. So he shined his light in, and he said, yeah, that was what was casting the shadow. He said, but don't worry, I've seen this before, and based on the size and color, I'm pretty sure it's benign. And I want to talk to my partners, so if you just sit here for a minute, I'll be back. So when he came back, he said, we want you to see a specialist, and you're scheduled to have an appointment next Monday at 9 o'clock. I said, I'll have to check my calendar. And I'll let you know if 9 works. And he said, Jack, I was hoping we wouldn't have to go there. Because I have to tell you, this could be life or death. So I was at the appointment. My husband, John, came with me. It was confirmed that it sure looked like melanoma. And we decided that we didn't like the doctor, and we wanted a second opinion. So John went to work researching. That's what he's good at. Lots of things he's good at. And he decided we wanted to see Dr. D'Amato. Well, Dr. D'Amato was in England. But days later, we found out he was actually in San Francisco. He'd been hired to take over the leadership of the Beekman Vision Center at UCSF. and rebuild it from the ground up to be a center of excellence for treatment of uveal melanoma. So I was the doctor's first patient. We flew down there, but before doing that, we got married. Because of what you went through. We're going out of state. We didn't know what to expect. And Dr. D'Amato, I met with him on July 8th, on Monday. He told me his instruments were on a ship. They hadn't arrived yet. And he wasn't quite yet the head of the department. But he inspected my eye and he said, we need to have a biopsy. And so the next day, he borrowed the outgoing lead's instruments. And we wound up in the Grand Theater operatory with all these cameras and people and balcony people looking and watching. I didn't care, I was out. And when I came to, Dr. D'Amato was patting my hand in the recovery. And I opened my eyes and he goes, Jack, do you know where you are? And I said, first thing, we're in a hospital. Where do you think we are? But we hit it off and he was my doctor for 3 years. He did a biopsy and the biopsy came back Castle class 2. So it was no longer benign. And he did a biopsy and sent it to Foundation 1 for genetic testing. And that came back about 2 weeks later. And I had 2 of the 3 genetic mutations that you heard about today. GNA 11, GNAQ, BAP1. I had BAP1 and GNA 11. And my GNA 11 has a variant of unknown significance at S326A. Well, as Nikki would say, what the hell does that mean? So John put a team together, starting with a not retired, he left the industry. He was a pharmaceutical laboratory researcher, cancer researcher, who wanted to go out on his own and work directly with cancer patients. And he happened to open a business in Seattle, and it's called cancernavigator.com. His name's Dr. Hartmut Stecker, PhD. And he worked with John to put my team together, and John added a naturopathic oncologist. And John wanted to know what prescription drugs prevented cancer, what supplements helped build my immune system. And so we had a double program going on, and actually we went the natural oncologist first, and he said, I met this great guy who's from pharmaceutical end at ASCO in Chicago. They had lunch and they decided they were going to work patients together. And so he referred us to Hartmut, and it's like the yin and the yang. And so that was my team, and I had Dr. D'Amato, and I went to MD Anderson for my first oncology. And that lasted about 3 years. But at MD Anderson, I was asked as a class 2, no mutation, if I wanted to be a part of an adjuvant off trial with vorinostat. And vorinostat, it's an HDAC inhibitor, and it fights BAP1. And I had BAP1, and I took that 600 milligrams every day for 2 weeks, and my platelets crashed to 25. So I was taken off the drug and had to clear out, and then I came back in at 200, and I was on it until just 4 months ago or so, 3 months ago. Dr. Bhatia and Dr. Stecker, for the last 2 years, have been talking to us about, I think it's time that we looked at taking you off that drug. You've been on it for 9 years. You've been on it for 9.5 years. But we finally decided to get off the drug. And I feel great. And if my scans are good in May, I'll be celebrating 10 years dancing with NED, my 10th anniversary. Thank you. So I moved my services back here. Dr. Stacey joined us, Dr. Bhatia joined us. It's my dream team. I don't want to poke the bear, but how many of you have had retinopathy or told you have retinopathy? I also did. And we're all different and all our mutations are different. And we're such a small population. It's going to be hard to find a cure, just a single cure. And what Dr. Scallett was talking about today, backing down the chain and looking for the most common connection that we can knock out, is absolutely correct. So my retinopathy started, we traveled a lot. I retired in 2009, I said, and we had booked a cruise and I was pretty stable. So we flew to Europe and to the port city and spent a night in the hotel. And the next morning we took the shuttle bus down to the ship. And when we were escorted to our cabin, the young porter, she said, "Welcome to your home away from home, gentlemen." And I walked in and we had a beautiful view of the water and a beautiful balcony and sliding glass doors. And a white curtain came down over my left eye. And I had a whiteout blindness. And it lasted for about 2 months. And eventually it cleared up and it went away. So I had that looked at by Dr. D'Amato. And we decided another trip much later after that. And we flew to South America and we went up to the wine country at 9,000 feet. So these are long flights. And 9,000 feet to 12,000, that's really high. I was fine. I spent the night in the hotel. We went to the wine country, came back down. I woke up and I was white out again, blind. I've had 4 of those. 2 of them lasted 3 months and 1 lasted 4 months. And 2 of them weren't clearing. So I saw Dr. Francis, who deals with that sort of thing, and he recommended a vitrectomy. Does anyone know what a vitrectomy is? Vitrectomy. In simple terms, they put 2 small holes in your sclera. You're out, you're under. And they insert very small instruments. My guess is it's a tube that has a light on the end, and the other instruments go down it, perhaps. But the tube can vacuum the contaminated vitreous fluid out, and it can refill it. It can have a little laser go down. It can have little forceps, little tweezers. But he said to me, I'd like to wake you up in the middle of this because I might have questions for you. Is that okay? And I said, sure. So in the middle of this surgery, I'm woken up and my head's in a block, so I can't move. And I see this swirling water, and he's saying, well, I'm in the process of draining your contaminated vitreal fluid. And then I see this little bar go by, and I'm seeing this in my eye. And it's the coolest thing. You would love it. And I saw what looked like a little spark. And then I saw the forceps dragging this tree limb across my eye. And I said, are you harvesting the blood vessels? And he said, yes, because I had asked him. I was told by Dr. Francis that I have new weak blood vessels growing at the base of my dead tumor and in my eye's drain, main drain. And he said, that's absolutely right. And that's why your eye isn't clearing, because it can't drain. So I got to watch this whole thing. It was absolutely great. The next morning I came in, he took the dressing off and I could see perfectly. So after proton beam and these episodes with going blind, and I was also told that my whiteouts were good news because my optic nerve still saw light. A blackout is not as good news. So I felt blessed for that. I just lost my train of thought. Where was I? Oh, yeah. But he told me after 2 vitrectomies, he told me that my eye was too weak. I'd never be able to have another surgery. So in October, John and I decided to celebrate our 70th birthdays and our 35th anniversary. And we flew to Tahiti and spent 2 weeks in the fun in the sun and the surf. And the second to the last day, I was snorkeling and I had my head in the water and it was just drift snorkeling and the water was only this deep. And I felt like the pressure was building up in my eye. And so I stood up and I popped the pressure in the corner like you do. And I felt an explosion in my head. And I called John over and he said, we need to go find a doctor. And so we were on a Moran and we had to take the ferry over the next day anyways to fly home at night. So we had the day and we saw the ophthalmologist there and his partner, and they told me that I torn my sclera and he could see into my eye and it was an open invitation to infection. So we flew home. I was loaded up with antibiotics and steroids. I saw Dr. Stacey the next morning who said, I think it's time the eye comes out, right? So he said, but I want first to continue on the antibiotics and the steroids. And I'll book a surgery for 2 weeks ahead. Well, a week from that date, I started having pain and the steroids were keeping me up buzzing around the house at night. And as we approached that date, he said, I'd like to stay on the antibiotics, so I'd like to push that date out another week. And I said, okay, could you push the date out and book another week to keep the first date? And as we got to the first date, I said, I just can't do it. I just can't do it. We have to take the first date. And so on November 7th, Dr. Stacey nucleated my eye. I went home. John fixed me a cocktail. It looked like a cocktail. He took a picture. It was a drink glass with ginger ale in it. And also in that time we were talking, do I need a plastic surgeon because my lower lid is drooping? Should we do the eye first and then tighten up the lower lid, or do we tighten up the lower lid and put this just was dragging on to me for it seemed. And Dr. Stacey said yes. So on November 7th, we went and he said to John, he didn't tell me at the time. I found out later a nucleation takes like 35 to 40 minutes. Mine took 2 hours and 45 minutes. My eye was so infected that 5 of the 6 muscles had self-detached from my eye. And Dr. Stacey had to go in and find the butt ends of the muscles and attach them to the new socket. And I saw an ocularist 2 months later, and they said, you have incredible movement for your muscles in your eye. I said, that's Dr. Stacey. But in the meantime, we were down in the desert and I joined the gym because I had 2 months. And I decided I was having trouble with balance. I don't have an eye here. And so I signed up for this class, Balance and Strength. And there were 35 people in it. And I went there early to tell the instructor, I just lost my eye. I'm having trouble with balance. So could you keep your eye on me? So he put me in the second row in the middle. And people came in They were almost all 80 years old and above. I'm now going to be 71. I was one of the kids. And we start doing exercises in the chair. Then he says, let's stand up and hold on to your chair on your left hand. And we start moving our legs slowly. And then he said the wrong thing. He said, if you feel like you can do it, you let go of your hand. Well, every time I hear that, of course I'm going to do it. And I let go of my hand, and I must have started gyroscoping because he said, one-eyed man, grab your chair. And I was still like this, and the music was still playing, but there was no other noise. Everybody had stopped in shock. And I had an eye patch on. They hadn't met me. And he had said, we have a new person here today. His name's Jack. And out of the corner came this woman's voice that said, Jack, my name's Sue. And if you need any help over, I'd like you to call me. Then there was Bill. There was Tommy. There was Joan. Everybody introduced themselves to me. And I've never had that feeling before. I have a lot that I was going to say, but I think that's a good.
I think that's
new, old and new alike. I think you need to know that people want to help us. And trust me, they don't know what their boundaries should be with us. I worked on 2 projects with Melody when I first joined Recurrence site. The first one I did a training for newly diagnosed patients, and I was going 100 miles an hour, and I did an Excel sheet, and it was 6 feet tall and 3 feet wide, and it had about 12 columns. And you started at the top, and if you had this diagnosis and you chose this treatment, and it was pretty easy. It was just big. And Melody said, why don't we start a little smaller? And we really need to have a brochure for new patients. So we came up with this brochure. It was the final product. And one of the most important parts of this is the list of resources and connections on Facebook, our group, other groups. It's all about connection. And this has gone international now. We have translated in 5 languages. The 6th language, Greek, is being proofread. We didn't have any volunteers, but that'll happen shortly. The other thing is people want to help you. I said that. I designed a 6-fold invitation to fund. And this is 2 years ago. Together, let's focus on a cure. This is a year-end project that features patient stories, comparison of cancer diagnoses. There's 279,100 new breast cancer, 228,820 lung cancer. There's at the most 2,500 new uveal melanoma patients. And I used to have a statement in there that says, the pharmaceuticals won't give us a minute of their time. There's just no profit in spending money to save 2,500 people. So your friends will help. So every year end, we make a call out. We have these printed. We have envelopes. We can do the mailing. Last year I wasn't up. I always write a freehand note to my friends and family and put it inside. There's a return envelope. There's a donation card, and it goes to a Recurrence site for patient programs and research. Now, I was on the board for 4 to 5 years with Melody. I worked very closely, and I told her I'm really just tired. And she didn't want to lose me. And she said, well, what do you want to do? And I said, I like this research, that we started funding research. And she said, well, just name your title. Say, I'm the director of melanoma, uveal melanoma research for Recurrence site. And we vet, we're on our 3rd or 4th John and I fund in combination often with the Current site, and now the Current site has had enough funding that we're going to be issuing our first solo, well, for me, first solo research project. But what I learned is this. The institutes and the hospitals with research arms, I read their contracts, and I wrote my own architectural contracts so they were equitably between a homeowner and the contractor. That's how a contract's supposed to work. These weren't equitable, and the institutes wanted 50 to 80% of the cost of the research. And I got on the phone and I got the head guy and I said, this is ridiculous. We're an orphan cancer. We only have 2,500 people. And with this, we're giving you 100,000 just to kick the project off. You need to work with us. Otherwise, I have 2 other labs that want our money. Twice in a row, we got no overhead. The other thing, I wrote the contracts with milestone dates. The other contracts that we had been involved with, there were no milestone dates. So we divided into 3 or 4 payments, and when the payments due, they write a report, a very simple report, not peer-to-peer scientific. I review it, I send it to Dr. Hartman Stecker. He reviews it scientifically, gets on the phone with the lab. He certifies the payment, or he asks questions, or what is his style is he works with the laboratory to get them back on track. And then they rewrite where they are and where they're going. And he writes a stipulation and I make payment. So then we go to the next payment and the next payment. And at the end, they need to write a publishable report so that we have proof that this is research that's done, and I want people to share it. And I want the failed reports to be published too. I want people to know this report failed and we might be able to do this instead and it might be successful, or we don't want to go over here. So that's it in a nutshell.
Well, I'm feeling very inspired. I don't know about everyone else's, but this was really a wonderful way to end the program. A few closing comments, and then I know we're a little bit later, but hopefully we're not too bad. I want to really thank Ritu and the team. This really would not have happened without Ritu. She's been playing this for at least the last 9 months, probably a year actually. So this is not, today's the culmination of a ton of effort on her part, and it really wouldn't have happened without her. So we're really fortunate to have worked with her to put this on, and the rest of her team. Fred Hutch supported the event. We're in the Fred Hutch building. We all had lunch, so big thanks to the Cancer Center. I want to suggest everyone fill out the post-program surveys. We're going to do this again, and we want to make it better. And the best people to tell us what we can do better and what you want to hear about next time are you. So we take the feedback from the event and design the next agenda based upon things you liked, things that you didn't like, or topics that you want that weren't shown this year. So we really take that seriously, and I encourage you to fill that out. It helps us improve, and we actually almost like to know what we didn't do as well as we like to know what we did do well. I'd like to thank everyone who presented and our patient stories. I think that's really what brought us all here today, and I found it very moving. And all of you for attending in person and online. This is why we have the event, and we're looking forward to doing it again. So thank you all.